Good morning and welcome everyone to this meeting on CardioCon. This time, this is the consecutive fifth year. Good to be back in a person meeting again. Last two editions we had to go online because of COVID. I have very distinct memories of some of the international faculty, including Dr. Kelkar, who's here. He was there even for the first meeting, and we've been blessed and been growing with your blessings all these years in terms of science. And it's always a pleasure that we were associated with APA from the first meeting itself, and so has been the association with Sal Hospital. So big round of applause for both of them, APA as well as Sal Hospital, for being a support for us. So as I always say, that knowledge is one that precious wealth that can neither be stolen, nor be inherited, nor be divided, nor be snatched by the king. It's a shloka in Sanskrita which says, Na Rajharyam, na Bharatbharyam, na Bharatbhajyam, na cha Bharatchari, which means it's neither has weight, nor it can be snatched by the king or by the rulers, nor it can be stolen. But it's one that wealth that grows as you share it with others. So knowledge is that one wealth that we intend to share with all of you, and that's why CardioCon each year devises it in a format of debates to keep it interesting. And medical science, as I say, is not a science like mathematics. You don't have 1 plus 1 always 2. You'll always have two sides of a coin. And those cases, that's the reason why, even if you will have AI coming into medical science, personalized medicine would have to go through a human brain. Because for that distinction to come in, your human application of knowledge and where to apply what will always change the line of treatment. Whether you have two similar patients, two clones being treated for same disorder, may not end up receiving the same treatment. And that's the concept of medical sciences. So I invite you all to the inaugural function here. And for this presentation on inauguration conduction, I invite my better half and part of organizing team, my wife, Dr. Neha Sharma, to conduct the inaugural function. Dr. Neha.
Hello. It's not just the destination that alone matters, but it's the journey that actually matters, and it shows it's very important sometimes. Very good morning to all the dignitaries, esteemed, and faculties. I'm Dr. Neha Sharma. I am the member of the committee, organizing committee of CardioCon 2023. I welcome you all to the inauguration ceremony. Now, I'll invite, first of all, let me invite Dr. Kamal Sharma, Chairman of Scientific Committee of CardioCon, to welcome Dr. Anil Kulshresht, who is the President of APA. I request Dr. Anil Kulshresht, President APA, to felicitate Dr. Neha Shah, Director Sal Hospital. Next, I request Dr. Mukesh Ladda to felicitate Dr. Jitendra Anand, Vice President APA. I request Dr. Kalpesh Hansora to felicitate Akshat Shah, Managing Director, Sal Hospital. Okay, Akshat sir is not available, so yeah. Mr. Abdul Qadari is collecting on his behalf. Now I request Dr. Jignesh Patel to felicitate Dr. Apur Parekh, Secretary APA. So Apur Bhai is not there, so Dr. Jayesh Trivedi will be taking on his behalf. Now I request Dr. Prashant Vazirani to felicitate Mukesh Bhai, coordinator, APA. May I request all the dignitaries to light the lamp, followed by Saraswati Vandan.
Dr. Kelkar, please join us for lamp lighting. Ajay bhai.
Yeah. Now I invite Dr. Kamal Sharma to give the welcome speech.
Thank you very much, dignitaries, for honoring us. Uh, so I welcome you all to CardioCon. I think I've already given you the background of the conference, and I've already mentioned what we intend to do is to make science reach each and everyone in an interesting format of debates. Lot of times, lot of industry people do approach us and tell us कि sir हमारा एक वो talk रखना है, and I tell them unless I can create a debate around it, I'll not keep the talk. And that's why you can see all the talks that we have kept are only based in the format that would subscribe to the science, not otherwise. And it's a pleasure that we have APA on board always for the last 4 years for this conference. And so has been SAL, which has been our patron all throughout for supporting the program and science all throughout. So thank you very much, and I welcome you all for the conference. I would request now Dr. Anil Kulshresht to say a few words on behalf of APA.
Thank you, Dr. Kamal Bhai. APA has been lucky to be associated with Dr. Kamal Sharma team. This is fifth edition of Cardiacon, and it is growing by leaps and bounds. Really, it gives me immense pleasure that every year he finds such a nice topics to debate on, because routine topics are people are tired of. They don't want to study theory. They want to learn something in form of debate, pro and cons. So this conference gives this advantage. So on behalf of APA, I welcome you all, and I would also like to thank Dr. Kamal Sharma and his team for putting us such a nice program. Thank you very much. And now we would like to felicitate Dr. Kamal Sharma on behalf of Association of Physicians of Ahmedabad, I will request APA team to come on the dais. Those who are present, they can join us on the dais. Sir Kamal bhai, please.
So, as the inauguration function comes to an end, can we have the inauguration end with the national anthem? And I request all of you to stand up for national anthem. Thank you very much.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तब शुभ नामे गावे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you very much. So, being on time is an appropriate behavior and culture that we all need to inculcate, because cardiology is a branch that if you are not in time, you have had it. So, I think we are ahead of time in terms that we still have 5 minutes before the first bout begins. But I would spend that time utilizing an introduction of our speakers and the topic. And for the sessions to be conducted, I have Dr. Jayesh Trivedi with me, who will be comparing and hosting the session in Hall A. Hall A, he will be assisted in the morning session by Dr. Jignesh and Dr. Prashant. And Hall B, which starts the intervention hall, which is on second floor, where you have the Grunzik Hall, where we are discussing interventional cases pure for hardcore cardiology. The first session starts at 11 o'clock, will be managed by Dr. Mukesh and Dr. Kalpesh. So over to Dr. Jayesh Bhai.
Good morning to all of you. We are very happy that again we are meeting in physical form, because we have been conducting 2-3 years COVID guideline follow. We followed that COVID guideline. We could not meet, but this time we are so lucky that our vaccination has acted very well. On the outset, first I would like to congratulate Dr. Kamal Sharma, because he is the one who started Cardiocon 5 years back. And yes, he needs a very big round of applause. And we have been conducting this program, such kind of debates, only in Ahmedabad. I have never seen anywhere where people are contradicting the other speaker, and then they come out with a scientific on the basis of the scientific background. They prove themselves that their suggestions were correct. So it is such a wonderful, and then physicians get a home carrying message, where they deliver everything in a proper way and put things in such a way that we know what we have to do, and we know that what we don't have to do. So such kind of facilities, medical facilities, are being provided only by Cardiocon, and we are thankful as a part of Association of Physicians of Ahmedabad to upgrade our knowledge, Kamal bhai, we are really thankful to you. And we are thankful to all those delegates and participants, the speakers, faculties who have come from distant places, and they supported us and they encourage us to carry out such activities in future as well. And we promise you on behalf of Association of Physicians with Anil bhai and Jitendra that we will be continuing with you till we'll survive. So now, without wasting time, as he suggested, indigo jaisa hai apna, to reach in time is always a virtue, you know. So we would like to start our first session, bout number 12, on atrial fibrillation, for which I would like to invite Dr. K.K. Goyal sir, Dr. Gaurav Gandhi, and Dr. Kamal Jeet sir. Kamal sir, please sir. They will be chairing the session. And Dr. Jitendra Patel, Dr. Jitendra Anand, Dr. Devang, and Dr. Ronak Shah, they will be co-chairing.
Dr. Keval has an emergency. He's from my institute, so
So you can take
he's
over.
not
it,
here,
sir.
so I'm here.
You can
Yeah.
start.
So we have a case of atrial fibrillation. And where do different NOACs stand? Because you have so many choices now with a lot of brands and a lot of generics as well in market. 78-year-old hypertensive, female, weight 55, history of persistent AFib with fast ventricular rate of 100 beats per minute, with ejection fraction of 30% on echocardiography, without past history of any embolic phenomena, with CHATS-VASc of 5 and annual anticipated rate, stroke rate of 4%, mortality rate predicted of 5%, without anticoagulation by Garfield AF score. This all is included so that you know what are the different methodology of scoring a patient's risk by various scores in the data sciences, and has got Hasbled score of 2, had normal coronary angiogram, and apart from standard medical care, including the rate or rhythm control, optimal anticoagulation strategy would be. I request the other chairpersons to introduce our speakers.
So there are three topics and three drugs. So all the three drugs will be discussed by our field speakers. First of all, I would like to invite Dr. Tushar Bhatti, who will speak in favor of diabetes.
Dr. Tushar Bhatti from Rajkot, is an interventional cardiologist from Yashoda Hospital, Hyderabad. He's done and he's practicing right now at Vocal Super Specialty.
Pointer.
He'll be speaking on dabigatran as a NOAC. Is the new cost-effective strategy. Cost-effective in the sense because we all think that the generics have changed the game. But does it hold the game? That's the point, because that's cheaper. But does it? So he's going to pitch in with that for the scenario.
Good morning, everyone. We will start the session of atrial fibrillation and use of NOACs in atrial fibrillation. First of all, I would like to thank Cardiocon team and Dr. Kamal Sharma sir for inviting me for this opportunity. And we all know whenever any academic is there, sir's name is always there first. So let us start today's session. So sir has already described the case scenario. 78-year female, hypertensive, AF with fast ventricular rate, LV ejection fraction is 30%, and CHETS2 score is 5, Hasbled score is 2, and normal CAG. So I will discuss about the dabigatran. Why dabigatran is the better choice for this patient. So first of all, we will see this atrial fibrillation is the most common sustained cardiac arrhythmia, and it is seen in 1 to 2% of the general population. Major risk for this atrial fibrillation is ischemic stroke and systemic thromboembolism. AF is responsible for 15% of the ischemic stroke cases among the all age groups, and this rate increased up to 30% in people older than 80 years of age. So why dabigatran? dabigatran is reversible, potent, competitive direct thrombin inhibitor, and unlike heparin, which can only bind free thrombin, while dabigatran is capable of binding, inhibiting both free and clot-bound thrombin. So we all know dabigatran is direct thrombin inhibitor. Dosing is 110 mg BD and 150 mg BD. Elimination by 80% of renal excretion. It is a prodrug and half-life of 12 to 17 hours. So this is the first study, the RELY study, which we all know, that is the randomized evaluation of long-term anticoagulation therapy, which was done between dabigatran versus warfarin. And this study was published in renowned Journal of New England Medical Journal on September 2009. And result of this study was, we can see there is a primary outcome in which dabigatran 110 mg is non-inferior to warfarin group, whereas dabigatran 150 mg is superior than the warfarin group of people. So this is the brief about RELY trial. And in RELY trial, in inclusion criteria, we can see our patient is matching, like age is more than 75, LV ejection fraction is less than 40%, and she is having hypertension also. This was the exclusion criteria in which they took excluded the severe valvular heart disease, stroke, any condition which increases the risk of hemorrhage, creatinine clearance less than 30, liver disease, and pregnancy. And they did follow-up of 2 years. And the primary endpoint was stroke and systemic embolism, and primary safety endpoint of major bleeding. And secondary endpoint of stroke, PE, hospitalization, vascular death, and all-cause mortality. So in this study, they studied and they get the conclusion of 150 mg dabigatran significantly lower the rate of stroke and embolism, and it has similar rate of major bleeding compared to warfarin group. And in dabigatran 110 mg dose, there is a similar rate of stroke and embolism and lower rate of major bleeding. So in both doses, they are significantly reduces the risk of intracranial hemorrhage. And there is a little bit increased risk of GI bleed was there, and dyspepsia was the most common side effect observed in this study. The safety outcome, if we see, dabigatran of 110 mg versus warfarin and dabigatran of 150 mg versus warfarin, we can see there is a significant reduction in the non-life-threatening and life-threatening bleeding, minor bleeding, and definitely significant reduction in the intracranial bleeding, which is seen in both dabigatran 110 mg as well as in the dabigatran 150 mg of dose. This is the another data they took from the cumulative hazard ratio for the primary outcome of stroke versus systemic embolism, in which they got the conclusion that dabigatran 150 mg is definitely better drug than warfarin, and it is a superior drug in getting the primary outcome. So we'll discuss about some trials comparing NOAC in recent data. Actually, there is no randomized trial comparing different direct oral anticoagulant in non-valvular AF, but some observational studies showing some conflict results. So this is the first meta-analysis was done between the rivaroxaban and dabigatran group, and this pooled hazard ratio for the primary as well as secondary outcome. And here, in conclusion, we can see the rivaroxaban is associated with higher risk of stroke and bleeding compared with dabigatran. So according to that meta-analysis, dabigatran is better drug compared to rivaroxaban. In this meta-analysis, again they studied the apixaban and dabigatran, and they took the pooled hazard ratio of primary as well as in secondary outcome. And conclusion of this outcome was apixaban is associated with similar risk of stroke and bleeding compared with dabigatran. So dabigatran is equally safe drug as compared to apixaban. This is one more study published, and this is the Nexus study. That is the main aim of that study was safety, effectiveness, mortality of apixaban with vitamin K antagonist, rivaroxaban, and dabigatran in oral anticoagulation in non-valvular AF. This is the observational study, and they took the outcome was safety in the form of major bleeding events leading to hospitalization, and effectiveness of drug in the form of stroke and systemic thromboembolic events. So this is the cumulative incidence curve for the safety of apixaban versus dabigatran. And the result was apixaban was associated with similar safety to dabigatran. This is another cumulative incidence curve for the effectiveness for apixaban and dabigatran. And here they can got the conclusion that apixaban was associated with similar effectiveness to dabigatran. So here apixaban and dabigatran both are similar drug in the concern of safety and efficacy. This is one more study which aim to compare the risk of stroke and systemic embolism and major bleeding in patient with atrial fibrillation using dabigatran, rivaroxaban and apixaban. So if we concern the stroke and systemic thromboembolism, dabigatran was associated with superior effectiveness compared to rivaroxaban. And in the form of major bleeding, if we see the safety, again dabigatran was associated with superior safety compared with rivaroxaban. So in this study, we can clearly correlate dabigatran is definitely a better drug than rivaroxaban. This is one more study done to compare the safety and effectiveness of dabigatran versus rivaroxaban and apixaban. And they took two groups, dabigatran versus rivaroxaban and dabigatran versus apixaban. In dabigatran versus rivaroxaban, they studied the first stroke and major bleeding event, and conclusion was dabigatran was associated with significantly lower major bleeding risk versus rivaroxaban, and there is no difference in stroke risk. For dabigatran versus apixaban, the sample size was limited, so they could not draw any definitive conclusion. This is another Aristophanes study which did studies of effectiveness of safety of oral anticoagulation. And according to this study, apixaban and dabigatran were associated with lower rate of major bleeding compared with warfarin. And dabigatran was associated with lower rate of major bleeding compared with rivaroxaban and similar rate of stroke or systemic thromboembolism. And here rivaroxaban was associated with higher rate of major bleeding compared with warfarin. So summary of the major trial for NOACs in stroke prevention in atrial fibrillation. This is the major trial for all these NOACs. Like for dabigatran relay study, which results was high dose was superior and low dose was non-inferior to warfarin. Whereas in rivaroxaban Rocket AF trial, again rivaroxaban is non-inferior to vitamin K antagonist. In Aristotle trial, apixaban was non-inferior to vitamin K antagonist, but superior safety than vitamin K antagonist. And for edoxaban, Engage AF trial showing non-inferiority than vitamin K antagonist. One another study was done for seeing the discontinuation risk comparison among the newly anticoagulate AF patient. In this study, they have observed there is a significant lower risk of discontinuation compared to NOAC with all these newer oral anticoagulation drug. There is some drug interaction of dabigatran we have to take care, like with P-glycoprotein inhibitor as well as inducers. So these are the list of drugs. I will not go in details, but these are the list of drugs which we have to check carefully whenever we are using dabigatran. And these are some drug interaction with potential for increasing the bleeding risk when we are using dabigatran. So obviously aspirin, clopidogrel, NSAIDs, SSRIs, SNRIs, and we are not recommending to use concomitant use of unfractionated heparin and low molecular weight heparin. Okay. So this is the just shifting. Idarizumab is an antidote for dabigatran, and what the guideline, as we all know, the guideline of AF and use of oral anticoagulation. These are the guidelines. And so which NOAC to choose? Here is the table. We can see which NOAC we have to choose. So this is the summary, and dabigatran is obviously cost effective. So this is the finally why dabigatran is better choice for this type of patient, because it is superior and other NOACs is non-inferior. It is also reducing ischemic and unspecified stroke, and it is better than vitamin K antagonist and equal in safety profile with apixaban, and it is always cost effective than other NOACs. Thank you.
Thank you to Dr. Tushar Bhatti for speak on the given topic. And we'll keep a question answer in the panel discussion at the end of all the three talk. So I would like to call upon the next speaker, Dr. Ajay Naik. He will going to speak on the rivaroxaban as a NOAC is the most suited therapy in this patient. So Dr. Ajay Naik doesn't need much introduction. He's a very well-known electrophysiologist specialist and cardiologist in Ahmedabad. And he's working as an interventional cardiologist and cardiac electrophysiologist in same hospitals. And he has an experience of more than 25 years. So over to you, sir.
Privileged to be here in this fantastic conference. Thank you, Dr. Kamal Sharma. This is a very cleverly worded debate. You've put it as cost effectiveness for dabigatran and most suited for rivaroxaban and safety for apixaban. So it's a cleverly placed debate. Now, cost effectiveness issue is very much gone in the current era with all the generics around. So that is, we'll keep it apart. But for this particular case, 78-year-old lady, hypertensive, atrial fibrillation, EF of 30%, body weight of 55. We've said the CHA2DS2-VASc score is 5 if we consider EF 30% as heart failure, and Hasbled score is 2. Now, what I'm going to say is rivaroxaban is probably the most suited therapy for this patient. What are we worried about? We are in this subset. We are worried about bleeding as a major issue that we want to mitigate. Stroke we want to reduce, and cardiovascular mortality, if we can reduce that, would be great. For this subset of patients, the older patients, as age increases, chances of atrial fibrillation increases, and these patients will experience more stroke. So more than 75 years of age, the risk of stroke is almost 2.32 when you compare it to less than 65 years of age. And when we talk about the number of patients, elderly patients who have been studied in the trial, probably the largest number of patients were in the rivaroxaban and Rocket-AF. So when you look at the elderly patients in pivotal trial, almost 44% in Rocket-AF were more than 75 years of age. So that is just like our patients. And the overall CHA2DS2 score, remember our CHA2DS2-VASc score is 5 for this patient. Rocket-AF has studied the patients with the highest risk. So here the CHA2DS2 score was 3.5, and specifically for patients more than 75 years of age, CHA2DS2 score 3.7 in Rocket-AF. Compared to that, in the other trials, it was much lesser. If you again look at the older patients in these pivotal trials, mean age 79, mean CHA2DS2 score 3.7, we are talking about 44% patients being represented in Rocket-AF. So that is probably almost similar to our patients. Almost half of the patients enrolled in the Rocket-AF trial were elderly, and it mimics what this patient had. Age more than 75, hypertensive, and for the heart failure. So very much mimics the kind of patients we have. Our patient is fairly representative. Problem with older patients is we are always thinking about bleeding. What if they bleed? So many of these patients will not receive anticoagulation. In fact, this was an observational study of around 25,000 patients. When you talk about patients who are more than 75 years of age, almost 27% did not receive any kind of anticoagulation. And this is US, that fear of bleeding, we do not treat these patients with appropriate dose. So 1 in 10 patients, here we are talking about US, 1 in 10 patients in US of NVAR treated with NOAC receive inappropriately lower dose. In India, it's going to be much larger proportion of patients who are getting inappropriately lower dose. Problem with inappropriately lower dose NOAC is it increases the risk of stroke. So patients of AF, if they are not adequately protected from stroke, if they are not protected, prescribe the right NOAC dose. What are the risk factors? Atrial enlargement, large LA is a big risk factor. The second big risk factor is off-label low NOAC dose or inappropriate lowering of dosage, which is used. Now you are very well aware what I am pertaining to when I am talking about this. And there are other risk factors. When we talk about older patients receiving NOAC, the potential underdosing is very high in apixaban because right in the beginning there were 2 dosages available. So people try to mitigate the risk of bleeding by using the lower dose, but it was inappropriately reduced dose. Whereas for dabigatran and rivaroxaban, it was not that. And that resulted in higher risk of stroke with dabigatran with the other two drugs. So if the dose is inappropriate, whether it's inappropriately low or high or any inappropriate dose, it is the outcomes are not all that good for the patient. Our patients would not require NOAC dose reduction for older age alone, except for dabigatran. Since this patient is 78-year-old, at age 75 to 80 with individualized bleeding risk, if you think, then the dabigatran dose would need to be reduced. But otherwise, apixaban or rivaroxaban, we don't really need to reduce the dose for this patient. This is very stark. Protection from stroke in older patients is maintained even with reduced dose rivaroxaban. So this was 20,000 odd patients, more than 80 years of age with non-valvular AF, and look at the outcomes. Rivaroxaban 15 milligram OD versus warfarin, whether it's when you talk about stroke or systemic embolism, it's clearly to the left side of the line of unity. Whereas with the other drugs, it is overlapping. So rivaroxaban was much better than warfarin. Protection means effective prevention of stroke. Here again, older patients, stroke and systemic embolism, when you are comparing rivaroxaban with warfarin, the stroke and systemic embolism is much less with rivaroxaban compared to with warfarin. And even older patients, net clinical benefit of rivaroxaban versus warfarin greater in older patients compared with younger patients. So here you are talking about more than 75 years of age, events avoided. It is much more prominent in older patients. So older patients need anticoagulation. They benefit much more with anticoagulation. So it is important that in order to mitigate the risk of bleeding, you don't take them off anticoagulation, but you have to give them and monitor them better. Also, the risk of major bleeding, intracerebral hemorrhage was much lesser with rivaroxaban when compared to warfarin, and that is true for virtually all the NOACs. Our patient, 78-year-old with similar score, CHADS-VASc of 5, mean Hazlitt of 2. Here this was a SAPHIR AC study of around 2,000 patients. Major bleeding, intracerebral hemorrhage, all to the left side of unity. So it showed the safety of the drug in terms of reduction of bleeding. And older patients, again, more than 80 years of age. Here we are again talking about major bleeding, intracerebral hemorrhage, all to the left side of the line of unity. This was, rivaroxaban was much safer than compared to warfarin. With bleeding in GI or total mortality, ischemic stroke, it was non-inferior to warfarin. Adverse event rates and mortality remain low in older patients treated with rivaroxaban compared to routine clinical practice, and that is also seen in this study. So we have prefer in AF and prefer in AF prolongation registry in patients with AF more than 75 years of age. Protection for elderly patients with AF is both in terms of efficacy and safety. Here we are looking at all these three drugs, rivaroxaban, dabigatran, and apixaban versus vitamin K antagonist. Again, rivaroxaban is the only drug which clearly falls on the left side of the line of unity. So rivaroxaban clearly superior to warfarin here, whereas the other two, it was non-inferior. So for our patient, what does it mean? We need to individualize therapy for this patient, find the best drug possible for this patient. And it's not like pathar ki lakir that once you've given a drug, forever, the rest of the life it is going to be like that. You may need to periodically revisit what is happening to her, whether the creatinine is bumping up, whether you need to change the dose, whether you need to shift the patient from one drug to other. We need to individualize therapy and do whatever is best for the patient. This patient, we need to carefully consider her age, frailty, that is an important thing. We have to think of frailty index. It should come into our practice again. And comorbidity when selecting an anticoagulant and its dose. Overall protection of patients with complex comorbidities like this patient, in the real world setting, probably we have a great amount of data with rivaroxaban compared to others. Thank you very much. I'll stop.
Thank you, Dr. Ajay, for giving excellent talk. And now over to the Ajay, please on to that. We have a third speaker, Dr. Prafula Kerkar, and he is going to speak. Dr. Prafula is MD-DM cardiologist, consultant interventional cardiologist at Asian Heart Institute, Mumbai, and he has been guideline committee conveners for Cardiology Society of India and have several hundred publications and presentation at international forum. And he is going to speak on the apixaban is the safest NOAC in this scenario. So over to you, sir.
Thank you for the kind introduction, and thank you, Kamal. It's a pleasure, always pleasure and privilege to be here. Last 5 years that I've been participating in this meeting. Well, Ajay has made my job very simple. You guys have already read the case. I have also highlighted all that we're going to talk upon, and I'm going to try and show you how does this advance. Okay. Yeah. Okay. I'm going to show you that apixaban is not only the safest, as also very effective in this complex. Why isn't it advanced? Shall I go there? Gatabandhan udhar karna hai kya? Next, I've been taking the page. Thanks. Yeah, so I'm going to show you that it is not only the safest but also effective in this very elderly, frail, low body weight person who does not have coronary artery disease and of course does not have renal function CKD. That is on the basis that the Hasbled is 2 and the CHATS2 ask is of course very high. So you need safety, all right, but the only two Hasbled score points are hypertension and age, and there is no abnormal renal function here, right? By the way, I'm going to not indulge in homeopathy like what he said. The whole world does. This is a very strong message that here you will use a 5 milligram BID dose. How do you decide the dose? As it was in the Aristotle trial, 2 out of 3 ABC criteria, you would go for the lower dose. Here, to have safety as well as effectiveness, you're going to use a high dose because there is just one body weight which is lower. Now let us look at Aristotle trial here itself. Yeah, the usual inclusion criteria, randomized trial, and what is it? Comparison with warfarin in a therapeutic range. That's important. Which cleverly our man hid it from you. That is, Ajay hid it from you. And the mean CHATS2 score, there was a good 30% patients which fit our population out here. And the TTR 62%. And look at this. Somehow Tushar Bhai tried to confuse you by saying that I'm trying to tell you that apixaban compared to warfarin is superior in terms of the primary efficacy endpoint, in terms of preventing stroke and systemic embolism, as also superior in terms of preventing major bleeding. 21% relative risk reduction there and 31% relative risk reduction here. And importantly, at this dose, it is preventing mortality, the hardest endpoint too, though it was a secondary endpoint here. So, as far as this is concerned, and that same consistent effect, you go by age, it is still retained, and you see the point estimate to the left. वो नहीं चलेगा, इधर चलेगा. हाँ, so see the point estimate, the same, yeah, for major bleeding as well as efficacy. You see in the elderly, point estimates go, there is superiority here, even for both these endpoints. And that consistent effect, our patient is on the verge of 80, 78, still maintained in the 13% of the population in Aristotle trial. As also, look at the dose wise. If you go by the dose criteria that I told you, the low dose, our patient deserves a high dose, but even in the Aristotle trial, for the low dose, the point estimates are favorable. That's what I'm, no p-value for interaction, not significant, as efficacious in a low dose. And this is what Ajay Bhai hit from you. Look at the comparator arm in rivaroxaban trials out there. The TTR is the lowest of all the things, 55% time spent in the therapeutic range, whereas with Aristotle, it is 62.2%. So that is what we are comparing here. We have to compare apples and oranges. But head-to-head comparisons we can't do amongst trials, and that's what is a disclaimer in red that I give you right at the beginning. And the common USP for all the three agents used in the right dose would be decreasing intracranial hemorrhage. So the vertical bars, all three are better than warfarin. We are comparing with warfarin. But the nice endpoints that Ajay showed you, across the board, whatever the dose be, better with apixaban. And also, he told you a large chunk of the population. Here, look at the age more than 75. Actually, by numbers, you see Aristotle, by far the largest. It was 18,000 plus patients. So the percentages, don't go by percentages. Look at the absolute numbers. Age more than 75 in the third row out there, in the third column out there, 5,678. The absolute numbers more. And then in the elderly, again, look at the Aristotle trial itself. And what do you find? And all the four trials. Again, the point estimates, you look here, favorable for efficacy, as also favorable for bleeding. And look at the dabigatran, which was favorable for stroke prevention. For bleeding, you just can't use that 150 milligram dose. It is actually will cause more bleeding. And that is the same thing in a meta-analysis, age-wise meta-analysis of individual DOACs compared to warfarin. What do you see? Apixaban point estimates for stroke efficacy shown in the yellow, as well as, sorry, shown in the blue, as well as shown in the red, everywhere, across the thing. Major bleeding, stroke embolism, and intracranial hemorrhage, everywhere the superiority is what you see. Now look at this. Now, group of experts from Europe, including Gregory Lipp, the biggest guy who gave the guidelines how to use NOACs. Now, Hans Dieter, the first author, they are trying to tell you how to choose a particular agent. And what is the expert recommendation? I am no expert out here. Expert recommendation for an elderly population more than 75 years age, first choice, apixaban, 5 milligram twice daily, right? And again, the international consensus validation of the FORTA label. What is the FORTA label out here? FORTA is fit for the aged classification. And where do you see apixaban stands? At class of evidence, the level of recommendation A. On the basis of evidence they come out with. And apixaban is indispensable for the elderly. Indispensable. Yes, all the other three molecules are also shown. Dabigatran with an asterisk to go on your lower dose there, and that's what it is. So having said that, let us look at the real world. Now it is always, I will always twist and tell you what is good in the real world, because real world data is all observational studies. You got to look at the disclosures of the guys who are doing these studies, and but yet there is the same Aristophan study that Dr. Tushar Bhai alluded to. And if you look at in that same study, in the older population, apixaban, and this is a large study, mind you, it's about 2 lakh people, and out of these 88,000 odd patients are more than 75 years of age. And what do you see there? You see that apixaban versus dabigatran, you see that stroke systolic embolism is higher, 32%, and major bleeding, risk reduction is 32% with apixaban versus dabigatran, and major bleeding reduction 26%. And also against rivaroxaban, you find the same efficacy out here. Stroke and systemic embolism down by 23%, and major bleeding down by 47%. So also this other observational study, again all these are from database of US Medicare. And what have they done? They have just tried to look at the real close competition, that is rivaroxaban. And rivaroxaban versus dabigatran, the patient numbers here in that database, 5,81,000. And they first looked at the standard dose and look at the major ischemic stroke hemorrhagic event. And you find that rivaroxaban is associated with a 13% higher risk compared to apixaban in this large database. Then you look at the low dose of rivaroxaban, reduced dose, and a good 23% of patients in both arms were on low dose. The low dose given according to the correct way, right? And in the real world, in the Medicare database of 1,34,000 odd patients, and rivaroxaban is associated, mind you, even in the lower dose, with a 28% high risk compared to apixaban. Now, this is not relevant, but the GI bleeds are the commonest, and that's when our elderly people start getting GI bleeds, yes. But GI bleeds wise, look at both the societies, the ESC guidelines as well as the GI disorder guidelines together, the gastrointestinal bleeding. If at all, as a class 2A recommendation in 2016 itself, in patients at high risk of GI bleeding, a VKA, you may even choose a VKA, but if you have to choose a NOAC, do not choose these, that is dabigatran 150, rivaroxaban 20, or edoxaban 60. That's what is the class 2A recommendation. So, in summary, I would say that apixaban 5 milligram BID on the basis of evidence, again the evidence will never be RCTs. The only RCT evidence are all these three trials that we talked about. Apixaban, mind you, for this patient also is safest and efficacious in a dose of, for this elderly frail patient, is the safest but efficacious for our elderly patient. The benefits of apixaban versus warfarin have been consistent in patients with AF regardless of age, and owing to the higher risk at the older age, the absolute benefits, which means we take into account the efficacy as well as the bleeding, are greater in the elderly for apixaban. You saw the point estimates all to the left, and effectiveness of safety of oral anticoagulants in elderly patients in real world with atrial fibrillation is also consistent with this RCT data, and that the results are consistent even when our patient grows old and goes over the age of 80 years. That's when she would, however, require a dose reduction to 2.5 milligram BID. So having said that, let's be ready for the discussion. Thank you.
I also invite the other moderators, Dr. Devansha and Dr. Ronak, please join us. Yeah, over to Chairperson. Chair.
So, all the
I think so the speakers on the rebuttals at the stage, please. Ajay bhai, please. Yeah, back to the corner. Ronak, please.
so
Chairperson, sir.
all the speakers have supported their corresponding this molecules very well. And now the thing is that we have 3 to 4 criteria for the choosing any molecule. One is that superiority for the stroke prevention. The second is non-inferiority for the bleeding prevention. The third one is cost effectiveness, and fourth one, last one, maybe a quota that sir has rightly thought that for the age. So now cost effectiveness is nowadays not so much issue because of development of the so many grants, and superiority obviously proven in by all the trials in a very large meta-analysis also that all the molecules are superior for the stroke prevention. The thing is that what is the for this specific patient who is elderly and 78 years and with low body weight, so in that case maybe whatever the molecule which is quite non-inferior for the bleeding prevention, that will be most effective, and probably apixaban and which is having somewhat edge over other molecules for this bleeding prevention, specifically GI bleed. What others' opinion would be interesting?
Just one small comment. I think everybody was looking at Machli Ki Aankh of Arjun, chasing the anticoagulation. One important message that I wanted to drive: when you deal a patient with LV dysfunction and you have AF, always think of tachycardiomyopathy. So that's the slide. You should always think of. I have had patients, including one of the intensivist father, was scheduled for dual chamber ICD. Patient was in persistent AF. We just cardioverted him. Today his ejection fraction is 55%. He just came for a second opinion. He said, just go and just have a look. We cardioverted him. He was in chronic AFib, reverted to normal LV function. A lot of the symptoms can actually happen because of AF-induced cardiomyopathy. For fellows who are here, these are the differences that you can have on the slide because of calcium mishandling, contractile dysfunction, or of course the non-ischemic improvement. And that's why the reason was we mentioned a normal coronary angiogram. Next slide. As we were looking at this is the comparison, probably the crux of the three talks, how the CHADS-VASc was very beautifully brought by Ajay Bhai. He talked about baseline CHADS-VASc being higher in Rocket AF. Median follow-up almost the same. Hazards reduction, pretty much outcome was significant for all of them. But dabigatran, you need probably higher dosages. Bleeds, again, very well brought out by all the three speakers. Next slide. So can we have the discussion now, the rebuttals or suggestions that any inputs that have, I think Dr. Kelkar was able to rebut everything that the other two speakers did. Ajay, anything you have to say on what Prabal sir was mentioning?
In different ways to make your point. Yeah, but we have three drugs at the moment, prevalent and are good. You need to individualize therapy. You need to choose what is right for your patient. One of the very important things is creatinine, and that comes into the picture the moment you are talking about this subset of patients, 78-year-old lady, LV dysfunction. And if we don't talk about renal dysfunction, then it's a big point. So whenever in your clinical practice, you must be thinking, the first thing after you're looking at atrial fibrillation is what are the creatinine, because we are going to decide your drugs according to that. And that becomes a very important thing. Regarding this case itself, this patient being a higher CHADS where the patient had a higher CHADS score of almost having a drug to probably begin with for drug, the chances of bleeding are much better. Dabigatran becomes very interesting.
One question to both of you. Sir, does the availability of antidote in this specific patient of 78 years old changes your mind to dabigatran also?
Yeah, but the point is, that is a very big point you bring out, that if we see that it is confident that, because again, you're going to use dabigatran, you are for these elderly patients, going to start seeing that so highest stroke risk, because I think something that told us in this summary slide, it's the highest for getting a stroke. Now, fear of continuing, because you've got an antidote, what are you going to use? You're going to use a dose of dabigatran, which is low dose, which is just non-inferior to warfarin in terms of bleeding, in its case, right? And then you're again, second safety measure, if you're going to use dabigatran, you're going to use it for equivalence with warfarin, and of course, the IC bleed is going to be definitely better than warfarin. So then, why are we so thinking about it? And this so-called, it all depends on what is your country about. What Dr. Ajay pointed out is very relevant. These elderly patients, their creatinine, it's not that they don't require monitoring. Their creatinine is going to go up. And creatinine going up in an elderly patient, dabigatran, we are going to be really, really worried. Because it's the most renally excreted drug, 80% of the time. Whereas your dabigatran is least renally excreted, followed by rivaroxaban.
Other thing is
I
that
would not use dabigatran in this patient.
just the antidote doesn't come free. It's costly. If it comes free, it comes with the original brand, which is again costly. So cost effectiveness goes away. So if your fear कि वो free में antidote मिलेगा, तो you'll have to buy the original brand. Then the cost is gone. So then that logic doesn't hold true. So I think it's pseudo It's like the having an atom bomb, you may never use it.
If I have to do a Gatabandhan here, I will do with Ajay. Not that Ajay is from Korean. But if at all for this particular case,
Just one addition from whenever we are talking about antidote, really the last section despite raising all the problems. So the real because of the chances of getting this point is less, no doubt. The real need of antidote is here.
So after hearing all the three molecules, it is the same situation for like a cricket team for Rohit Sharma to select Sky or Subman Gill in the final 11. So according to the situation, which molecule is score better for treating the non-valvular AF and looking to the advantage? So I have a question to both the speaker. Apart from the beauty of all the clinical trials for all the three molecules and the benefits of NOACs in the specific non-valvular atrial fibrillation situation, I have one question. Where do you consider watchman devices when these all three molecules, even though after looking all this data is not safe to use in above age of 75 with some high risk of the bleeding? So which is the specific situation and what will be the scenario in Ahmedabad whether we have started putting watchman devices in contraindicated NOACs in non-valvular atrial
So
fibrillation?
I have deployed that. Despite so typically it is the elderly this reduce the dose after 1 week, this switch the drug to a safer drug after another week, and then we said does not work. And that is the time we would advise any academic closer. And I have done a few. But here we are, in this part of the world, we are ultra conservative and do any invasive procedures much less. In the West, they would not even wait for a week or a second. Okay. So LFM exposure is a good idea, but we understand the indication. The drop of a high specific LFM exposure is not on. Definitely, there is no real great science like the kind of randomized RCT this one has. That only read John Mandrola about that. It is an indication. It's the procedure looking for an indication. But as very rightly said, we've done a couple of where there is a true intolerance, the patient on NOACs has also substantiated the patient desires. Having said that, one of our patients was already had a large hole there and an ASD closure to be done. But we actually they opted out, didn't any of this closure first, then brought it back. In fact, I did one on during the same trip with the LA appendix closure and then the ASD closure. We are waiting for paisa.
I think the appendage closure and IVC filter both have same indications now. That either the patient cannot take drug or if he has a bleed and you cannot give the drug. Except those two, I don't think there are any other indications, including the Watchman trial had this very strict inclusion criteria.
Is there any indication like patient having stroke in spite of taking just NOAC or warfarin?
No, that's not right now a class 1 indication. So even if a patient has a stroke on NOAC, doesn't make you qualify for a Watchman device. It's not class 1 indication. No.
But that would be another subject you really need to look at closely because that might be.
So from physician perspective, final questions to all the three eminent speakers. What will be the take-home message out of all the three molecules? Which is the score best amongst all three for using the NOACs in these situations?
Each speaker will say for their own molecule. So you'll have to ask the chairperson.
Then I would like to ask to you.
Chairperson. I think most important is this thing that we have put in a quiz. So for every bout, there'll be a quiz. The quiz is live on the app. App in the sense the delegate link. Go to the link. There is a Q&A. You can click the answers. The whosoever gets it quicker as a sum total of number of points gets prize. Top 3 people get the prize at the end of the 25 question. 5 questions were there yesterday. This question will be active till the next question pops up in the app. And that's how it is. So the network analysis has shown the real world incidence of IC bleeds. We all fear maybe it's DABI, but now the 3 talks have already been done. what does it the max? So dabigatran, apixaban, rivaroxaban, and warfarin was the option. Let's go. And if you're still logging in, maybe I'm giving you the clue how it works. I'm displaying the answer here. For the next few times, I will not. The answer is of course warfarin, and this is from the reference for the same. So this is the network meta-analysis done in 2021 recently. And of course, the take-home message would be this, that at least do anticoagulate with a NOAC. Warfarin days are gone unless you have a compelling indication of putting on a warfarin. Choose appropriate dose, choose the appropriate candidate. High CHADS-VASc would have more real-world data for rivaroxaban. High has bled. You would be more tempted to use apixaban, but real-world data shows that probably all three are equally good. So choose the drug according to the indication, but choose for their inclusion and exclusion criteria. Go by the age, weight, eGFR, rather than because I want to give lower dose, so I will go lower dose, is not the right strategy. Thank you very much. Thank you, Chairperson, speakers. Your mementos and gifts are in your kits. Thank you very much. To save the time, we have done that arrangement. Thank you very much. We move to the next session. Jayesh bhai.
Thank you so much. It was a wonderful discussion as usual. And now ACS and antiplatelets, very important topic as far as physicians are concerned. And we are definitely interested in knowing more than what we know as on today. So I would like to invite Dr. Hasid Joshi, Dr. Nilesh Bhai, and Dr. Jignesh Kothari as a moderator, chairpersons, and the moderators are Dr. Rakesh Sharma, Gyanendra Singh, Mustafa, and Umesh Kapoor. Please come on the dais, please, all of them.
Intervention sessions at Grunzig Hall upstairs on second floor will begin at 11 a.m. 11 a.m. we have the first interventional debate in the Grunzig Hall, which is the interventional hall. So till then, of course, we have all the participants here. Interventional cardiology session is on second floor, hall B. It starts at 11 a.m. The first one is an interesting one, drug-eluting balloon versus drug-eluting stents. Over to
Chairpersons are
chairpersons
requested to introduce the speaker. Kindly.
and the topic.
Good morning, everybody. It's my pleasure to introduce Samir Bhai, Urmil Bhai, and Rashmi. All of who were, Samir Bhai was our mentor at UN Mehta. No need to introduce him to you. He was the starting person. So I invite Dr. Samir Bhai to start with talking about ticagrelor. Somebody to describe that first? Would we need a podium?
No, yellow stays in between. So this is the ACS choosing again between the antiplatelets and high bleeding risk. Now we know a lot of data of that prasugrel means committed to angioplasty, ticagrelor or season, but now you have cangrelor. So we lot of times in interventional cardiology end up with a patient with acute coronary. We don't know where the patient is headed unless you do an angiogram. So this is a 56-year-old diabetic hypertensive, 60 kg anterior wall ST elevation MI, pulse of 100, PP 140/88 class 2, history of 2 episodes of bleeding in stool 2 years back, which he states was due to query piles. But his hemoglobin has always been, again in inverted commas, normal, eGFR 60, angiogram, triple vessel, 100% grade 5, which is highly thrombotic, long proximal LAD, 90% also focal lesions in type A, which is in circumflex and RCA. Patient is planned for PCI, which is, it can be either POBA. If you get good flow, the cardiologist will put a stent. If he doesn't get good flow, he may leave it and give it to the surgeon. So stage PCI to LCX, RCA later on if he is able to do a PTCA. And if he is not able to do, then he will do a plain balloon and give the patient to the surgeon, which is hybrid approach, which is commonly adopted these days. So for that, can we have Dr. Dani's talk on ticagrelor is all season antiplatelet without higher bleeding risk and proven efficacy for even for patients who are stage revascularized.
Okay, so good morning to all of you. Thank you, Kamal, for inviting me here. Always a pleasure on this forum discussing about some practical things. And let me begin. So the patient profile already, Dr. Kamal has already alluded to, 56-year-old diabetic, hypertensive, 60 kg weight, so a slim guy, presents with anti-wall STEMI with a pulse of 100 beat per minute, BP 140 by 80, Philip class 2, and has had episodes, 2 episodes of bleeding in past, 2 years back in stool, and that was supposedly due to piles, but hemoglobin has always been normal, so those episodes were also presumably not very significant. eGFR is 60 ml per minute per 1.73 square meter. So that's a bit low for him at 56, what I would expect. But he's a diabetic, and coronary angiogram reveals triple vessel with occluded LAD, and possible PCI lesions in certain RCA also. So PCI POBA to LAD planned and done, planned, an ideal P2Y12 inhibitor would be. So that is the problem in front of us. So what are the possible scenarios here? One can presume that there was no bleeding, no ischemic complications, the PCI went like a dream. We just did the angioplasty, opened the LAD, and there was a good flow, and then we shifted him to the ICU. And there was nothing else. He went off on a expected course. And then there could be two possible scenarios. He chooses either bypass surgery or he chooses angioplasty. If he chooses bypass surgery, we will need to withhold antiplatelets for 3 to 5 days, especially one of them. What could be other scenario? Stormy course post angioplasty. He had no reflow during angioplasty or slow flow. He had ischemic complications. He had arrhythmia or hypotension, or he had persistent ST changes, or he had recurrent ST changes in the post-op course, post-PCI course. And then you might have to choose or give him GP2B3 inhibitors, or go for repeat PCI, stent the LAD. I don't know why we chose POBA, because we wanted to give him a chance for CABG. So then you may have to stent LAD, or you may have to do urgent PCI to LCX or RCA. This could be the scenario, or you may have to go for urgent bypass surgery. And then there is no time to withhold antiplatelets. So here are the consequences of your antiplatelet regimen comes into play. Until then, everything is hunky-dory. Third scenario is there is a major bleeding complication. And then if there is a major bleeding complication, he may need multiple transfusions. You may have to stop antiplatelet therapy. There is a possibility of ischemic complications once you stop antiplatelet therapy. And then what do? Then you go for urgent revascularization, be it bypass, be it PCI, everything will be fraught with a lot of apprehension and complications. You would do urgent revascularization, or you would delay it until his bleeding complications have been addressed. So these are the possible scenarios. The third scenario is the worst and least likely in a 56-year-old who has had minor episodes of bleeding due to piles. But still, you have to be prepared for that. The third scenario is most complicated, but probably needs least amount of thinking, because no matter what antiplatelet you have chosen, you have to stop there. All right, so what we are talking about the need to identify an ideal antiplatelet which is effective in this scenario, that is in STEMI, which has a lot of data in STEMI, and which is safe, which would not make the patient bleed. It will not allow for ischemic complications. It will not allow the patient to bleed. It will have data in this kind of scenario in STEMI. So effective means low or no stent thrombosis early or late. Because it's ST elevation MI, we are worried about stent thrombosis. Because there is a size of thrombus which is given, we are worried about thrombosis. And we should have data of this antiplatelet's effectiveness or efficacy in STEMI, ST elevation MI. And it should have efficacy whether you stage PCI or CABG later on. You should have possibility of both options. That kind of antiplatelet where there is a data. And if he goes for bypass, then it should be possible to withhold this antiplatelet for lowest period or smallest period of time. Because when you want to go for bypass, you should be able to go for bypass within like 2-3 days or even something like that. Here we are talking about 3 to 5 days, because following ST elevation MI, nobody is going to do bypass for 5 days unless it is mandatory. So he is not a high bleeding risk patient. So as I said, the bleeding complication apprehension is much less here. He's 60 kg weight, so that is the only thing. Otherwise, the bleeding piles history is probably not a big thing, and comorbidities are okay. So here is what we have as far as ticagrelor is concerned. And then I'll quickly, you know everything about ticagrelor. So I'm not going to talk much about and extol the virtues of ticagrelor and talk about prasugrel and talk about cangrelor. What we need to understand is this is the scenario. These are the possible scenarios, and then what could you choose, which would have probably benefits in all scenarios. So the ticagrelor mode of action or mechanism of action, I will just go through very quickly. Immature platelets is a concept, and there is enough data to show that immature platelets are probably the most important thing in thrombosis. And immature platelets are the ones which have dense granules, and compared to the older platelets, these newly born platelets have higher tendency to aggregate and adhere. And these are probably, especially in acute coronary syndrome situation, these are the platelets which are responsible for ischemic complications. So I'll go quickly. Immature platelets we have data that they have higher role to play in acute coronary syndrome. The pharmacokinetics and pharmacodynamics of ticagrelor, which is compared to thenopyridines, which is clopidogrel and prasugrel, this is CPTP. It's a transfer protein, and that's how ticagrelor differs slightly from thenopyridines, which are also P2Y12 inhibitor. And pharmacokinetics and pharmacodynamics of ticagrelor is such that it has better effect on immature platelets. It binds reversibly to P2Y12 receptors. So when you stop, the reversal is faster, and it does not bind to the ADP binding sites of the platelets. So ADP is allowed to bind. So it has an additional mechanism of action also. It inhibits adenosine reuptake. Now all these possibilities allow for decreased inflammation, quicker action, and overall availability of ticagrelor for immature platelets also. Why? Because prasugrel and clopidogrel are irreversible inhibitors. They bind platelet, bind for life. While ticagrelor can bind, but it is reversible. So when immature platelets are released, ticagrelor can redistribute, unbind itself from the mature platelets and go to immature platelets. And that's why possibly it has better effects. Of course, this has never been clinically proven, but pharmacologically, this is a proven fact. So I will go very quickly in the interest of time. There is a difference in platelet binding between thienopyridines and CPTPs, which I have already established and you understand. And if you look at the ticagrelor, it is overall superior to prasugrel at binding to young immature platelets, and that has been proven. So these table you know very well. I don't need to show it again and again, but if you compare it to prasugrel, you can be more confident in this scenario with ticagrelor because it has broader applicability. It is indicated for ACS. It is indicated if you choose PCI. It is okay if you choose CABG. While prasugrel is not so okay if you choose CABG. So prasugrel is better if it is PCI setting. So that way, ticagrelor is superior. Ticagrelor has also showed a cardiovascular mortality benefit versus clopidogrel, and prasugrel has never shown that, not mortality benefit. So ticagrelor is also approved for long-term protection against subsequent CV death, which again, so far prasugrel has not been granted that indication. It has also shown less stent thrombosis compared to clopidogrel. So that way also in ischemic complications, it is fine and it is as safe as any other antiplatelets as far as bleeding complications are concerned. Okay, I will go quickly. Now, if we talk about guidelines, this is the data which supported the statements I made. I will go just very quickly to the latest trial, that is ISAR React 5. And ISAR React 5 has been touted to propel prasugrel as a antiplatelet of choice. But ISAR React 5 had lot of limitations. And one of the limitations which I would like to highlight is that 1.3% of the patients did not receive a ticagrelor loading dose, while 13.9% of the other group did not receive prasugrel loading dose. So, question of selecting, obviously ticagrelor has a broader applicability. The patients were there, but they were not given prasugrel loading dose because of the physician's lack of faith, or physician felt that this patient was not suitable for prasugrel. I will not go into detail of that, but the fact is that it underlines ticagrelor has broader applicability. I could go on to limitations of study conduct, but in interest of time, what I would like to say is, compared to prasugrel, ticagrelor has broader applicability. It is as safe, and as far as in this scenario ischemic complications are concerned, it is equal, and it has added advantage that the patient chooses for bypass, you have enough data. What about cangrelor? Cangrelor also has only one advantage over ticagrelor, that it rapidly unbinds. So you stop, and within 6 hours, 1 to 6 hours, the effect is gone. So if the patient needs urgent bypass, then only cangrelor comes into play. Now, possibility of that happening is very, very low. So, in my opinion, cangrelor, you have to also consider the cost and availability. So, if you look at all these things, ticagrelor has a broader applicability, is indicated for ACS, regardless of management strategy. ESC guidelines, every guideline has class 1 recommendation for the use. It has shown CV mortality benefit. It has shown not to increase risk of fatal bleeding over clopidogrel up to 12 months. It is approved for long-term protection against subsequent CV events. And unlike prasugrel, you don't have to go through the steps that whether a patient's weight is less than 60 kg or more than, is he more than 75 years old, is he slated for PCI, etc. So if you again come back, effective, data availability, and safety, ticagrelor ticks all the boxes. And that's why I would say that is the only P2Y12 inhibitor which I would choose and go ahead without any worry in this case. Thank you.
Thank you so much, Dr. Samir Bhai. Our second floor session has already started. So those who are interested in invasive work, coronary invasive work and other invasive work in cardiology, they can go there and attend also at the same time. And now I would like to the chairman can introduce the Samir Bhai, you will have to wait. Summarize afterwards.
Good morning, everybody.
પહેલેથી સમીરભાઈ જોડે જતા રહ્યા તમે
2001. And it's an irony that I am placed by Kamal to oppose my teacher. In this particular patient, I'll step by step show you how ticagrelor and prasugrel are almost similar. If you just consider the data, the latest data, and the physiology, everything, prasugrel is almost as effective and almost as safe as ticagrelor. So if you go, I'm not going to do all these things, we all know. So antiplatelets in ACS, there is no doubt. The mechanism of action of various antiplatelets also we know. Sir has also elaborated about the irreversibility and reversibility of certain molecules. So we now come to, in this particular patient who is having an acute coronary syndrome, is having LED thrombus occlusion and is planned for percutaneous intervention, which is the standard care of treatment nowadays. So here the question is very crucial whether to go for prasugrel or ticagrelor. Ticagrelor is a newer one and very difficult to assess right now, but prasugrel and ticagrelor are already established. It is a third generation agent with irreversible ADP receptor antagonism, which is in a way a little bit helpful also, as I'll show. Efficient generation of active metabolite as opposed to clopidogrel, and high levels of platelet activation inhibition, which also has been shown in various studies. Higher response in clopidogrel hyporesponders. So clopidogrel is almost out. I'm not going to do that issue. I'll just make a point here later on in those patients already loaded with clopidogrel, and trial data are also there. If you see the comparison of clopidogrel, prasugrel, and even ticagrelor and cangrelor, loading dose and everything we all know. Contraindications many a times very forcefully propagated by other manufacturers is bleeding risk. That also I'm going to show is not that much kind of problematic. So if you see the studies, it's a study design itself, because whenever we look at the results, we have to see the design of the study, which is particularly relevant in this case. If you see the Triton TIMI 38 study, which was conducted with prasugrel, which included ACS 100% of patients, ticagrelor 100%, and cangrelor only 44% of ACS patients. GP2B3 inhibitors were used much more commonly in prasugrel group, and that was probably one of the cause might have been because it showed little more bleeding complications. The duration of medication and everything is okay. Primary efficacy endpoints were similar, including death, mortal infarction, and stroke. And if you see the comparison of prasugrel and ticagrelor, this is a very interesting meta-analysis. There are some flaws with meta-analysis, we all know, but they are also very important and strong tool to understand differences between the molecules. If we see mortality, then mortality, this is pooled data of many studies, and if you see clearly the prasugrel, overall if you see the mortality in prasugrel group is little lower than that of ticagrelor. Then if you see the myocardial infarction incidence, then in all these studies pulled out patient of around more than 5,000. If you see the myocardial infarction in patients treated with prasugrel also is much lesser compared to ticagrelor. If you look at the revascularization, again that also is better with prasugrel. Stent thrombosis, again, if you see, is better in prasugrel. This is very important point, because ticagrelor gained the momentum because it showed that stent thrombosis is reduced to less than 50% when you use instead of clopidogrel. So here a molecule which is even more effective in terms of reducing this stent thrombosis than ticagrelor. Then stroke incidence, again, if you see, people are so much worried about prasugrel causing strokes. So here also, if you can see in this meta-analysis, the prasugrel stroke incidence was better than that of ticagrelor. 14 strokes out of around 5,000 patients compared to 24 in ticagrelor group, and 6 compared to 13. And if you see the bleeding, again, which is very strongly kind of told about, is if you see in this pool data of around 5,000 patients, 128 bleeding, clinically significant bleeding compared to 202 in ticagrelor group. So it is not like it is a bad boy. So based on this, we can definitely say that authors concluded the prasugrel is at least as effective and probably even better than ticagrelor. Then this is a real world data from USA itself. So if you see real world means all patients, all that is what we do. So here if you see in 30 and 90-day mesh comparisons, mesh and bleeding, everywhere you can easily see prasugrel is better than ticagrelor. This is the real world data in the USA. It was said in this because they were probably very astonished to see these results. So it was like they added this point that probably physicians appear to preferentially use prasugrel in younger patients, and that's why probably this data. But it is just a speculation. So then I come to ISAR react. Sir has tried to dissect its flaws, but if you see, this is the ISAR react trial where more than 4,000 patients, prasugrel versus ticagrelor, one of its kind, head-to-head comparison, which is rare to see, and primary endpoint was composite of the 3-point endpoint and safety is bleeding. Here, if you see in the conclusion, among the patients who presented with acute coronary syndrome, like the patient in our case, where with or without ST segment elevation, the incidence of death, MI and stroke was significantly lower among those who treated with prasugrel compared to ticagrelor. The incidence of major bleeding was not significantly different. It was similar to ticagrelor. And this was a subgroup of the same study, ISAR subgroup, where patient underwent coronary intervention, like in our patient, where out of the more than 4,000 patients, 80% of the patients were eligible for vascular intervention, were randomly assigned to ticagrelor and prasugrel. And if you see, 9.8% of patients in ticagrelor group had primary endpoint, while in prasugrel group it was around 7.2%. So almost 25% reduction in the 3-point MACE. So that is not very insignificant, I would say, because if you see the current medications where even a 16 or 18% reduction in the MACE events is considered significant. So 25% reduction in MACE is something which is spectacular in my opinion. And the bleeding risk, you can see here, even prasugrel is little better, 78 compared to 84 bleeding events. So this is again one of an observational study, more than 7,000 patients. And here these Kaplan-Meier curves show us 1 year death in the groups, either STEMI or this is statistically adjusted STEMI cohort or NSTMI. And here the conclusion was, compared to ticagrelor, prasugrel was associated with superior clinical outcome in STEMI patients, which is what our patient is, but not in non-STSMI. Probably again because the thrombus load is more in the STEMI patient. Again, here, this is again meta-analysis kind of thing. Network meta-analysis, which is truly eye-opening. I'll say network meta-analysis takes into account many trials, very scientifically and statistically, goes into details of each and every patient, and then produces the outcome, which you can see. This is the rank probability of which agent is superior. And here you can see, out of all, in every respect, the number one is our so-called bad boy, which is prasugrel. First in all-cause mortality, first in cardiovascular death, first in definite or probable stent thrombosis, stroke, and bleeding, which are the main objections by the clinician. And minor bleeding, MACE, everything favorable to prasugrel. And ticagrelor comes second or third. And cangrelor, even though it is being injectable, fast acting, everything said all together, it again takes second or third rank. So if you see again, cardiovascular death, myocardial infarction, stroke, minor, everywhere, the conclusion is despite rapid platelet inhibition provided by cangrelor, strong effects of ticagrelor as touted, even with that, the first rank goes to prasugrel. And here, I would like to point out one or two important things in this patient. In this patient is posted for coronary intervention. And in this era, if this case were 10 or 15 years back, I would definitely understand that patient might have to go for bypass later on. But here it is an LAD angioplasty. Why do you want to just do a POBA? Just go for a stent and then after 2 or 3 days or even in next admission, go for the second angioplasty of heart and LCH. As simple as that. Why do you want to go for bypass in this patient? And in today's world, most of the patients, we can do coronary intervention. It is not like 10 years or 15 years back where we were limited in resources and hardware, where probably in few patients we had to go for bypass. So here in this case, there is absolutely no preference of ticagrelor or prasugrel. That is what I would say.
Thank you, Rashid. Thank you so much. Next speaker, kindly introduce.
So, good morning, everyone. Let us talk about a very important molecule, which is cangrelor, especially in the setting which has been given to me. We all know the history of this patient. It's a bleeding pile. That is one history. Patient is having CVD, diabetes, may need a bypass surgery. Plan is deferred vascularization. That means at present we are planning only the adenoplasty, and later on we are going to do plasty of stent or circumflex. Cangrelor, according to me, is the safest in this situation, with the case which has given to me. Now, why we need a second anticipated agent, and when should we give? We should give once we know the glomerular anatomy and once we decide that angioplasty, we are going ahead with the angioplasty. That is one. And second important thing is to give no stent thrombosis or no bleeding. That is the main purpose, because the patient is having acute myocardial infarction and the patient is having bleeding history also. So adjuvant pharmacotherapy is going to be crucial, and we have to give once we decide that patient is going for angioplasty, and we have to add a second anticipated agent, and we have to continue it for a longer time. And as you can see here, the stent thrombosis is probably the most adverse sequelae which we really want to prevent once we undertake the patient for angioplasty. And this is the reason we give a second anticipated agent, which can be ticagrelor, which can be prasugrel, or in the newer time or newer era is going to be cangrelor. I'm going to justify that in present case. As you can see here, prasugrel irreversibly bind. It's a prodrug. That is little disadvantage. Important thing is the time of action. Okay, it's a 30 minutes to 4 hours. And now the patient is already on table. 100% LED occlusion. We are starting the procedure. Okay, we cannot wait to have anticipated effect for a longer time. That is one. And second disadvantage is offset of action takes about 5 to 7 days. And as the case has been described, the patient may need a later bypass surgery or a stage plasty. So what needs to be done? That we have to keep in mind. The limitation of oral antiplatelet agent, we know absorption may not be predictable. Patient may have nausea, vomiting. Delayed onset of action, as I have told, 2 to 4 hours, which is not good in this situation. It cannot provide a reliable antiplatelet effect, and we really need a reversible platelet inhibition because patient has a bleeding history. At the same time, patient may need a bypass surgery later on. So delayed onset of action also is very important, and cangrelor is a molecule where this disadvantage is not there. Those patients, I presume that this patient is not pre-treated with any other antiplatelet agent. Okay, now we are going to start antiplatelet agent. The most important thing is if you have a delayed onset of action as far as platelet inhibition is concerned, then definitely stent thrombosis is the major thing which can happen. What we used to do in past when the cangrelor was not available, we used to give GP2 inhibitor in this subset of patient. It's a very effective molecule, very useful molecule. The major disadvantage, the bleeding complications are very high. Okay, and these basically offset the advantage of using GP2 inhibitor. Now let us understand and know about the cangrelor molecule itself. Cangrelor basically is the adenosine triphosphate analog, which basically acts on the same receptor of clopidogrel, prasugrel, and ticagrelor. That is one. Potent onset of action, that is very important. Second important thing is reversible action. That means Once you stop, or the bleeding chances are much less with cangrelor, as you can see here. Another important thing is when there is situation like delayed absorption, okay, which is a disadvantage for oral molecule, is not going to be there with this molecule. And it has an impressive flexibility, meaning by suppose during procedure of primary angioplasty of LAD, suppose the rupture occurs or some complication occurs and patient need an emergency surgery, the offset of action is very important because it's going to go within 60 to 90 minutes. As you can see here, extensive platelet inhibition within 2 minutes start, that is important. It is maintained throughout the infusion period, and 90 minutes once you stop the molecule, the anticipated effect goes. Higher dose of cangrelor is more effective because it also acts on the pre-selectin expression also. There is no need of hepatic conversion with this molecule, which is required for prasugrel. And renal impairment or hepatic impairment, it is not going to affect the efficacy of this molecule as far as antibiotic is concerned. And practically, there is no drug-to-drug interaction. So now let us compare all these three molecules. As you can see here, cangrelor where it stands, it is also a reversible molecule. This is also not a prodrug, so it is going to be effective very fast. The major advantage you can see here is a 2 minutes the starting of action time, that is one. And offset of action, as you can see, is 60 minutes. So that is also very important, especially in this subset of patient when there is a bleeding history, as well as bypass may be required in near future. So unique pharmacological property has an attractive option, especially in this kind of patient. Now, what are the data which can compare with this molecule? As you can see, there are the Champion TCI, Champion Platform, Champion Phonics. All the trials have clearly shown that primary endpoint, death, myocardial infarction, need of revascularization, is significantly low. If you see the p-value, it is 0.005. So it is a definite advantage. That is one. As you can see here, the risk reduction at the end of 48 hours and 30 minutes in primary outcome, stent thrombosis, ischemia-driven revascularization, and myocardial infarction also favors the use of cangrelor in this subset of patients. So there is advantage as far as safety is concerned. As you can see, thrombus formation, acute stent thrombosis, need of GP inhibitor will be quite less in this group of patients. If you look at overall complication rates are almost 20% less. At the same time, the bleeding complications are not increased, especially the major bleeding. Okay, the gastro-major bleeding or a T-major bleeds are almost same. That also we have to keep in mind. Somebody may argue because all these studies were done with the clopidogrel, okay, not with the prasugrel, but this molecule has come in market, I mean, in pictures in 2005. Okay, and all the studies were done in the previous time before 2015, where the prasugrel or ticagrelor was not commonly used. But let us study, as you can see here, where the cross ticagrelor was used. Okay, of course, we don't know whether Samir Bhai is going to use the cross ticagrelor in this, but even in this subset of patients, 30 minutes, when you finish the procedure, we know that nowadays PAMI can be finished in 30 or 40 minutes. If you look at the platelet inhibition, which is much less if the ticagrelor has been given, even the cross, okay? So as far as anti-platelet efficacy is concerned, fast action can be achieved with cangrelor only, that is one. What about the prasugrel? As you can see here, this is a study where three molecules were compared. It was cangrelor, tirofiban, and prasugrel. And as you can see here, compared to prasugrel, the platelet inhibition at the end of 30 minutes, which is the time where we require a maximum antiplatelet effect because we are going for the angioplasty, is quite less compared to the other molecules. What about the comparison with GP2 inhibitor? Of course, GP2 inhibitor, as I have told, is a good molecule. It's a comparable efficacy of cangrelor and GP2. Both are IV molecule, both are antiplatelet agent. So as far as ischemia or a thrombosis is concerned, there is no much difference. But the major difference or major advantage of cangrelor is in the bleeding complication. As you can see, the major TIMI bleed or a gastro major TIMI bleed is significantly less with this molecule, as you can see in this slide. So historically, nowadays we are not using GP2 inhibitor much in most of the patients, okay? Mainly because we have it's only a bailout, that is what we call, then we are stuck and we have to use. That is the only thing. Bleeding is the major concern, okay? And especially when we have a prasugrel or ticagrelor, and then suppose this patient has been given and by chance no reflow occurs and we have to give a GP2 inhibitor, it's going to be a significant bleeding complication, and also patient has a history of bleeding piles. At the same time, whenever there is a suspected, suppose the patient develops no reflow because there is a big chunk of thrombus in the LAD, then a GP2 inhibitor probably might be used. What are the guideline indication of cangrelor? It is 2B indication, where patient is, I mean, there is no GP2, antiplatelet agent has been given, and mainly to reduce the ischemic complication in this patient. Now, let us come back to our patient, which is having a history of bleeding pipes, 100% thrombus containing lesion. There is a long segment lesion, and it's a deferred vascular. That means we are going to do a stage angioplasty or a bypass surgery later on. What we have to keep in mind, patient is having diabetes, and definitely it's going to have a diffuse disease. there is more chance of no reflow in this patient as we expect it to be having a diffuse disease. We may not put in a primary situation, and we may subject this patient for CABG later on. So that also we have to keep in mind when we are doing an angioplasty. Another important thing is delayed onset of ticagrelor, prasugrel is also going to contribute for no reflow and stent thrombosis also in this situation, and we might have to use a Bailout GP12 inhibitor. Suppose we have given this molecule in this patient, then problem is the antiplatelet effects is going to last maybe for 5-7 days. And by chance, suppose patient requires a bypass surgery in the near time, that is stuck. And suppose by chance the patient develops some sort of a complication during procedure, then also ticagrelor, some patient has to go for urgent CABG, that also is going to be really a problem if the patient is on ticagrelor or a prasugrel. We have to keep in mind that patient is also having a bleeding PR. By chance if it occurs, then we are practically stuck because we don't know at that situation what to do and go ahead. This may be the similar case scenario which has been described. This is the LAD lesion as you can see here, and as you can see, we have done a plain angioplasty in this patient, and angioplasty was done. And this is many a times what we many a times encounter. And this is what many a times we encounter. Once we do angioplasty, we don't know it's a thrombus central lesion, diffuse LAD, there is no row flow, we cannot put a stent in this situation, and many a times we decide that patient should go for CABG later on. And this is a situation where by chance if ticagrelor or prasugrel has not been given, it may be serving the purpose. So this may be the situation. As you can see, there is a no reflow. Okay, after doing angioplasty of LAD, we know a patient is also having a bleeding complication, and if we have to give a GP2 inhibitor in this patient because now there is a no reflow, and if we give it, then there is going to be a big problem. So among this, all the three options which has been given, thrombus containing multivessel disease, primary angioplasty which we are doing, and there is a bleeding risk also. Probably cangrelor if you use, that allows CABG to be performed early if it is required in a specific situation, and which is likely in this patient because patient is a diabetic and likely to have a long segment disease. Bleeding piles also is a contributory factor, and at the same time, if you expose them, then we have to delay the surgery for a later time. Extra advantage if the patient is having vomiting, not tolerating, or delayed absorption, cangrelor IV is a molecule. Ticagrelor may be a choice if there is a single vessel disease and there is no diabetes, no bleeding history. Definitely that should be the choice. Otherwise, cangrelor is the best choice. Thank you very much.
We'll take only two questions because we are short of time. Only two questions, please.
We are using cangrelor since very long. As such, we were one of the champion study trial was there. Our center was that participating in its study. So we know about this molecule. The problem was it was not available for a long time. Okay, and now recently it has been available. We are using it very frequently, especially when there is acute situation like this. Okay, we don't know, there is no second antiplatelet which has been given. Suppose by chance patient is on ticagrelor which has been given, or a prasugrel or clopidogrel has been given, we may not be using this molecule. But if it is just we are doing angiography, we find out there is 100% lesion and we are going, and if we want an antiplatelet effect very fast, probably this is the best.
So I think Kamal Sharma began showing it blossoming and blooming in the medical fraternity, like the Kamal which is popular all over the country. And one silent observation is that he has very intelligently chosen the colors of all the three things, blue, red and yellow. It goes to tell you that here, think and implement. He has deliberately avoided the green colors to make you not feel that green is go ahead with.
We have green also, we have pink also, don't worry. There are five speakers in one of the session. We have all colors.
Green color would signify that
green is peace and green is greenery, don't worry. Unless we have food from the green, we will.
And yes, now I think from the description he has made, ticagrelor you can compare with Swift. Go to the notes of what he has described. Prasugrel can be fungi and Kias, and the taste is hogs and oddies. So we let us highway for the rebuttal.
Yes, thank you. Yeah. See that there is definitely a different situation, okay? Because now the patient is already in ticagrelor, okay? The problem with ticagrelor, I mean, the advantage is once you start within 2-3 hours. So by that time, we take the patient for angiography, do angioplasty, maximum platelet occur. So probably there may not be the need of cangrelor or any other agent in this situation. But the case which has been given is we have done angiography. Till that, only aspirin was given. And now we want to go ahead with the angioplasty with thrombus-containing lesion, okay? There is a role of cangrelor. So no other antiplatelet agent is given in past, then there is advantage. Of course, we can give it. We can give IV molecule also in this situation, but it depends on the time. Suppose ticagrelor is within half an hour, or patient might have vomited, or patient is cardiogenic shock. Definitely cangrelor has a role. Otherwise, ticagrelor by and large is fine.
What about bivalurity? You have not mentioned, if I'm permitted. Bivalurity. It used to be a drug given as long as the procedure was there.
Yes.
Only there was a catheter-related thrombosis, so I think it went into disfavor. But still, it is a drug which can be given only as long as the procedure is there, and then discontinued after the procedure.
Yeah, so you are right. So what we should be doing, we will be giving this for about 2 to 4 hours. Okay. By that time, we have completed the procedure. We know that we are going there with a stent. We have put the stent, and there is good result. There is no diffuse disease. Probably the circumflex lesion can be tackled very nicely. So once you give this molecule for 2 to 4 hours, we have to give ticagrelor after that. Okay, once you have finished the procedure. But at the time of procedure, when we are doing it, cangrelor may be the best choice. And later on, definitely we can go for the other.
So bivalirudin has come back strongly recently with this couple of trials coming in positive. But the problem here is if he ends with CABG. So that's the reason when we were pitching antiplatelets against antiplatelets, not anticoagulants versus antiplatelet. That was the reason we chose cangrelor as a debate rather than prasugrel or ticagrelor. Dr. Gambhir has some closing comments. Yes.
I think most of the things have already been told by all the three speakers. One or two points which possibly needed to be highlighted by the speaker who spoke in favor of ticagrelor. See, there is a study which has shown that if you give ticagrelor in the ambulance versus if you give it in the emergency room, there is a significant reduction in the incidence of stent thrombosis, which means the earlier you give ticagrelor, the lesser is the incidence of stent thrombosis. That is one added advantage. That's one. Number two, there is a study which has shown or which have estimated the platelet aggregability and levels of ticagrelor versus platelet aggregability in three forms: oral, crushed, and tablet. And they have shown that at half an hour when ticagrelor is given through the nasogastric tube in a crushed form, the levels are much higher, and those levels are acceptable. Similar is at 2 hours, but at 4 hours there is no. So if you want to achieve early levels like cangrelor, you can give the ticagrelor which we routinely give in our cath lab. We crush the tablet and give it in the form of nasogastric. So you achieve the same level of. The third thing is there is as yet no data which suggests that after giving GP2B3A, you can safely give prasugrel, whereas you can safely give ticagrelor. So ticagrelor has certainly advantages. Cangrelor, I have no experience, so I will take it.
Thank you very much. So can we, for the sake of time, close this? The question here was which of the following secondary, the quiz based on this is which of the following secondary. So everybody was talking about ISAR REACT 5. Dr. Rashmit must have pitched very strongly on ISAR REACT 5, which was the trial which compared the two molecules head on. But it had its own drawback. People talk about ISAR REACT 5 showing prasugrel superior to ticagrelor. So this is the live quiz that you can play on the delegate link that is there on the app. Go into the delegate link which has been shared with you. There are prizes, of course. We'll tell you who gets it quickly. The options were all cause death, myocardial infarction, stroke, or all were similar or not significantly different. So that's the option to choose. So
That's the question from the ISA React 5. I think the summary of the thing is that, of course, you will be, if you're a perfectionist, dedicated interventionist who's sure that you will end up surely with 3 stents, prasugrel may be better. But when you're not so sure and thrombus is going to be giving you trouble, cangrelor maybe or ticagrelor maybe. Cangrelor, you can always follow it up with later reloading with tica or prasugrel urbil. So no harm that by the time, and then load whatever you want to. Thank you very much, all the panelists. Thank you for patient hearing. Next slide. So the answer here was we all were similar. Remember, the ISA React talked about prasugrel being superior, but it was for the combined endpoint and stent thrombosis, not for death, MI or stroke. All 3 were pretty much similar, not significantly different. Combined endpoints was different, so both of them are as good. ISA React 5 banks very strongly on this trial for prasugrel, but that's not the case. So that's how you interpret the data. That's the problem. Next slide. So for the next session, we have very interesting acute heart failure. Everybody talks about chronic heart failure. Everybody knows 4 pillars. When you have, we believe in being on time and before time. That's what we are talking about. When patient has come with acute heart failure, when do you initiate and what do you initiate first? So recent evidence, 77-year-old. For this session, I want to invite our chairpersons, Dr. Sanjay Shah, Dr. Sandar Patel, Dr. Kandar Nimawat, Dr. Mukuloza, Dr. Smitesh Dutt, Dr. Falguni Vora, Dr. Path Patel as the moderators and chairpersons respectively. So 77-year-old case, Dr. Jayesh Bhai, case.
I have to announce one thing. Today we have a gala dinner. And you will hear all cardiologists singing one or another song. So this is a different attachment, which this time we are doing it. All cardiologists and physicians, they are going to participate today. They are going to be singers. So everybody is invited. Thank you. Chairperson, kindly introduce the subject. 77 years old.
Hello. Good morning. I think I have to describe the case. Good morning. I will invite Dr. Prabhu Kelkar to deliver his talk.
Well, I suppose there's no reason without the details. I'm in the red corner, but I can't see the blue man right there, so I'm happy to take some extra over. Having said that, RP is now evidence-based for ADHF, acute decompensated with long-term benefits. Now, I would say the evidence has been around for hitting this and hitting the space bar and doing it. So I would say that now I would say the evidence has been there since 5 years. It's only that the guidelines came now, and that's why now. But we're dealing with a very sick patient. Yeah? Patient is in hospital and hospital now stabilized for all such costs. We discharged because the words of discharge and had a previous hospitalization. And low on blood pressure, elevated NT-proBNP has iron deficiency, so heavyweight Brian comes in there, and intolerant to GDMP, I doubt very much. His nausea is the reason why he or she, whatever was the patient, is omitted the GDMP, and that's why put her at a very high risk and made her even sicker. And the controversial issue, NYHA class 4, which might be construed to mean that Army is out. I'll show you, yes, very difficult wicket to bat on, and I'll need some extra overs, typically doctored by the great Kamal. But this is like mundane stuff, right? It is routine for the so-called heart failure specialist. Why worry about this? The key moment here, it's actually an opportunity. Hospitalization is an opportunity, especially in the pre-discharge as well as the post-discharge phase. Because all novel heart failure, acute heart failure therapies till date have failed. And we got to look for evidence out here. And the evidence why? Because early treatment initiation in hospital is associated with improved adherence, and this patient is a defaulter. Not only that, discontinuation or non-use of GDMT is going to, VHF is associated with poor outcome. So having said that, look at evidence, and the evidence for the 4 fights today comes from Pioneer HF, which I'm going to dwell on, the Victoria, Verisigwat, Affirm HF with Brian Pinto, and Impulse with Jayesh Bhai. So having said that, Soloist WHF was in diabetics, as also it was in a dual pathway inhibition molecule, SGLT1 plus SGLT2, so that's not relevant. So add to that, not RCT, but open label evidence, not one but 2 trials with ARNI. I'll deal with transition as well. And for all these 4 molecules, this patient should be stabilized. And I presume right at the outset I told you she's stabilized, because there is got to be hemodynamic stability, not on inotropes, stability of key laboratory tests, mostly vital organs, especially kidney, that it is showing stable parameters, and that of intravenous diuretics and being transitioned to oral treatment. This is the 2 feared reasons why people don't give ARNI. But if you look at the Pioneer inclusion as well as exclusion criteria, this blood pressure and this EGFR is fine to get on to ARNI. Not only that, the low EF, regardless of ejection fraction, look at the distribution of ejection fraction in the paradigm HF, as low as 5% to 42%, and consistent effect. ARNI is effective across the range of ejection fractions, even less than 28, as you can see with the point estimate, for every other endpoint, including CV death. So, if you fear ARNI initiation, बेचारा patient मर जाएगा. That is the importance of all this. So Pioneer first, and among the key questions addressed for people who fear initiating ARNI, how to titrate the dose is very much there given in the Pioneer HF. And for this particular patient, I would titrate given a blood pressure in the 100 range with total maximum. Okay, so dose level 1, that is what 50 milligram BID is what you would start with. Having said that, the up titration to the fullest dose in this study done in 8 weeks time. And mind you, the comparator arm, unlike my fellow worthy opponent, is not a placebo. It is enalapril 10 milligram twice daily. And what did they see? The most important marker of prognosis, NT-proBNP, down by as early as the first week compared to enalapril, and retained to be down. NT-proBNPs in our patient are high. They're going to come down with ARNI. Not only that, you look at the safety which we are worried about, worsening renal function, hyperkalemia, symptomatic hypotension, angioedema events, no significant difference between the 2 arms. So also, and of course, an exploratory endpoint, 46% reduction in the serious event composite endpoint, the same kind of a effect that is showing in the Impulse trial, which Jayesh Bhai is going to talk about. 46% reduction, impressive, driven mainly by the fact that this patient is not going to get re-hospitalized. Not only that, look at the extension study. What is that? Yeah. So look at the extension study out here. Not only in the initial phase, when we went into an open label thing, the NT-proBNPs came down. But if you got what is called randomized to the enalapril arm, you'll never do well. The curves never come together again. That is the importance of starting ARNI now in this patient, as what Jean Wilcox in her editorial has to write. The optimal time to start ARNI, not only ARNI, all GDMT is now, that is in hospital, so that you can monitor closely these patients. Because they're all sick patients, isn't it? And look at this open label trial. Why open label? Done earlier than Pioneer trial, because it was unethical then, because ARNI was approved. And how can you go beyond 12 weeks with giving enalapril to the patient? So therefore, but the randomization here in this trial is pre-discharge initiation versus post-discharge initiation, and looked at mainly safety and tolerability to go to the highest dose. And the highest dose achieved, whether you did it pre-discharge or post-discharge, in 50% of HFrEF patients, stabilized patients, within 10 weeks. That's why I'm trying to tell you, give up on homeopathy, Start low, but up titrate to the fullest dose of ARNI. And no difference between pre-discharge and post-discharge initiation. Having said that, again, the same events that we are worried about between pre-discharge and the post-discharge initiation, the same safety, well tolerated, and rates of adverse events or treatment discontinuations were comparable whether you did it pre-discharge or immediate post-discharge. Small wonder then that there is a consensus amongst both guidelines about using ARNI as a first-line therapy in hospitalized HFrEF patients. And this consensus is very much there, as you can see here. Now all the Fantastic Four need to be started immediately, as early as possible. But there is some little problem with this American guideline. I don't know if you can see that. That red box that I'm showing you, somehow they kept class 4 patients out, whereas the Europeans included all patients, all class of patients. Maybe the Americans got influenced by the latest published LIFE trial. But mind you, LIFE trial was about advanced heart failure patients. And if you go to and even otherwise, if you look at my competitors today, all the 4 trials here shown here, NYHA class 4 patients are up to 9% in Pioneer in both the arms, both the enalapril as well as this arm. Whereas in Victoria, blue corner management around just 1.4%, about similar as Paradigm HF, isn't it? Though there are only 11% of the patients started in hospital initiation. Impulse Bhai, Jayesh Bhai is rocking out there, 9.8%. So, but NYHA class 4, mind you, is not the same as advanced HF. When we are dealing with advanced HF, what are we dealing with? Look at the life inclusion criteria for a little while. And NYHA class 4 symptomatology defined as chronic dyspnea or fatigue in the previous 3 months and patients who require chronic inotropic therapy. I'm sure this patient is all set for discharge and not that kind to worry about class 4 patients that the Americans talk about. Current inotropic therapy or use of inotropes in the past 6 months was there in a quarter of these patients in the advanced trial. And even if our patients were in advanced heart failure, still you got to start right at the top there, the Fantastic Four. Why? Because this Fantastic Four will give you survival benefit. All these 4 molecules. SGLT2 inhibitors are included out here. There is nothing about beta blockers and MRA here. We are talking here about ARNI versus SGLT2 inhibitor. I have shown you not 1 but 2 trials of ARNI where in hospital initiation and big trials for that matter, transition going on, 1,000 patients, 19 countries trial, going on for a year the trial. So there is no fear about ARNI. Please do not fear ARNI is what is the message. SGLT2 inhibitor, Impulse trial, again, what kind of a thing have they used there? They used what you call a win ratio in statistics. There is one problem with win ratio there, is that the win ratio does not, you are not able to assess the power of this trial, right? So you use few patients, you do a quick trial, you use all comers and all and get the benefit. Yes, SGLT2 inhibitors are great molecule, but not the same robust evidence like what we have for ARNI. Again, the American guidelines do not, they talk about cost effectiveness. Probably it's not so relevant for us. It's only intermediate value for SGLT2 inhibitor. And the other 2 heavyweights from Mumbai, these are mere planks to the in-hospital therapies that we are talking about in such a sick patient. These are planks, and these planks come only after the pillars have been put, right? So what do these planks have as guideline recommendation? Because they are planks, very sick what? Blue corner man is 2B. You know what 2B means, right? And very sick what may be considered for a combination of hospitalization and CV death. That's the primary endpoint, only reduced hospitalization. Mind you, NT-proBNPs are high here, and patient needs to be already on GDMT. That's why smartly he said apart from GDMT. I don't think very sick what is GDMT for this patient. And that highest quartile NT-proBNP, more than 5,000, is a relatively, this molecule is going to become ineffective. The message here is that once this patient goes into the truly advanced heart stage, none of us four guys are relevant, right? We have to think cardiac transplant, etc. for this patient. And IV iron replacement, finally, I know Dr. Brian has been such a big fan of IV iron, and 4, 5 trials happened, all for functional improvement, quality of life improvement, etc., etc. Finally, the Affirm HF trial is giving hospitalization benefits, but yet this is the final slide. Yet the ACC AHA says you use it only to improve the functional status and quality of life. Of course, that does matter. And finally, I would say that we have the most robust evidence, and the initial dose level for this patient will be 50 milligram BID, and we need not fear because इसके आमने बाद में हमारी ठीक होने वाली. Thank you so much.
Now I will invite Dr. Praveen Kahale.
Good afternoon. So basically, Dr. Kerkar had made my presentation easy, that the heart failure patient or this patient require definitely great attention, and he is a very high risk patient. So my contention today is adding Vericiguat is a safe and effective strategy and choice in this patient who is hospitalized. So what are the consideration in this patient? Definitely he is a HFrEF patient who is hospitalized 3 months back, and he has a CKD non-compliant to the treatment. So what are the questions? So what is this? Is it acute heart failure or it is a different population? How can we reduce the risk of hospitalization as well as worsening heart failure? And how we address the renal dysfunction, and what about tolerability issues? So we all know patients with heart failure, once they get hospitalized, they have very high event of rehospitalization within the 30 days. So this is a very risky window period, and each hospitalization decreases the probability of survival. So when we speak of heart failure, this is what we see the risk of a heart failure. On the left side, what you can see is the risk stratification of ASCVD. Now when the event rate per year is 7%, we say this is a very high risk patient for ASCVD, give him statin, treat his coronary artery disease. But when we speak of heart failure, the low risk heart failure which comes to OPD has a 10% event rate in year, and 40% those who are treated with all 4 drugs. If you treat with all 4 drugs, so the event rate without drugs is 40%, and if you treat with all 4 pillars, you can reduce the event rate to 10%, and these are the OPD patients which comes to us, and the event rate is more higher than ASCVD. But moment they have worsening heart failure, which means they get IV diuretic, whether they are hospitalized or an emergency setting, the event rate goes back to 20 to 30%. So we are dealing with a very high risk situation here, and we need to give them best of the possible options. Now, what is the risk of cardiovascular? Once patients hospitalized, this is what we say is a vulnerable period. Immediately after hospitalization, 1 to 2 months is a vulnerable period where there is again a risk for an hospitalization, and there is a evidence-based strategies. If you implement here, we can definitely reduce the rehospitalization. And these are the studies to show that you first 3 months and 3 to 6 months, you have a very high event rate in these patients. So guideline recommend what you should do. You should optimize this therapy, follow up early appointment, and initiate multiple therapies in the course of disease. So you need to add all. So it is not the one drug or another drug. It is about a polypharmacy, different drugs with different multiple mechanisms, and that we have seen in all fields. Diabetes, you start one drug, another drug. Now we say start combination. Hypertension, 20 years back we came that it is the different mechanism of action. Lipid lowering, initially they used to say there is no evidence for ezetimibe, but now we say we want to get a target, we want to save patient, you can start immediately. So here what we are is important in this patient is different multiple drugs, polypharmacy, and how we can reduce these events in these patients. So what is the guideline says? These are the ESC guidelines that you need to start this oral medication before discharge, and Dr. Kirkar has already told you that this hospitalization is one of the opportunity where we can optimize the medical treatment, and these are the 4 drugs which are already an established in guideline. Now, when a patient get hospital, it is not important what drug he get. He should get all the drugs. Maybe in the lower dosage is a new concept. So these are conventional sequencing. You add one drug, another drug, third drug, fourth drug. But now the era is where we want rapid sequences as in other medical therapies. Here you add low doses of these drugs, initiate them, and then continue and titrate as tolerated. Now it's very important that patient should tolerate the medical therapy, and then you can up titrate. So a traditional sequencing may take 3 months, 6 months, but here it is one of a rapid sequences which is recommended. So there is no clinical trial till now to say that how you should titrate one first or another first, and those all are not truly evidence based. So this is one of a rapid guideline, rapid up titration which is done in a clinical trial where you have a high intensity care, where during hospitalization you start half optimal doses of 3 drugs. So definitely this is a whole trial where there is no ARNI, there is no SGLT2 inhibitor, there is no vericiguat, and these 3 drugs they are giving on before discharge half dose of all 3 drugs: spironolactone, ACE-ARB, and beta blocker. You call first week. Now in Western world it's a big problem because once the patient goes, they call after 2 month, 1 month appointment. The intensivist cardiologist will see, then another doctor will see, and they require good guideline. We are lucky that our patients are lucky because we see ourselves as a cardiologist. We only follow up and then we do titrate, and we are following this actually before this evidence came. In 6-8 years we are doing very rapid sequencing in all patients. We are starting 3 drugs on day 1, day 2 of a heart failure. But now Western world and guidelines require this clinical trial to say that this is the correct way to give a medical therapy to these patients. So second visit at 2 weeks, you see they are doing well. Creatinine is not going up. Potassium is checked. NT-proBNP. And if this is a safety visit. And by 3rd week, you are giving all full optimal doses. And this is based or inspired by cancer therapy. Now heart failure, you see event rate like is cancer, but it is treated as flu. But in cancer, if you detect cancer, the oncologist says, come next week, I'll give you 4 drugs and we will see, monitor for fever infection, we'll see whether you developed a side effect. So this is based on the concept that you add 4 drugs or add 3 drugs, step them up, and then see if the patient tolerate or not. So what has been seen in this, what you call is a high intensity, there is a significant reduction in the event rate. You can see this Kaplan-Meier curve, and what happens is that the trial needs to be stopped prematurely. As the control group, it is not ethical to continue the clinical trial, and this is a recent publication. And what has been seen, that rather than achieving full dose of 2 drugs, this one drug, if you achieve 1 drug complete 100% target dose, you use 2 drugs, you do better. For example, beta blocker and ACE-ARB or ARNI. If you give half of both, that is probably much better than full of only the 1 drug, and that is what is logical, and that is what we are practicing in diabetes, hypertension, as well as lipid lowering, that multiple drugs. And this is a meta-analysis or statistical analysis. The more drug you add, more is the benefit. So you have a multi-drug approach, and it's very good that if you add ARNI early, then patient tolerance of aldosterone antagonist is much more. If patients get beta blocker better, as they improve, the first patient who was not tolerating ARNI after 2 to 3 weeks is going to tolerate. So the concept now is not the one medical or this medicine, it is the polydrug therapy. And what you see that when you add any of the 4, you can see the event rates are going down. So in our patient, when there is a recent worsening, what is the clinical trial which Dr. Kirkar has told, and this is what is the the clinical trial will go Victoria, but if patient is already on 4 drugs, still there is a very high event rates. So quadruple 4, even if you give, the event rate is very high, and there is definitely need of a new therapy. And the drug which we are talking, vericiguat, it's what we call is work through the NO pathway. NO pathway we know since now 30 years. We are using nitrates, sildenafil, phosphodiesterase inhibitor, riociguat, and this group of drug. But this drug, what does new drug which we are talking, is only stimulating this old pathway. This old pathway is endothelial dysfunction and reduce nitrous oxide availability. The Vericiguat is a direct stimulator of soluble guanylyl cyclase and increases the cyclic GMP. By its action, it reduces heart inflammation, fibrosis, blood vessel vasodilatation, and improve the renal function. So Victoria trial with this drug includes symptomatic chronic heart failure patients with ejection fraction less than 45% on already on available standard drug. So you are already on standard drug, and then there is a worsening event. Now, if there is a worsening event, means now you have selected a population which is the event rate of almost 20 to 30% per annum. And if you see this, they are 67% population is one which is hospitalized within 3 months, 17% within 3 to 6 months. So these patients, there is no run-in period. When you use an RNA paradigm heart failure, you have to see they are tolerating or not. There is a run-in period, and then you select a population. Here, there is no run-in period, because one of the big advantage of this molecule is there is no or minimum hypotension. And what has it shown? It has shown definitely, as Dr. Kerkar has pointed out, that there is no mortality benefit, but there is a very significant reduction in the heart failure primary endpoint, which is heart failure hospitalization. But please understand, this is only 11 very sick population, and within 11 months you could prove. And if you see, analyze it, the number needed to treat is 24, which is almost equal to all other drugs. So all primary and secondary endpoint in this drug, definitely this drug is a comparison with placebo on a top of standard pharmacotherapy. When Victoria trial was done, there was no SGLT2 inhibitor. So what you could see, that the target dose achieved with Vericiguat is 90% as compared to placebo, hypotension, syncope as compared to placebo, and any major adverse event in this population occur. So there is no incremental, it's just like a placebo as far as side effects are concerned, but it is working well when you compare benefit. Now what is an advantage? No reduction, major reduction in a blood pressure. So when we put this data in a clinical context, what we see as compared to paradigm heart failure, DAPA-HF, and your Emperor reduced trial, here this trial has a high anti-pro-BNP. These are more sick patient, worsening heart failure, and 84% population is recent hospitalized, and so much more sicker population. And what you can see, the number needed to treat is almost equivalent to all pharmacotherapies. So number needed to treat is almost same. So now in our patient, which is having EGFR, the advantage of this drug would be no renal dysfunction. You did not monitor creatinine, potassium. So and this from the Victoria study, there are all 3 different GFR. The drug, they didn't have any significant worsening of renal function. The renal creatinine, GFR as well as potassium remains within the range. So no monitoring. Usually what in clinical practice, what we are doing, whenever I am up titrating beta blocker, ACE, ARB or RNA, we have to call every week, check pulse, BP or creatinine. Here we tell first strip of 14 tablets, second strip of 14 tablet, and third strip of 14 tablet, 2.5, 5 and 10 milligram every 2 weeks. So that is what we say is tolerability and compliance is much better. Though we say very good that we should take all drugs, but in real world only 1% population receives all 3, and this is the CHAMP heart failure registry from USA. And those who have many patients, we say that they should take RNA, they should take beta blocker, but under treatment is extremely common. And whether you are inpatient, whether they are outpatient, and we have to accept the fact that we will have to add more and more therapy, though maybe in little lower doses. So majority of patients, even though have a good blood pressure, what you see, that's an under treatment. Definitely there is a quality care issue, because we have fear, perceived fear, and Dr. Kerkar has already told, don't fear with RNA. But the truth is reflected in the statistics. The fear is so big, and that's not going to go away. So these patients are to be treated like a malignancy, where you have to use polydrug therapy. We have to treat them very aggressively and fast in that window period. And Vericiguat in this is an opportunity to improve the quality of pharmacotherapy. Now, if you see the retrospective database in Canada and USA, almost 40% to 90% of population of acute heart failure, they are eligible according to Victoria criteria. They are a possible candidate to improve their trajectory. Whether you have outpatient worsening, whether you have prior heart failure hospitalization or current recent event, you change the trajectory by Victoria by adding Verisogot. You can see this is the event rate. Once you add Verisogot, this is outpatient worsening. Patient in your OPD increasing diuretic need. This is a hospitalized patient, and you can see you are reducing moment you add Verisogot, you reduce the event rate. And so the stable heart failure or a low risk is a myth. An acute hospitalized patient, you have to go with an aggressive polydrug therapy. So potential risk of attempting GDMT is side effect and adverse effect, but definitely they are much less than any cancer chemotherapy. However, if you do not increase, their survival reduce, hospitalization, quality life of symptoms are reduced. So one of my colleague asked me that should I add Verisogut disease patient? So because there is no evidence. So adding a drug in is not a very difficult thing, because in cardiology we do many things. We don't think much. As a lesion is there, we are stenting the lesion and we do. But this is a irreversible therapy. It's not like a nuclear bomb. The Russian president says I'll throw nuclear bomb, but he doesn't do it because it cannot be retrieved. A drug therapy you should always initiate. If there is a problem, you can always withdraw that. Thank you. So this patient should be given a Verisogut. That's what is. Thank you.
From Yellow Corner, I would like to invite Dr. Brian Pinto for talk on iron.
I've lost my voice actually yesterday. Tried to sing a song, but came down with this bad cough and cold. Let me hope I can do you some justice. आज और इधर ये तो मैं भी प्रफुल्ल केतकर के जैसा ही बन जाएगा. So we're talking about acute decompensated heart failure. Now, I always tell my residents, when you talk about this, remember the word CHAMP. CHAMP means C for coronary, H for hypertension, A for arrhythmias, M for mechanical, and P for pulmonary. This is not really my talk. This is to teach people that when your patient goes into acute decompensated heart failure, you need to think of something why he has decompensated. And that's the way we go for it. Now, when we talk about this being a robust evidence, the robustness is never there because there's no money in it. Remember that. When you compared acute coronary syndromes and aspirin reduced mortality by 20% when you gave it in the 80s when we tried that. And what does ARNI do? It does very great things, yes, but it reduces mortality by 20%. That's great, that's wonderful. But how much talk about it depends upon the amount of money that is put into that. And who writes guidelines? Guidelines are written by people who sit in a room and not by people who work in the clinical scenario. So guidelines should be followed. Now I'm going to quote you one thing over here. Renato Lopez came one day and put up a slide. Said, read it. I read it. He said, class 1A guidelines, only 8% of them have 2 randomized trials in them. Only 8%. So who quotes them as class 1A? They are quoted as class 1A by people who sit in the guideline committee. This is very important to note. The second important thing to note is that they up titrate and down titrate depending upon what they want to do. And we have to look beyond them to really treat patients in manners that we want to do. Look at what India does. India does badly if the overall situation is there. But India does extremely well in cities where we give treatment beyond the guidelines, because we treat our patient just as Praveen Prave mentioned. I may start very squat in a patient. In this particular patient, 77-year-old patient, I may start very squat before the 4 pillars have been started, because I may not be able to implement one of the 4 pillars. Okay. But let me tell you, I will be able to start IV carboxymaltose in this patient without a problem. It will not cause any problem at all. And look at what is happening over here and what we are talking about. Now, you can see that they are affected at a younger age, and it affects the patient's quality of life and discharge. Now, really speaking, one of these very bright people, or 10 of these very bright people, must have sat down and told us about these pivotal issues. And what are the pivotal issues that they wanted to consider? Add and switch. And one chap whom I think in this particular whole space, whom I respect, is John Mackman. This guy gives you a little bit of insight because he's both a clinician as well as a guidelines man. And what he tells you is that if you insert all these therapies quickly, rapid sequencing, I'm not going to read all this stuff because this is for you all to read. I have to interpret it. If you use all this stuff quickly, and if you were to implement all this stuff quickly, you will increase the quantity and quality of your patient's life in heart failure by about 6.2 years. Now that is wonderful, because all of us used to say that heart failure with reduced ejection fraction, your patients are going to die, 50% of them are going to die in less than 5 years' time. Now there's a lot of comorbidities that we need to look with heart failure patients. All of you know this completely, that we're just not talking about heart failure. All your heart failure patients have some amount of renal dysfunction. Look at that lady. What was her EGFR? 32. You'd struggle with some of the GDMP therapies. The trials may say static, but suppose your creatinine bumps up and your urine output goes down, then you're in trouble. But it may improve also. So each patient has to be looked at very carefully. But I can say that my IV carboxymaltose can be given irrespective of the trial. You understand? And it will improve the quality of the life of the patient significantly. You can see that the evidence changes from each part, the association with heart failure and diabetes. What about kidney disease? Extremely strong association. What is the clinical evidence for modulating comorbidity? Extremely strong. Anemia, in fact, I will tell you one thing. I do serum iron studies and ferritin of all my patients. And you are doing them wrong if you are not doing that, because 75, I must be giving at least 6 to 8 iron therapies every week to patients. Because even those who have a 14-gram hemoglobin have low iron. And you know, you all can give me a few extra minutes, I think. You know, how much iron do you have in your body? You have only 5 grams as a male in your body, maximum of 5 grams in your body. And what does a female have? 3 grams, by and large. It's a very, very important nutrient. You cannot afford to do it. Do you know what is the kind of gain loss that happens in your body? 1 milligram per day. That's all. So this is an element that is not lost very easily, not gained very easily, and it needs to be protected, very heavily protected, and you cannot afford to make any mistakes on that. Why do Indians have a very low iron level? 2 reasons. One is their nutrition is poor, maybe vegetarianism and all that, but more importantly, they are big tea drinkers. Now, tea chelates iron, okay? Coffee does not. And orange juice improves your iron absorption. So if you want to improve your iron absorption around meals, then you use orange juice or have coffee, not tea. Now, if you want to have tea, don't have it with your meal. Have it 1 or 2 hours after your meal, 2 hours maybe. Now, you can see that country-wise iron deficiency is significant in the Indians. Look at the Singaporean Indians, 82% iron deficiency. So many people with iron deficiency. And if you check ourselves over here, I'll tell you the females, actually 90% of them, irrespective of heart failure, iron deficient. And males are also significantly. I give my acute coronary syndrome, my angioplasty patients, it changes their quality of life so significantly that they continue to remain with you only. They don't go to any other doctor. Because they're so happy with you, they're able to walk much better, they're able to exercise much better. And who is talking about only the quantity of life? Do you want quantity of life on a bed? Or you want quality of life? You want quality of life and quantity. Quality of life is extremely important. And this is the role, and this you must understand. Hepcidin. What is hepcidin? Hepcidin is a protect. Are awaaz mat kar. No awaaz. Hepcidin is a hormone that is used in the liver, that the liver uses so significantly that when you have an infection, you will reduce the absorption of the iron from your body to protect yourself. That means any infective process, hepcidin is produced, and hepcidin reduces the iron absorption at that time, and this becomes even so in chronic inflammatory states. So the importance of hepcidin is there to prevent infection, and unfortunately, when you have a chronic inflammatory state like heart failure also, your absorption is markedly because of this protective hormone that you have, which is called as hepcidin. Now, you can see that because of that, everywhere the iron is affected, but it is done so as a protective mechanism. Okay. So, what are the causes of this? You can see that by causing iron deficiency, you have so many other risks that happen. A reduced quality of life, increased risk of death, reduced exercise capacity, and besides that, it's a GI blood loss, malabsorption, malnutrition that causes all of this. So when you can see that, you can clearly see that the prognostic consequences of iron deficiency in heart failure are very significant. And I just want to tell you a couple of things. One is, the IV iron therapy does not improve you because it improves your hemoglobin immediately. What it does is that it is the powerhouse. The number of ATP molecules that are produced in your cell markedly go up immediately, and that increases your well-being. That's why IV iron therapy improves you almost immediately. And the recommendation for testing, and this recommendation was there long time back. It's a class 1C recommendation that you check with a full, and you do the serum ferritin and the TSAT. And one more thing over here, which is not related to this, you also check thyroid at the time of heart failure. TSH should be checked. Now, two things. Always get the ferritin done. Always get the TSAT done. Because you can see, what does transparent saturation tell you? It tells you basically the amount of available iron. Ferritin tells you the storehouse. So you come to know and when you see very high ferritin levels sometimes, don't get confused. It is because of inflammation. Suppose you see ferritin levels 1000, you'll see that in COVID. You'll see that in other inflamed status. So wait for the inflammation to settle, but TSAT will give you the clear dynamics. And very importantly to note, heart failure and iron deficiency symptoms are quite similar for similar patients. So this I'm not getting into. So you can see a great number of patients without anemia have iron deficiency, and this should be clearly noted. Iron deficiency remains an independent predictor of mortality in anemic and non-anemic patients. This has to be clearly understood and clearly, kind of matters. Now, iron matters for contractility. Remember that if you do not use iron, your contractility goes down by a significant amount, and therefore you will improve cell metabolism. You also improve all the cells in your body. It's also useful for your muscle cells. And clearly, intravenous iron is the way to go. None of the oral iron gets absorbed. It doesn't get tolerated. So don't try to give your patients oral iron. It makes no sense. The trials have shown that there have been no benefits with oral iron. The iron out study showed you that, and therefore oral supplementation does not help. I'm in the yellow corner because most of my recommendations, the guideline people have not sat over it adequately. Not because I'm in the yellow corner for my own self. If they had taken enough evidence-based stuff and they worked on it, they would have seen that the classes will improve with time. The level of evidence is A, but remember, when you say level of evidence is A, you have got adequate trials in place. Okay? And therefore, you must look beyond what you are looking. And please understand that your drip is so simple. Your carboxymide, I'm not going to talk about all sucrose and all those things because they're old. They're old-fashioned. You need to use a single dose, 1 gram usually, and you can do it not even without a drip. You can do it in a straight injection over 10 to 15 minutes, and you have this ability to do it. It's a great advantage, a great ability to do it, and we do it very frequently. All these trials have been there, and I think Stephen Anker has been at the head and the bottom of most of these trials, has been extremely good, and as Praful mentioned at last, we have the Affirm trial, the Affirm HF trial. The evidence, I think you need many more patients to really give you the data to suggest that this will be good. But clearly the beneficial effects are there, and you can see that how to give it, I'm not going to get into because most of you know. What I'll say is that you need to check it after 6 to 8 weeks again, and then look at it and decide whether you want to give another dose or not. From this trial, you can see that the ratio would be great. So for this particular patient, in spite of all the other pillars that you have utilized, please utilize the 5th pillar as well. Your patient will fare better with that. And in conclusion, I would say that only 1 or 2 injections, don't have to call every day, will benefit your patient significantly. And this is the first study where the iron supplementation in stabilized patients with heart failure really showed benefit. And it's not expensive. It's not expensive to give because it's not lifelong therapy. It's to be given in 1 or 2 doses. Thank you very much for your attention.
I would like to welcome Jayesh Rawal sir for his talk about SGLT2 inhibitors in ADHF.
Am I audible? Respected seniors and colleagues, very peculiar topic. 3-4 years ago, when marketing people told me about SGLT2 inhibitors, I was little apprehensive about glycosuric drug being helpful. And then over the past 3 years, mammoth data has come, and we are now using it as one of the main pillars of heart failure therapy. My talk will be addressed to acute heart failure. Dr. Kamal has pitched me in a very peculiar situation. Always Bombay speakers are very, strong enough to impart a good, and in that event, I am just a mellowed down speaker who is projecting myself from Ahmedabad and projecting to, Dr. Praful has been our teacher when we appeared for DM exams 25 years ago, and that's the thing that I have to match with those recommendations. And I'll just jump on to Dr. Praveen's 2 slides. One slide documented that Emperor trial gave number of needed to treat minimum as compared to other compared trials. That means that empagliflozin was significant enough. Number of patients to be treated for target was very minimal. And second slide he documented was about the first drug to be started in acute heart failure. The first drug he mentioned was SGLT2. no talk about acute heart failure can go down without telling you about precipitating factors. All of you know about that, and I'm not going to narrate all these things. We have to treat precipitating factors. Of course, Dr. Brian has narrated anemia as one of the cause, but apart from beyond anemia, he has documented a very nice presentation. SGLT2 inhibitors have been shown to be a wonderful drug for chronic heart failure irrespective of diabetes. They improve cardiovascular outcome, hospitalization rates, cardiovascular death, all-cause mortality. And this effect is beyond glucose lowering action. What we know about is a pleiotropic effect. This word came when ACE inhibitors were introduced into the market. And of course, SGLT2 has also pleiotropic effect, the effect beyond glucose reduction. There are direct actions on the myocardium, there are direct actions on the renal vasculature, there are direct actions on the systemic vasculature, but in nutshell, it is very much useful in heart failure. How do we see the impact on renal vasculature? That it reduces the SGLT2 receptor expression, it inhibits the NH3 expression, and that's how it reduces the sodium and water retention. Why we started using SGLT2 in heart failure? Because heart failure and diabetes, both of them have endothelial dysfunction, both of them have insulin resistance, and that's why we intended to use SGLT2. And when we started with SGLT2, diuretic effect, natriuresis, glycosuric effect were very nicely documented, but there are some other metabolic effects like increase in glucagon, increase in ketone bodies. Ketone bodies are energy source for myocardial cells. Now we concentrate ourselves to SGLT2 inhibitors, and here when the patient gets admitted with acute heart failure, our target is decongestion. And by decongestion, I mean to say that you need to wash out all the sodium and water which is retained. And there are some trials which are already ongoing, dictate AHF and EMPA response. I'll just narrate it. But how early we should start SGLT2 inhibitors? All of our concentration has gone into the most right panel where soloist WHF, EMPULSE trial, and the ongoing DAPA ACT HF TIMI68. Those three trials are to be talk of the time now. EMPULSE trial, Dr. Kelkar has already told that we have a very, it is fitting into all different scenarios. Chronic heart failure, but now we have to use empagliflozin in acute heart failure. The inclusion criteria included patients with acute heart failure irrespective of ejection fraction or diabetes. That means preserved ejection fraction is also one of the subset which will be targeted. Systolic blood pressure has to be greater than 100 millimeter of mercury, and there are no symptoms of postural symptoms of hypotension. There should be no increase in intravenous diuretic in last 6 hours time. There should be no IV vasodilators. There should be no IV inotropics, and of course documented heart failure by BNP or NT-proBNP. And the EMPULSE design has very categorically started empagliflozin very early in acute heart failure or admission. 3 days from the admission, they randomize the patients and look at the clinical benefit. The death was reduced significantly. Empagliflozin had a 4.2% reduction total death as compared to placebo, and quality of life heart failure event, the new heart failure event was also significantly less. Look at these graphs where probability of event starts separating. The graph started separating somewhere near 5 to 7 days, and the reduction in event, first heart failure event, was quite significantly seen over 90 to 100 days of study. So the net effect is that empagliflozin versus placebo, the acute decompensated heart failure was associated with significant clinical benefit, and that clinical benefit started as early as 15 days and was maintained beyond 90 days. So it is with fewer death, improved quality of life, and greater reduction in body weight. Now, this is one ongoing trial, dictate AHF trial. Diuretic response was being evaluated. Here, the empagliflozin has to be given, dapagliflozin has to be given early in, along with IV diuretics. And secondary endpoint was whether the patient still worsens over a period of time, or 30 days hospital readmission, or change in NT-proBNP to the untoward incident. The inclusion criteria are more or less same. Heart failure admission in last 24 hours, hypervolumic decompensated heart failure, and of course this trial was to evaluate no diabetic patients. So type 1 diabetes is excluded. The results are supposed to be coming in next April to October. Then the trial which Dr. Kelkar told you about is soloist. This is sotagliflozin. This is something different than SGLT2 inhibitor. It's a combined SGLT1 and SGLT2 inhibitor. And here the inclusion criteria included the heart failure patients on IV diuretics, stabilized off oxygen, and transition to oral diuretics were maintained. BNP was high. Type 2 diabetes was included. And of course, stage D and stage heart failure was excluded. Randomization started somewhere in early phase, and look, you can see that soloist sotagliflozin very clearly documented the benefit towards reduction in CV death, heart failure hospitalization, and urgent heart failure. And look at the lower panel. Lower panel very clearly says that you have the benefit, significant benefit seen as early as 28 days. So apart from SGLT2 inhibitor, a combined SGLT1 and SGLT2 inhibitor will also come on the horizon for our armamentarium. So soloist trial has very clearly seen that sotagliflozin significantly reduces the composite endpoint of total CV death, hospitalization, urgent heart failure visits, and benefit was consistent among all patients whether they were started on sotagliflozin before or afterwards, and heart failure with reduced or preserved ejection fraction. DAPA ACT HF trial still ongoing. I have already told you this has randomization on day 0 of acute heart failure. Guidelines have already incorporated. This is European guideline, of course, for chronic heart failure, where they have written 1A for dapagliflozin and empagliflozin. Then I would just draw your attention to last June, July, AHA journal, and this is the trial of MPEG-HF, where empagliflozin was used in the acute decompensated heart failure, and there you need to go for whether urine volume is increased or not. The randomization was within 12 hours of hospitalization. The color is different used here. So we gave empagliflozin within 12 hours of hospitalization. And you can see the better urine volume. The urine volume generated was very significantly higher over a period of day 5. And I would draw your attention that my patient had nausea. Kamal has nicely written down, nausea was there. Nausea can be because of hyponatremia. And I'm not worried about hyponatremia in presence of SGLT2. If I go on increasing the dose of torsemide or dose of furosemide, then probably hyponatremia will be very worrisome. While SGLT2 inhibitor will increase my urine volume, at the same time, you don't worry about hyponatremia. NT-proBNP very significantly reduces over a period of 5 days, and diuretic efficacy was stabilized after 3 days. Look at the last lowermost point. That shows that urine volume start decreasing after 3 days. So initial 2 days you wanted a orthopnic class 4 patients getting totally dry, and that is very effectively done by empagliflozin. Quality of life scores have also been very nicely seen. Look at the weight reduction. Acute heart failure, we are worried about weight reduction. We ask our resident a daily weight chart has to be maintained, and you can see empagliflozin reduces the weight very fast. Day 30, excellent reduction. Similarly, EGFR, Dr. Kamal has already narrated. We are dealing with a lady with high serum creatinine and low EGFR. In that event, ARNI, if I am starting on the first day or second day, already a patient in heart failure, low cardiac output, 100 systolic blood pressure, and we are dealing with a modest increase, say 20% increase in serum creatinine level over a period of 7 days with ARNI. So why to worry about those increase in serum creatinine level? And that's why my first choice will be SGLT2 inhibitor rather than ARNI in acute decompensated heart failure. The quality of life scores are already good with empagliflozin in early heart failure, acute heart failure hospitalization. Now, this is an old data, little old data where analysis showed that if your patient has a one index event of heart failure, the empagliflozin fares better. All 4 panels, the lower panel is without heart failure, and the upper panel is with one index heart failure. And look at all 4 graphs show a separation of 2 lines just before probably 5 days or 10 days. And that's where we need to involve. So by ARNI, as a very emphatically told to you, ARNI can be a class 1 indication, can be a very peculiar drug, but in my case scenario, with 100 systolic blood pressure, with eGFR of less than 35, I would really not tempted to use ARNI first. My first therapy would be SGLT2 inhibitor. And of course, my documentation will be further emphatically told by the clinical trials by the end of 2023. Thank you.
Very nice.
Thank you very much, all the speakers. It was a brilliant four-cornered or four-colored tug of war for this wonderful topic. A brief comment from physicians, all 4 of us, that many times we are facing a hostile situation of heart failure where the blood pressure is lower than 90 systolic, where I think we recommend to curtail certain drugs like nitrates, nicorandil, little bit of diuretics, settle them with ionotropes, and then we can use any pillars. So thank you very much, and the house is open for discussion. Again, because of constraint of time,
We'll take
I would
only
allow
two
one
questions
question.
only, 2 questions, and the sir would like to speak something about.
I wish I could have extended my talk on the quality of life with ARMY. I've shown a slide where ARMY is actually involved. What am I trying to tell you here? The KCC two scores, neither did we allude to. Both the PDM and quality of life. Okay. Yes, the guidelines are written by people with problems, with association with pharma industry, and then guidelines are not to be followed. Sorry, we are in an evidence-based scenario here. And the foundation pillar, that's why our man talks about, apart from CDM, the 4 foundational pillars, we didn't talk about beta blockers and environment, but quality of life improvement by KCC score. This is not the physician assessment. Patient is on a placebo and a comparative substance. And then maybe looking at and where one of them is sexual activity. And the highest score about improvement for sexual activity. That's what RP shows. That's one thing. The other thing I was going to talk about with HGLT2 inhibitors, they are only trying to create evidence. Reported trials, MPAG, HF and all, 60 pages. What are we talking about? We're talking about thousands of patients, and then we are coming to conclusion. So these are the 2 things. As far as Vericiguat is concerned, today even no guidelines, even the trialists themselves say that it is after GVMP that we would like to use it, after working last week. Like we talking about take evidence from soloist WHO, a trial conducted through Corona sponsorship gone, not even reached all its numbers, detect and take it out and take a molecule, take a trial which was in diabetics, not relevant to our patients, it's not a diabetic, all patients in general patient, we himself admitted HbA1c to 1 for HbA1c. Yes, about how to use RP, we are Indians backing on a difficult wicket, right? Yet we will win against the Australians. That's what it is. That's why I told the doctor, that he had created. So that is nice you take. And if I had gotten some more time of such level, army is still the winner.
So 4 pillars are 4 pillars. You need to choose them, there is no doubt. But then the situation that I gave, patient has nausea, patient has altered creatinine, he was on 4 therapies, now has got creatinine derange. He comes to you with an acute hospitalization. Remember, acute scenario in a chronic decompensated heart failure is different compared to an acute recent diagnosed first time hospitalized acute heart failure. So thing is that when you can't receive money in rupees, even dollars chalega. So so if you can't give ACE, ARNI, IRB, SGLT2, you have therapies like, and then make sure, as Dr. Brian pointed out, if you आप outpatient को बोलो कि तू जाके injectable IV FCM लेके आ, सर चलेगा, oral ले लूंगा, पालक की भाजी खा लूंगा. When he's hospitalized, that's the right time when you send him with IV FCM home. That's the only time that probably you, as he said, probably 1 dose. And Vericiguat is the one therapy that has now told us there is a new entity called acute decompensation of heart failure, where you need to think differently out of the box. That's why I say AI, robo, whatever comes in will not replace human brains, because you need an analytical thinking, because not every heart failure by the AI algorithm will tell you give ACE ARNI only or maybe SGLT2 only, but you'll have to choose if this situation was to change, decreasing creatinine, presence of UTI, dehydration, rising creatinine, nausea, and you'll have other therapies. But again, patient had discontinued GDMT, 3 days, that was again in the history. So we don't know, we have to restart. So ideally, रुपया भी चलेगा, डॉलर भी चलेगा, पाकिस्तानी रुपया गिर गया तो वो भी चलेगा. तो थोड़ा थोड़ा सब कुछ ले लो.
That I have a point to make, which I think is very significant. See, you shouldn't get stuck with these pillars. Okay? These pillars are great, but this is a different patient. This patient is away from these pillars also. After the, not to restart the beginning, restart. But here's the situation where very square. Could be started even before one of starting the other ones, because if the no, I'm not saying intolerance is not, but intolerance could be, may not be, but could be. So you have to keep your mind more open that you want to save your patient's life. So you use the pillars, of course, but don't get stuck on pillars. Use the Vericiguat also, use the IV carboxymaltose also. Bring that in. That may allow your patient, because your patient is vomiting, you may have to wait a couple of days to give IV carboxymaltose, because at some point in time you realize that when you start IV carboxymaltose, your patient should not have a high WBC count, your patient should not have a pulmonary infection. So you don't want to give IV carboxymaltose when your patient is infected. So it's not like this patient could receive IV carboxymaltose. You have to check so many other things. And I have a suggestion that it doesn't mean just because the trial of Victoria used Vericiguat after the 4 GDMP, that in every patient that should be the way we go. There will be situations where we can use Vericiguat before we take on all the 4 pillars. That's the point. Not that.
So I think all therapies for this.
We agree that all 4 drugs need to come on board, but don't lose the focus out here. Is what I'm trying to tell you. IV iron, yes, life matters. You add life to us, not just right. That is important. It is always all patients, class 1, yes, look for iron, give iron. All that is fine. But in this, that's fine. IV iron and they are not partnership pillars. But if you can't use the partnership pillars, the plant won't make the
So you can, there are some architects who can put the planks first ahead of the pillars. So all you need is the planks as well as pillars. That's the crux of the message. Yeah, Dr. Kale, closing comment.
Yeah. So basically, what I was telling, that you add Vericiguat, you are not married to it. If you reach the full doses of all 4 drugs, you can always withdraw it.
So thank you very much. Thank you all the panelists. Thank you. We have this question. All the following are correctly matched for the trials in heart failure, acute heart failure. That was the question. The answer, next. is deliver. Deliver is not in chronic. It's not in HFrEF. It's an FPEF. Next slide. Next slide. That's the reference. Next. So we have next bout, very interesting one, and we have diabetes and heart failure. Now, dapagliflozin, empagliflozin, remogliflozin, 3 flozins we have. I invite our chairpersons, Dr. Asha Shah, Dr. Raghu Satyanarayan, Dr. Dhaval Doshi, Dr. Badlani, Dr. Manish Agrawal, Dr. Pragneshwara, Dr. Devendra Singh Jhala, to introduce a very interesting fight in heart failure.
Dr. Rajesh Shah, you are invited as a observer, MCI's observer.
Dr. GMC Observer. GMC Observer, Dr. Rajesh Shah, welcome. We have, GMC has granted us 4 credit hours for each day, which is 8 credit hours, which is probably one of the highest to have for a conference, which is just of 2 days in this kind of a format. Because remember, Epicon got 13 credit hours for 5 days of conference in 6 halls. We got in 2 halls, 2 days, 1 virtual, and we've got 8 credit hours. Thank you very much. Okay, ma'am. Just left.
Okay, good afternoon all, and I thank Dr. Kamal Sharma for giving me the opportunity to be here with all of you. And as we know, the nice debates and fights are going on, which is more enjoyable than the lecture itself. So this also is a scenario of which is the preferred gliflozin to be used in heart failure. For the first talk, I would like to invite Dr. Bansi Sabu, and I don't think the audience needs the introduction for Bansi, because he is the most dynamic diabetologist and conference organizer. He recently organized Epicon very successfully, and I also had, I can say I had the privilege that I was his PT teacher, and I'm very proud to see what he is doing now.
Thank you, madam. Thank you for your kind words. I always feel very privileged that when madam is chairing this session. Thanks, Kamal, for giving me talk. It's a debate. We are 3 of us are here.
I think I'll have to, excuse me, I'll just read.
Oh yes, sure, please. I'm sorry for that.
So here, 55 kilo Indian male on optimal cardiac medication has diabetes with an A1C of 8.2 and with a BMI of 25.5. Indian should have a BMI of 23. This gentleman is 25.5. The LVEF is 45% and on eco, and he has a history of CABG 2 years ago. He is on which should be the best SGLT2 inhibitor. So we have 3 speakers. One is going to speak on dapagliflozin, the other one on EMPA, and the third one on Remo. So we have to choose between the 3. Over to Dr.
Thank you, Chairperson. I will request AV guy again to make it again 10 minutes because it's already 50 seconds gone. Thank you. So, thanks, Chairperson. Thanks, moderators. Thank you, Kamal, for giving me an opportunity. Thanks, the scientific committee. So, we are 3 who are going to talk on DAPA, EMPA, and Remo. I don't know whether Remo will be really in the debates. I doubt. So I'm sorry, Jayesh, why they've been given to you. EMPA, yes. Many kings are going to Sanjeev Pathak only. All Ahmedabadis king go to only Sanjeev, so he can afford to write EMPA. But I will show the scientific evidence. We will not talk anything related to the other than science. The commerce will not come here. But yes, it is commerce is there because this is supported by AstraZeneca. DAPA is a preferred SGLT2 in treatment of heart failure. And again, Dr. Raghu had talked about the case. So please, the case is very important with a BMI of 25.5, having a history of CABG 2 years back with ejection fraction of 45%. This patient is having A1C of 8.2. The further investigations required or information required, definitely we would like to know about the EGFR, and I'm sure EGFR is normal. Is this patient is with improved ejection fraction? Now that's very important because this is not the history of 45% ejection fraction. I don't know whether previously patient was with a 30 ejection fraction and now he had come with a 45 or whether patient was 55 ejection fraction and gone down to 45. Is the patient is hospitalized? I mean, patient is asymptomatic and he was already in hospital where patient is being asked by me that whether I should start the treatment or not. So I don't know whether patient is hospitalized or not, and I don't know whether it is ambulatory, no symptoms. So these are the some of the things which I don't know, and I believe that patient is ambulatory, patient is having stable ejection fraction, and EGFR is normal. So my further talk will be depending on that information. The European Society of Cardiologists, the diagnostic criteria for heart failure is the reduced ejection fraction is less than 40. That's important. With a moderate reduced ejection fraction is between 41 to 49, and with preserved ejection fraction is more than 50%. I'm sure all of you know about that. This is the European Society of Cardiology diagnostic criteria for heart failure category, and my patients come with this particular group with a moderate reduced ejection fraction between 41 to 49. We know that a patient may go between moderate reduced ejection fraction to preserved ejection fraction or to reduced ejection fraction depending on the comorbid condition. If a patient with diabetes, ischemic heart disease, high pro-BNP, lack of heart failure specialist is not going to a particular specialist, there is a possibility a patient with 45 ejection fraction might be going in 25 too. For those who are young age, female are more chances of getting improvement, lower heart failure severity, shorter duration of heart failure, and fewer comorbidities. Probably a patient with moderate ejection fraction may go to the preserved ejection fraction too. What's the guideline is talking about? This is 2022 American Heart Association, which is supported by ACC and all other associations in all over the world. The stage A, those who are at the risk of heart failure, and just before somebody was talking about the acute heart failure, what GDMT is, guideline directed medical therapy is talking that SGLT2 is the class 1. If somebody is a pre-heart failure condition, again SGLT2 inhibitor is there. In stage C and D with a ejection fraction of less than 40%, even it is between 41 to 49 and more than 50, these are the two conditions where it is class 2A indication, while otherwise when it is a reduced ejection fraction less than 40%, it is definitely with SGLT2. But my patient is with 45 with SGLT2 inhibitor goes with class 2A along with other therapies of heart failure. The same guideline is talking when it's a symptomatic, definitely again the SGLT2 inhibitor, even when the patient ejection fraction is between 41 to 49. That is what 2A, and the level of evidence with this we have randomized control as well as non-randomized control. Both have 2A and 2B evidence for the patients who should be on SGLT2 inhibitor. Now, this is very clear, and I am sure since last so many years, we all know that SGLT2 inhibitor should be given with a patient with established cardiovascular disease. And after the heart failure trial, it has been proved that SGLT2 inhibitor should be given irrespective of diabetes. They should be given all the patients with heart failure with preserved ejection fraction. Also, now there are data. Now here the debate is which SGLT2 inhibitor. And again, I'm sorry that I'm not putting here REMO. I'm putting directly DAPA versus EMPA because of the evidence what we have. The DELIVER, the largest, broadest trial to date in patient with LV ejection fraction of more than 40%. This is the recently published trial in 2022. The DELIVER having the number of patient was 6,263. Randomized DAPA 10 versus placebo, median follow-up of 2.3 years. The primary endpoint was composite of CV death, worsening heart failure, full patient population, and patient ejection fraction was less than 60%. And the baseline characteristic was around 54%. Average LVF with 50% of the patients were less than 60 ml of EGFR, and 10% of the patient hospitalized or recently discharged. There are other secondary endpoints which include CV death and all-cause mortality. Now, primary endpoint, there is a 18% relative risk reduction. That's very important. DAPA significantly reduced the risk of CV death or worsening in patients with LV ejection fraction of more than 40%. And again, as I told you, that my patient having ejection fraction of 45%, and you can see the difference from the day one, and NNT is 32. So DAPA 10 versus placebo, the composite CV death or worsening heart failure was significantly reduced by 18% relative risk reduction. If you see the primary endpoint in full population with LV ejection fraction of less than 60, again my patient goes in that because its ejection fraction is 45%, the HR is 0.8. And you can see very significant p-value of 0.0008. The LV ejection fraction of less than 60%, Again, further the HR is 0.83 with p value is 0.009, which is again very significant. So dual primary analysis. The outcome of LV ejection fraction of less than 60 or even with more than 60. Now here I am putting the patient because we don't know that this patient had gone from 65 to 45. So even at any level, you put the patient with our preserved ejection fraction or with the patients who are moderately preserved ejection fraction, both the condition, the primary composite, you can see here all three, the patient with ejection fraction of less than 60, more than 60, all of them are getting benefit for worsening heart failure event, hospitalization for heart failure, CV death and all cause death, all of them got benefit. The primary endpoint in a pre-specified subgroups, again I am putting the LV ejection fraction between 40 to 49 and even more than 60 also, they also get the benefit. Enrolled during or within 60 days, within 30 days of hospitalization of heart failure, again there was a benefit. Yes, it was more and improved ejection fraction patients with the ejection fraction of less than 40, they improved, they also got the benefit, the favoring the dapagliflozin in this particular trial. If you put the secondary endpoint, which is KCCQ total symptom score, and you can see here there was a significant benefit with the patients who are put on a DAPA in compared to the placebo, whether you go with a 5+ improvement, 10+ improvement or 15+ improvement. Now let us look at EMPA data because this is a debate and I have to show EMPA data with Sanjeev Bhai is going to show you more. This is the Emperor Preserved trial and study design, which is a phase 3. He will be talking more about it. The LV ejection fraction of these patients was more than 40. Effect of EMPA versus placebo, primary and secondary outcome. Please just see this, and I am going to show you the pool data only. The results of key endpoints in the subgroup of the patient with preserved ejection fraction. Yes, there was a benefit. SGLT2 inhibitor is going to have the benefit. The same may be shown by the REMO also, but I have to show the data between DAPA and EMPA. And here I am going to show what the pooled analysis suggests. The Emperor Preserved, when I am comparing directly with DAPA heart failure and deliver, if I combine both, it is more than 11,000 patients with heart failure with moderately reduced ejection fraction. And you can see in DAPA heart failure, there was a 14% relative risk reduction of the patients who have moderate ejection fraction. CV death, all-cause mortality, first heart failure, total hospitalization for heart failure. And if I put Emperor pool data, ejection fraction influence the effect of EMPA on a heart failure and renal outcome, you will find the patients between 40 to 50, 50 to 60 and 60 to above. And the similar way the renal outcome, the Emperor reduced and Emperor preserved. Effect of EMPA, time to cardiovascular death, it is Emperor preserved was 0.9. So no benefit of CV death with EMPA even in a pool analysis if I put the Emperor reduced and Emperor preserved both the data together. What about patient future risk? There is always a possibility this patient may go in hospitalization for heart failure, for CKD is already with the 45% ejection fraction, post CABG diabetic patient who is uncontrolled. So they have to see the data with the what about the CKD status, how it is going to show the benefit, the molecule which we are going to write to this patient, whether it is going to halt the progression of CKD status also. Here the data for a DAPA CKD, which is also talking the patient who are started on DAPA, there is a 44% relative risk reduction in composite outcome of sustained decrease in more than 50% of eGFR decline, end-stage kidney disease and with renal death. So if I put that EMPA kidney reinforce the SGLT2, yes, there is a EMPA kidney outcome. Also the primary endpoint both, but all-cause death and composite CV death for hospitalization for heart failure was not there in EMPA kidney. It was only with DAPA CKD2. So last slide, the DAPA is ahead of EMPA in various parameters. The clinical parameter, glycemic control, almost same. But the new onset of diabetes was relative risk reduction by DAPA, all-cause mortality in CKD and CV death and hospitalization for heart failure in CKD, again beneficial with DAPA, and hospitalization for heart failure in primary prevention and CV death in a reduced ejection fraction was also significantly reduced, which was not studied even with the EMPA2. So with this, I put the case that yes, still you can use any SGLT2 inhibitor, but the data which is shown in the benefit with the DAPA heart failure, with deliver and with DAPA CKD, with this patient with a 45 to 45% of ejection fraction, it goes more in the favor of the molecule which have more scientific evidence in compared to EMPA. Thank you very much.
Now I would like to call Dr. Sanjeev Phatak who will speak on empagliflozin is a preferred agent, particularly in this patient.
Good afternoon and thank you, Dr. Kamal, Cardiocon, and the organizers, and thank you, Bansi. One of the slides, not one, a couple of your slides on the bottom showed that dapagliflozin is not approved for preserved and mildly reduced ejection fraction. Of course, it is, but that was your slide. And Bansi, being the strongest lawyer for the SGLT2 inhibitors like Ram Jethmalani, but I have got the strongest candidate, that is Amitabh Bachchan or empagliflozin. So he fought for Vinod Khanna. I am reminded of the 1970s and 80s when the Amitabh Bachchan Vinod Khanna war was getting on, and then suddenly Mithun Chakrabarti came, poor man's Amitabh Bachchan, remogliflozin. So I know that Ram Jethmalani is there against me, Saurabhji is there against me, the two biggest lawyers of our country, and I'm a very small lawyer compared to them, but I am going to speak in favor of Amitabh Bachchan, that is empagliflozin, the Amitabh Bachchan of SGLT2. Let us start with this case. So first, I have a heartfelt sympathy because they are fighting for a losing cause. The 55-year-old gentleman, he's obese because his BMI is 25, though he's 55. So he must be short. He's having uncontrolled diabetes. He has past history of CABG. His ejection fraction is mid-range, 45%. He is on GDMT and lifestyle, which SGLT2 obviously empagliflozin. Why? What are our aims of management? First, of course, glycemic control. He has come to a diabetologist. Second, maybe he's overweight, BMI is 25 plus, so some weight loss. Prevent future cardiovascular events. He already is having cardiovascular event. He had ASCVD and has undergone CABG. To prevent heart failure progression and to reduce mortality. Now let us talk about the glycemic control. Bansi never showed any glycemic control. He deliberately omitted diabetes. He put diabetes out of equation as if the patient is not diabetes. We know that dapagliflozin's data, like the heart failure data or CKD data, is regardless of diabetes. In diabetes, dapagliflozin has mainly principally one trial, that is DECLARE-TIMI, and it is a negative trial, we all know, as far as the cardiovascular 3-point MACE is concerned or cardiovascular death is concerned. What about glycemic efficacy? I could find only one trial which compared EMPA versus DEPA, and it clearly showed that HbA1c, fasting, weight, systolic blood pressure, everything was better with EMPA compared to DEPA. Comparing EMPA and REMO, there is no trial, but comparing DEPA and REMO, there was an Indian trial submitted for DCGI, and which showed that DEPA and REMO are equally effective. REMO is non-inferior, which proves that EMPA is definitely superior as far as efficacy is concerned compared to DEPA and remogliflozin. Now coming on to the cardiovascular events. We know that EMPA-REG is the benchmark or the most important trial which changed the way we treat type 2 diabetes. We don't treat just from the glucose numbers. We treat to prevent the cardiovascular events, and in this trial, very robust cardiovascular death benefit was observed, and it is an unbiased totally observation which all of us know. And this was regarding all the categories of cardiovascular death, whether the death from fatal MI, fatal stroke, heart failure related death, sudden death, everything was prevented, and that was also regardless of what type of CAD the patient was having. In this patient, we have priority to CABG and prior heart failure, LV ejection fraction being 45%. And in both these conditions, EMPA has clearly shown the benefit. We know the cardiovascular outcomes of all the cardiovascular, the SGLT2 inhibitors, and EMPA is the only drug which has shown 3-point MACE benefit, 4-point MACE benefit, CV death benefit, heart failure benefit in diabetic patient. Right now, we are talking about our patient who is having diabetes. He is not without diabetes. And the comparison is very, very clear. 3P MACE, CV death, all-cause death, significantly reduced with EMPA, nothing, no benefit with dapagliflozin. And that is why EMPA became the only SGLT inhibitor to be officially recommended to reduce the risk of death in diabetic patients with established cardiovascular disease. How about our Indian or Asian patient? You can see that the Asian patients actually benefit more. This data from the EMPA-REG clearly showed that the benefit was more compared to the other population. And if the BMI is less than 30, again the benefit is more. Our patient is having BMI of less than 30. So in both these conditions, the benefit of empagliflozin is very, very proven. So that is why this is the first drug that is approved. Now let us talk outside the EMPA-REG, and this is the analysis of 7 phase 3 big studies, in which also showed that 4-point MACE, 3-point MACE, CV death, heart failure, everything is positively influenced by empagliflozin. How about heart failure? Bansi mainly talked about heart failure. He forgot or deliberately forgot diabetes. And in heart failure also, emperor reduced, emperor preserved. All these trials have shown very good reduction in the heart failure hospitalization and composite CV death. Why DEPA showed more benefit? The probable reason was that the DEPA treated patients were not treated to the guideline directed medical therapy. Only about 10% patients were on ARNI, only about 7% patients were on CRTUs, only about 26% were on ICDUs, whereas in emperor reduced, many more patients were treated with the more aggressive or the current therapies, and that is why the benefit observed was on top of that was less than what was seen in the DEPA-HF trial. Otherwise, there is hardly any reason to compare these two trials. But in the nutshell, I would say that in the declared TIMI and in the EMPA-REG outcome, it is very clear that the first hospitalization for heart failure in patients with myocardial infarction or cardiovascular events is very, very significantly benefited with empagliflozin and not with dapagliflozin. Both reduced and preserved ejection fraction, EMPA has shown benefit. Both in mid-range ejection fraction and preserved ejection fraction, the empagliflozin emperor studies have shown benefit. So this is regardless of the ejection fraction, this is regardless of presence or absence of diabetes, but we are right now talking about diabetic patient where the benefit is definitely seen only with empagliflozin. The other benefits again are there with the other gliflozins also, but not proven to that extent, like the kidney composite outcomes, the effect on the blood pressure, the effect on the obstructive sleep apnea. All this may be there in this obese patient who may be centrally obese because his BMI is 25. He is a short person because at weight of 55. So he might be having the other comorbidities which may be benefited more with empagliflozin because EMPA has stronger data. Even in the NFLD, EMPA has stronger data compared to dapagliflozin. He was talking about the cost. Well, when you are choosing Vinod Khanna, he will be available at a lower cost. Vindhu Chakravarti at much lower cost. Empagliflozin slightly more expensive, but if you compare the cost, there is hardly any difference. And we Indians are very innovative. We doctors are no exception. The cost of therapy can be made half with half dose of empagliflozin. You just cut the tablet. And even the half dose will deliver you very good benefit as far as the A1C reduction is concerned or cardiovascular benefit is concerned. EMPRISE, EMPA-REG, Emperor Preserved are all with 10 and 25 milligram. That is why the benefit of EMPA is there with both 10 and 25, which is not there with dapagliflozin. So to compare in a slide, EMPA, DEPA and REMO, I'll just finish. You can see that there are more pluses on EMPA side, whether it is glycemic control, weight loss, cardiovascular events, benefit in diabetic patients, reducing the mortality, heart failure may be equal, sleep apnea, the selectivity towards the SGLT1, SGLT2, 2500 times with EMPA compared to DEPA. So mechanistically also there is a great difference. And there is no negative thing to that. DEPA initially was rejected by FDA for the reasons we know. Moreover, there was initially warning of kidney injury, bladder cancer. EMPA has not shown any such warning. So safest. So I'll show you, I have got 3 medicines. One is remogliflozin, which is cheap, but does not have any cardiovascular, any renal benefit. Maybe there, but at present nothing is known. Second is DEPA, which is good for heart failure. It is good for diabetes, but diabetes plus cardiovascular disease, probably not, because the only trial which we have has not shown any cardiovascular benefit. And the third drug is EMPA, which is 10 rupees more costlier than the DEPA and REMO, but has significant cardiovascular benefit, significant death benefit. So which drug you will choose? Obviously, the patient would not mind spending 10 rupees more. Spending somewhat more for Amitabh Bachchan, definitely the directors would say more affordable than spending less with the other actors. So where is the competition? Is there any comparison? EMPA is a clear winner. Thank you very much for your very kind order.
No, no. I would say the the fight has become really interesting with each candidate justifying their points, and in between the two big drugs with so many trials, now Dr. Jayesh Prajapati has to talk on remogliflozin, but we can see it is written that it is in Indian setup for his talk. So maybe the data and the drug usability is more in the Indian setup. Let us see what Dr. Jayesh has to say.
Good noon, madam, and all the chairperson and my friends and those who are on the attending this CM. I would like to thank the Kamal and organizing PV opportunity. I want to all the diabetologists are sitting here. I am the cardiologist talking on this topic because of Kamal, and he has given a topic like that. I have to fight. So of course, the Bansi has rightly told, and Dr. Phatak has also rightly told, but they have not shown one slide the conflict of interest. Both are studying the molecule of mind, and they are taking BR ahead. One thing is that I'm like underage, those who are getting the MBBS admission, but they cannot attend the college. So I'm like a tortoise in between these two rabbits. So I'm just starting my first step ahead. And of course, I want to say that I'm a human being living in the same world where the American and European are living. So I will try that I'm also a human being. And probably and Dr. Bansi and Dr. Phatak after 5 years will going to talk on remogliflozin, because this molecule will be on the lower side, and this might be growing one. Of course, Kamal has given me one thing in the diabetic population. So that's the one thing, so I can talk on remogliflozin somewhat. So we know that India is a diabetes capital and all these things, and these are the mechanism I don't want to discuss. And these are the SGLT2. These are, everyone agree that it's a class effect. So when we discuss the EMPA, CANA, no one has talked CANA. CANA has also got a good data. So why CANA was not here? So it's a class effect, like of course sotagliflozin, ertugliflozin, and people say SGLT2 inhibitor. So some molecule will require data for this one. So this is the Asian, I think Japanese molecule, and started studying in, taken over by Indian company, and they have started this. So SGLT2 inhibitors are now recommended for almost all the indications for diabetic, non-diabetic, heart failure, kidney protection, and all. So these are some of the study. Of course, Remo is not like they have not got any study. They have got a phase 3 study, and of course this is all Indian data, I can say, and they have studied the randomized blind control, and they have compared with a molecule. Of course, it is very difficult. We have not seen any atorvastatin, rosuvastatin hard endpoint data. So it is very difficult to compare all this. Even we have not seen head-to-head comparison between EMPA, CANA, and DEPA. All our data, they are individual compared with the other placebo arm. So there is no head-to-head comparison. So I cannot compare Remo with DEPA and all this. But the Indian company, they tried to compare with a DEPA also and CANA also, and they have tried to collect the data. And these are our Indian doctors, they have studied. Whether we believe or not, that we have to decide. So it's a double-blind study. The comparative arm of DEPA 10 milligram versus Remo, around 900 patients has been studied. 58 sites were studied. And of course, we cannot compare, as we know that atorvastatin and rosuvastatin, we have got only comparative efficacy. So they have tried to do the comparative efficacy, because for hard endpoint reduction, we require a very good study with so many patients, and that is a problem in our country, that almost we know that. So here they have tried to compare the molecule efficacy, compare with a DEPA and of course CANA and all that I am going to show. So here they have shown with a DEPA also the HbA1c level and week 24 and week after fasting. Of course, this molecule, one should not forget, Remo is to be given twice a day. So twice a day is advantageous. Why? That also I am going to discuss. So they have studied the postprandial. We Indians, we are facing more of the postprandial hyperglycemia because of our high carbohydrate meal. Another study, and they have shown the comparative efficacy between versus DEPA versus Remo. The INSPIRE study also, that's the Indian study, and that is assessment of safety and effectiveness of this molecule. And this was around 37,000 patients were studied, and 3-month data was completed, and they have showed HbA1c, fasting glucose, postprandial glucose reduction that was much more with remogliflozin, And the same kind of SGLT2 inhibitor effect, like body weight, systolic blood pressure, diastolic blood pressure, and everything. Another study was done, the forever study, that was compared between the remogliflozin and Vilda, compared with the established molecule like EMPA with a Lina. So that kind of combination was they have studied in around, of course, this is a small study, around 180 patients. Indian patients were studied in 58 sites across the India, and it has shown the same efficacy and same adverse effect with this molecule. Another study was done in the glycemic variability study. Of course, this is around 75 patient study, but it has shown that why it was done. So it's a start study based on a start study where I think Bansi and so many were of this start study. Indian patient, they are consuming more carbohydrates. Even the patient is a diabetic or the non-diabetic. And this group of patients, they have got a more postprandial hyperglycemia. So that what we are not talking on this podium. So the dietary habits of type 2 diabetes, that's what I have told. Non-diabetic, diabetic, we are consuming more carbohydrates. That's a problem in our country. So here they have studied the glycemic variability, and they have applied a patch, and these patients were given the one arm was Remo, one was DEPA, and two phase, day 1 to 14 and 36 to 49. And what they have found that compared to the DAPA and Remo, the Remo has got a good effect on postprandial high glucose level. So what they have studied, and they have concluded that the more reduction seen in Remo compared to the DAPA, especially at the night time. So twice a day doses of remogliflozin compared to all other SGLT2 inhibitors, which are once a day, it is efficacious to reduce such kind of peak in sugar level. So this is one of the advantages of remogliflozin, and that probably will be a weapon to fight against this DAPA and empagliflozin. So it has shown that, of course, almost the same efficacy in HbA1c and all, but postprandial hyperglycemia that was prevented by this remogliflozin, and that is advantageous for our Indian patient. This is a Revolution study, that interim analysis, where I think Dr. Bansi and Dr. Patak both have enrolled the patient in this study. So Revolution was also studied. This is also ongoing study, 365 patients, and it has shown that almost some part has been completed, and it has shown that Remo 100 milligram, Remo plus metformin 500, and Remo 500 plus 1000, it has shown efficacy for reducing the HbA1c, fasting, and all postprandial sugar level. Of course, with 500 milligram is also 500 plus 100 is good efficacious dose they have shown. And adverse event are at par with DAPA and all what we can say. Another study has been done, that a comparative study of efficacy and safety of different SGLT2, and this is also EMPA, DAPA, CANA, and all they have compared, and they have shown efficacy for systolic blood pressure, diastolic blood pressure, and all these things, and it was found to be almost comparative to the other molecule. So these are some of the data they have tried to collect it, Forever, Inspire, Revolution, and phase 3 and GV study, and they have shown that this molecule is efficacious. Of course, I have told that to her hard endpoint like diabetic, non-diabetic, kidney patients, and heart failure patients, preserved ejection fraction, acute MI, but they are aid. They are American, and they are like that. We are Indians, so we are behind, but probably we will win in the future also. So I want to tell that among all oral anti-diabetic drug, SGLT2 has an advantage. Of course, it has some pleiotropic effect that is to be proven by this molecule, and it is demonstrated the safety and efficacy compared to the other gliflozin also requires more data, but the Indians, they have got a higher postprandial glucose level, so that is one of the advantages of the Remo. And of course, some of the negative points I have told that, and clinical evidence is limited to Indian patients. Whether the company wants to try the global study, I'm not sure. Probably Dr. Bansi and Phatak will highlight this topic. A limited study on larger and heterogeneous group of patients will be required with this molecule, and probably head-to-head comparison is very difficult, but limited data, I can see that this molecule is not bad. Thank you. Thank you so much.
So, questions from the audience to any of the speakers?
No, Jayesh bhai, it was not pure diabetology case. I gave you mid-range ejection fraction, heart failure with mid-range ejection fraction. otherwise તો આપણું કામ જ થતું. They would say કે આમાં કાર્ડિયોલોજીની કોન્ફરન્સમાં ડાયાબિટોલોજીનો કેસ કેમ રાખ્યો? So but all cardiovascular diseases, if you have diabetes, especially more than 10 years, is a cardiac patient, practically speaking. If you have type 2 diabetes, we know that from Indian data, we know that from a lot of patients. CT angio studies done from Chennai. In Asian Indians, 70 to 80% of diabetics for more than 10 years would have coronary calcium score more than 100, which is a predictor of event rate of more than 10 to 20% in next 5 years. So that's why you need to intervene early. And then I kept mid-range ejection fraction because that's the gray zone. Because you can have data on preserved ejection fraction, reduced ejection fraction. None of the molecule has a strong data on mid-range ejection fraction. So his EF was 45%. And of course, as you correctly mentioned, I, Bansi Bhai, even Sanjeev Bhai are co-investigators in Revolution study, which is our disclosure, which we are doing with remogliflozin. But my question to both the speakers, Jayesh Bhai has already spoken his part, Bansi Bhai and Sanjeev Bhai, mid-range ejection fraction. Do we have data?
But is really Remo is indicated in this type of patients?
So diabetes, yes. Revolution study included heart failure patients, yes. And the outcome, draft is ready. It is lying in my email, Bansi Bhai's email. We have to approve and send it for publication. Interim data, I think we are here to publish it. I cannot speak more than that. The interim data is lying in our email as a Word file. I'll not be able to speak about the data before it. I think, Sanjeev Bhai, you are also investigator with that, and I think we all need to approve that. So it's pending, but if you ask me, can we treat diabetes? Yes. Heart failure overt? Probably no, but again, remember, even in Vertis CV trial, which was done with sotagliflozin, exact duplicate copy of EMPA-REG outcome, mortality was not reduced, but heart failure was reduced. So heart failure reduction is a class effect. There is no doubt about it. So probably it should work for remogliflozin.
Why you have not kept Cana instead of Remo?
So Cana, firstly, cost is not coming down. Number two, we know data from Canvas. What's the problem? You don't have mortality reduction. You had a patient last year, if you go through our debate, Canvas kind of scenario I tried to create, only SGLT2 which has some signal towards stroke reduction. Stroke reduction. If you look at the odds ratio, forest plot, everywhere on all other SGLT2, there is a trend towards increasing stroke. Cana, there is trend towards decreasing stroke. Both the subgroups not reaching statistical significance. Otherwise, heart failure, again, class effect. Why Cana has fallen in volume? Because we don't have data as robust as mortality reduction.
Well, I just want to make one comment on what you talked about. That a patient with a 10 years of diabetes, the patient of cardiologist. We believe that even the day diabetes is detected, patient is cardiologist.
But mokalta nothing, sir.
That is what just let me finish. What we physician have to do, that patient should not reach to you. And that's our duty. We are preventive cardiologists. Now we don't have any preventive cardiologists really practicing who are all our interventional cardiologists. So we have to make sure that our patient should not go to it and they should not reach to you. We want our patient, the worst part is here, even after post CABG, this patient sugar is not controlled. And there I feel responsibility of a physician. We could not achieve the target A1C. Even this patient was gone for CABG, and now we are discussing who will decrease the status and hospitalization for heart failure. We are forgetting that this patient needs a good control of diabetes. Correct. Even after the best surgery which is done by, we have with us CABG surgeon also like Dr. Anil Jain is here, but we are not achieving a tight control. It is the sugar control which is rather more responsible for this patient to develop post-CABG heart failure. You know that within 3 weeks, if your patient post-CABG is not having good control of diabetes, even inside the ICU of post-CABG, the chances of blockage are very, very high. The heart failure incidence also increases. Long-term data if you see for 5 years, 10 years, 15 years. So what my message is here, you may use any SGLT2 inhibitor, but make sure that your patient A1C gets good control.
I think that's more important. Irrespective of ejection fraction, in presence of ASCVD, heart failure, whether it's mid-range, reduced, preserved, improved, or whatever, even if occult or non-occult as SGLT2 with the ASCVD, you'll have to choose SGLT2 ahead of others. Right. What Yeah, so patients take all three.
Regarding the EMPA, Cana and Remo, I want to say and DEPA. For coronary artery disease patient, I think EMPA followed by Cana followed by DAPA. That's what I have learned because the canvas has shown that a stroke and they have enrolled the more cardiovascular patients. That is what I
Heart
learned.
failure, probably all.
Heart failure, of course.
EMPA,
Yes.
absolutely. EMPA like data is probably yet to come, but not Cana. Not Cana. Probably we don't have that CV reduction outcomes. Remo data is yet to be published. Yet to be published. Absolutely. 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 Once you have a CABG, once you have a PCI, once you have acute MI, once you have a stent implanted, probably the EMPA get the most robust data. Heart failure, I say the tables are turned. DAPA actually shows mortality reduction irrespective of heart failure hospitalization as a combined endpoint. EMPA doesn't do it. I think they learned the lesson the other way around. How you design a trial also will end up in getting the outcomes. The EMPA people in the Emperor Reduced were smart to choose very selective patients with very high anti-pro BNP and didn't use in the all-comer, and they lost out there in terms of mortality. Again, it was not powered, but again, you can't compare apples with oranges. A lot of subgroup analysis have been talked about how Asians would do better, how AICD and CRTs were more implanted in one study and not the other, how ARNI was used more in the one arm, the other as compared to the other. But I think the crux is heart failure, SGLT2 has to be there, either of the two or maybe the third one.
So may I conclude, Kamal?
Yes, please.
That if you give EMPA, you are not going to be wrong, whether the patient is diabetic or not, whether the patient is having heart failure or not, CKD or not. With DEPA, because DEPA does not have data in diabetic patient with established cardiovascular disease, declared TB for heart failure, definitely yes. Chronic kidney disease, definitely yes. But declared TB, the biggest trial, was negative as far as the 3-point MACE and the cardiovascular death was.
Again, how
But
the
if you give
design of
EMPA,
the
you will
trial.
never be wrong, except for the cost. Yes, we cannot compare two trials, obviously. So give any SGLT2 with cardiovascular benefit, EMPA, DEPA, or even maybe CAN.
No, that's the point. I mean, they learned the lesson in declared TME and improved it in DAPA HF. And they showed it the other way around to compared to Emperor Reduced. DAPA HF actually showed mortality. Yes, with the EMPA outcome, yes. That's why Remo was kept as a debate.
Only 10 rupees per day for saving life. 10 rupees additional cost.
So this is an endless fight. I know that, like Russia and Ukraine. Now, what we are thinking in terms of America and China, that fight is going to be on. So be prepared for all earthquakes. And before that,
thank you all the chairpersons and speaker. Your memento and facilitation is in your kids. I would like to request our GMC observer, Dr. Rajesh Bhai, to be felicitated by Dr. Asha Madam. Please. Answer. Dr. Rajesh. Sir is observer from GMC. GMC has accredited us with 8 points, as I said. Thank you very much, ma'am. All our chairpersons and speakers, thank you very much. Thank you, madam. Mementos and felicitation of the speakers and chairpersons is in your kids. Please collect the same. Thank you very much to save the time. That's what we have done. Thank you very much. So this was the question. All of the following are correctly matched trials. Remolution for EMO, Empulse, Empagli, Dapagliflozin, Dapagliflozin, Vertis CV, Sotagliflozin. Can we have next slide? Yeah, so the Vertis CV, next slide. So Vertis CV is Ertugliflozin, not Sotagliflozin. Next slide. Over to Jeshbhai.
now the same thing what we were talking about, multi-vessel disease, always a matter of controversy between surgeons and physicians, cardiologists. And we people are always in the queue to hear whatever they have to say. So as usual, we would like to invite the chairpersons, Dr. Sumit, Dr. Pratik, and Dr. Nitin Bhai as chairpersons, and co-chairpersons are Dr. Alpesh, Praveen Bhai, Shaival, and Karthik. Equally distributed. City surgeons and cardiologists.
तो अनिल भी यूज टू कंप्लेन सारे कार्डियोलॉजिस्ट बिठा के मेरे को डिबेट करा रहे हो आज मैंने ज्यादा सर्जन कम कार्डियोलॉजिस्ट बिठाए ऑन द लाइटर नोट ओवर टू chairpersons please.
Good afternoon. I think the war of the words now starting. Batman versus Superman. I would not specify, who's the Batman, who's the Superman, but I think the surgeons deserve the designation of Superman, where they've been here for much longer time than we cardiologists. Surgery has stood the pressures and the test of time. Angioplasty has evolved over the last couple of decades, and I think Kamal Bhai and Dr. Anil Jan are already friends, huh? So there is no conflict of interest between the two. I think you are at good
we are
terms.
very good friends. That's all.
Great. I think Bansi Bhai has left. Otherwise, I would say the conflict of interest has now started for all the cardiologists because of Bansi Bhai's comment.
Should call Bansi and ask him to come back.
Yeah, before he comes back, we should finish the debate.
Yeah.
So this is a case, I think, what traditionally multi-vessel disease always has gone towards the surgeon side, and surgeons have years of experience. As I said, the angioplasty, the stents have evolved in the last 1 or 2 decades. But still, I think with the better stents, the better medications, the reduced cost of the stents, I would say, now the level is almost the same. So I would
Good afternoon to all. Thank Dr. Kamal Sharma and Dr. Amit Bhai. I think this topic is, as you know, actually I am surprised there is a debate about it. Somewhere I think we are all wrong. Settle the issue, the multi-vessel EAD is part of it. But since we have come to this thing, so this case is 37-year-old male without diabetes and hypertension with a strong family history of CAD with unstable angina triple vessel, mid LAD 90, proximal LCH 80 and mid RCA 90. Type A, B, C lesion respectively with right dominant circulation with normal LV function with passing LDL of 155. Now best strategy would be, I think I'll start with Dr. Anil Jain. And I think we will settle the issue once and for all. Thank you.
Just 1 minute. Go ahead. End up bashing us. Glove में रखते हो मार-मारी ना हो जाए. Okay, anyway, I thank everyone and we straight away go to the debate. Whatever I'm going to state is out of the context of debate. I am not against any procedure, seriously, but well, ironically, it's true that I think I would go on the side of CABG. I want to ask you how many people know what is a successful angioplasty? A successful angioplasty is after which the residual luminal diameter is not, the residual stenosis is not more than 50%. So leaving a 50% lesion in a vessel is a successful angioplasty. After which there is no MI, patient does not need a bypass, and there is no abrupt vessel closure. He has mentioned type A lesion. Can you believe the success rate of a type A lesion is more than 85%? Now, if I tell you I'm going to do a bypass and there is a 15% risk of a bypass, how many of you would send that patient to me? No one will send that patient to me. So already there is a 15% even in a type A lesion, which is the best possible lesion. Good target, good vessel, good everything, and there is a 15% risk in angioplasty. And this is not me. This is ACC AHA stating so. Coming to type B, there are 2 type B lesions for this patient. And for type B lesion, the success rate is moderate, 60 to 85%. So if I do a bypass surgery and I say there's a 40% chance of failure, are you going to send that patient to me? Yes or no? No, nobody's going to send it. I know that. And in that also there is type B1 and there is type B2. If it is B1, it is still okay. B2 is considered complex, very bad lesion with a very poor outcome with plasty. This is what he suggested. This is what a normal plaque looks like. Imagine pushing stents, wires, balloons, catheters, IVUS, everything into that. Now, what is this pathology? Coronary artery disease is atherosclerosis. And most of the myocardial infarction, I want to impress this point to all of you. Most of the MIs that we see are because of non-flow limiting lesions rupturing and causing acute myocardial infarction. Second, coronary artery disease progresses from proximal to distal part of a vessel over time. And the vast burden of plaque is only in the first few centimeters of that artery. This is a paper I want all of you to read sometime in your life. And it is written that majority of the infarcts are generated by non-flow limiting lesion. But PCI is slowly focused only on treating flow limiting lesions. Thus, PCI cannot be expected to significantly limit new infarcts. But CABG may do so through providing flow to flow to vessels distal to the occlusions. Not only that, it bypasses all the plaques too. So if this is the PCI, like this is a PCI, there may be plaques above and below the PCI, but CABG will be beyond all the plaques. The graft is distal, and I will show that point again and again to you. This is a study that shows that most of the infarcts are because of vessels that have less than 50% stenosis. Imagine plastic, after plastic, you have less than 50% lesion left after a plastic. And most of the MIs are because of less than 50% lesions. So imagine what is the chance of MI after angioplasty. If there is a plaque in the proximal artery, that is 50%. That can still lead to myocardial infarction. And most of the times, 50%, this looks 50%, this is not significant, let's leave it alone. We'll treat the critical part. That's how the cardiologists go. So both these techniques treat coronary artery disease, but myocardial infarction is common after PCI and not common after CABG because the graft in CABG goes beyond the entire plaque burden in the artery. And that is why, like I've written, the majority of bypass grafts are placed distal to the potential vessel occlusion from CAD. Hence, coronary bypass prevents against infarction by covering anodoic zones at risk for ST segment elevation, MI, which does not happen with PCI. What does the data say? All of you have been talking about mortality, mortality, mortality. So let's look at morbidity and mortality. This is a meta-analysis by Sipahi et al., which included most of the major trials. And what did it say? It favors for myocardial infarction, less incidence CABG. Look at repeat revascularization, it is in favor of CABG. Look at MACE events, favor of CABG. Only where PCI is favored is in event of stroke. Look at this. What does CABG do? There is a 27% reduction in long-term all-cause mortality and a 42% reduction in MI compared to PCI. 42%. Can you beat that percentage? 42% in MI. And we want a PCI for a patient 35 years old. I wouldn't do that. These benefits of CABG are so meaningful that we should prefer CABG over PCI. Look at this. He has mentioned all these A, B, C, D lesion. And this is the ACCHA 2022 paper, which says in all the data put together, if you try to do angioplasty in a complex lesion, B2 and B1 are nearly complex lesion, then the mortality is bad and the 5-year outcome is worse if you do PCI. Clearly it is worse. This is what it is. Look, 6.8% for single vessel and 9. ABC lesion. So it's A lesion, you have 6.8% failure at 5 years. If it's a B type lesion, 9.9. And if it is a B2 type lesion, 11% failure at 5 years. And this is for single vessel disease. By ACCHA, you got failure of stent. This is a single vessel. Imagine you put 3 stents, where would the failure be? 30%? Imagine where your patient is headed to. And look at this. They have reported death at 5 years. Look at the death, 8.2% death. And target vessel failure, 14.8%. Means if you do PCI, 8% patient will be dead at 5 years. Do you want death? We don't want death. We want patient to live. See, PCI only relieves symptoms. It does not prevent death and repeat MI. What is the failure rate? It's mentioned here. Long-term stent thrombosis rates were increased in complex lesion despite use of second generation DES. Use any type of DES, it doesn't work. Look at this patient. This paper, coronary artery bypass surgery, recent paper, 2016. What is the survival? Despite aggressive nature of coronary artery disease in young patients, even in young patients, the perioperative morbidity death is very good. What are the survival rates? 5, 10, and 20 years, 98%, 95%, 79 or 80%. Look at that. And freedom from complications, just look, 97, 91, 65. What excellent long-term outcome. If you do good arterial grafts, survival is done. This was an everlimous trial. Look at the data. This is the total death, myocardial infarction, repeat stroke on this side. Look at this. Where is CABG? 14%. Where is PCI? 21%. And composite endpoints are also different. All of you keep EMPA, DAPA, REPA, you worry about mortality. Why don't you worry about PCI versus CABG? Look at it. Look where the data is. Send your patient for CABG. Don't let him die with a PCI that kills him. Really, that's how it is. I'm not joking. I'm very serious about it right now. Look at this trial that was done through syntax and otherwise. And what is the outcome? Look at this. Multi-vessel disease, the green, multiple grafts if you are done. Where is the mortality for multi-vessel arterial grafting? And where is the mortality and outcome? The blue line is the multi-vessel stenting. You cannot compare this sort of data. You cannot compare PCI with CABG. I'm not trying to compare it also. I'm just trying to tell you, if your patient has triple vessel disease and you want him to live, it depends what you want him to do. If you want him to live, talk about CABG. This is what syntax says. You have a complex syntax score, the mortality in PCI goes up. But CABG, whatever the score, the outcome is good. Why? Because grafts are done distal to the atheroma, distal to the plaque, distal to the problems, distal to everything. Look at this. This is the number of papers, and this is just a small screenshot. I can give you 1,000 papers that give you the outcome of CABG. CABG means survival, live. The patient lives, he does not die. That is what. Now, suppose if you want to say, okay, what should an ideal graft or an ideal stent be? So I say stent should be done. An ideal bypass should not occlude. That is the most important thing. If it doesn't occlude, you can put it everywhere and everything is fine. Look, what is the quality of left internal mammary? It is a wonderful thing. It secretes prostaglandin I2, endothelial 1, tissue plasminogen, transforming growth factor B1. It is a capacity to secrete nitric oxide. You know, when you put a Lima 2 LED, you do arterial grafts like bilateral mammary onto a heart. It keeps secreting this nitric oxide, prostaglandin, and it prevents progression of disease distally. That is very important. Put a stent, and after 6 months, there's huge disease distally. That doesn't happen because these arteries, they secrete a lot of drugs, a lot of hormones that keep the coronaries dilated. Look at IMA. IMA has got a fenestrated internal lamina, and that prevents thrombosis. It is extremely excellent high velocity flows. Imagine the flow going through a mammary artery into the heart. Phenomenal. Whether he does effort, he's running, anything, nothing happens to the patient because it has a resistance to shear forces, everything you can imagine. They've written left internal mammary artery versus coronary stents, impact on downstream coronary stenosis and conduit patency. What happens distal to a mammary artery? It is written Lima grafting to left artery associated with significantly lower risk of downstream coronary conduit progression compared to percutaneous coronary intervention. So not only the graft flows, distally the LED also flows. Now compared to this, I want an ideal stent, okay? What would an ideal stent be? It will be free of thrombosis, not require repeat vascularization, it will maintain vascular function, it will be wonderful. So what happens if we get a stent like this? We can plaque the whole first few centimeters of LED, first few centimeters of circ, first few centimeters of RCA, just put a lot of stents everywhere, plaque everything irrespective of a lesion. You would have to stent everything irrespective of lesion, not with the lesion or without the lesion. Why? Because these plaques only rupture and cause coronary artery disease. And don't tell me IVAS for OCT. They hardly bother about plaques. I don't know how many people get an OCT. So cardiology has been coming up with these eureka moments. If you won the battle like this, first eureka, 1977, I've got balloon angioplasty, no more CABG. After a few years, oh, it didn't work. Then they come with the first generation PMS. Oh, it's very good. We will solve the problem of these stenosis. Again, thrombosis did not work. Then they came to first generation DES. Wonderful. It did not work. Next thing. Every time they study 5-10 years and realize they are wrong, you lose people. People die. You are again and again comparing it to CABG, but people die. Imagine these trials kill patients. They don't keep people alive. Remember that much. And again, they came with further beautiful stents. And now they have got eureka moments. Now we have got IVC, IVAS, OCT, this, that, everything. Lithotripsy, rotablation. Arre, what rota litha? You are killing people. No, really, I'm not joking. It's a fact here. Imagine If you have got plaques, you have to come to my theater and see the plaques. They look like rocks. Imagine putting a stent and a rota and an IVUS and a litho into that and trying to crush that junk. And what happens to the epithelium? There's no endothelium left after that. It's garbage. And the disease as such is going to come there. It is going to come there. So I don't think yet cardiology has come to the eureka moment where they say, now we have won the battle against CABG. And why? It is not that they do a bad angioplasty. They do wonderful angioplasty. At the time of angioplasty, if you see the angio, everything looks wonderful. But why does the disease come? Remember, understand the disease process and you will understand why CABG does well. This is what I've drawn. Where does the disease come? Disease will progress everywhere proximally, all bifurcations and all the places. So if the disease is going to come everywhere proximally, what is going to happen? Imagine if they put a stent here. Sorry. Flow is there. That is where the atheroma, even in your house, the junctions are where the things get together. Just last piece, right? And look at cardiac surgery. Eureka moment. Our eureka moment was 1964. A few days after my birth, I was born in 64. There, Kolosov did the first CABG Lima to LAD, and still that Lima to LAD is our eureka moment. 50, 60 years on, 58 years on, cardiac surgery has not changed. It is mentioned. The magic of left internal mammary artery graft. And look at this, 96.4% patency and survival rate. So it is the impact of co-lateralization. CABG gives relief of symptoms, prevents MI, reduces mortality. PCI gives only relief of symptoms, and that also temporarily because the plaques are going to rupture and give it. And that is what co-lateralization, I just said, that is why it prolongs life. No other reason to prolong life. Imagine all these papers are there without improper lipid. Just now someone said improper diabetes. Still we look at a 20 and 30. I had a patient today, a few days ago, 91, the first CABG we did in civil hospital. That guy is now 92 years old. He came with his daughter. In 91 we did CABG. 32 years later, he's still alive. And now what is the life history of CABG? Let's look at economics. This 37 years old, he has a bima, 3 lakh cost, 30 years later, maybe a redo CABG, he lives another 20 years, it's okay, 6 years, 6 lakh cost. Look at PCI, OCT will cost him 5 lakh, after that a re-intervention 5 years, then he gets an MI, he comes to us, we do a CABG and mitral repair with EICD, and then he lives in class 3, class 4, and he ends up spending 30 to 40 lakh. This is industry, spend 30, 40 lakhs, lovely, the hospital does a lot of work, and everybody has a lot of work to do, and everybody is starting DAPA, GLIPA, because patient is in heart failure with diabetes. And imagine if you've done CABG, this is where you are. So it's not about playing with toys like Rota, IVUS, Litho. It's about making the person live. We want him to live, not get there. Okay? So let our patient live. Let him age gracefully like good wine. Surgeons have Ma on their side, and once mother is on your side, nobody can defeat them. Thank you. There is something I want to show that proves my point. So this is why is the video not playing out there? I'm sorry, but माँ मेरे तरफ है, मैं क्या करूँ? माँ अपने साथ, आप बोलो, आपके साथ माँ हो तो आप कोई हार सकते हो? नहीं, माँ चाहिए बस. ये दिख नहीं रहा है, दिखाओ उसको माँ. माँ तो हमारे पास है. So this is what I wanted to show. We talk about co-lateralization. This is exactly my slide. Look, this patient had CABG in 97. He had come from Bangladesh. That Lima to LAD is flowing. All the proximal vessels have closed. Full progression of disease. Full progression. Proximally, everything is 100%. One Lima, one Ma is keeping this man alive after 27 years, and he is in class 1. Look at this. The whole heart is collateralized. So collateralization is important, not proximal disease. Everything else is toys. Thank you very much.
So So take
You
home
lead
mes-
one to defend yourself.
so take home message is all the cardiologists are doing stenting. Just stop doing it, refer it to surgeons. So we all will make epic hospital also.
Sorry, this is a debate. It's just for the sake of debate. I made a mention.
message आना बाकी
It's a
अभी मेरे
debate.
बोलने तो दो.
I'm
So
just
now Kamal is the right person to negotiate.
Good afternoon, everyone.
I know
So-
he's going to bash me with that glove.
Anil Bhai is a fantastic surgeon, a great friend, and we always enjoy this. And this is a showstopper debate, I call it. I mean, we always have the best part. अब मैं भूल जाऊं उससे पहले, I will first rebut what he said and what all he was showing. He showed you 2015 का data from Park. 2015 का Park it all data अपन दोबारा देख लेंगे side side आपका. 2015 का Park all data उसमें भी conveniently he misses out on the middle part where it shows that the CABG had higher curve than the middle. You want to show that slide? I'll show it to you. Again, the rebuttal on the CABG, इधर डाला, इधर डाला, इधर डाला, इधर आएगा, उधर आएगा, जहां मैं डालूंगा उधर कुछ नहीं आएगा. Again, is a wrong thing. उस पे जो आप point करने के लिए उधर गए, उसमें सबसे important message सबसे ऊपर था, आपकी हॉस्पिटल का नाम. Anyway, so उसमें भी कैथ लैब है और उसमें भी कार्डियोलॉजिस्ट है और दो हैं. अब ठीक है, वो उसकी बात नहीं करते. Another thing that I want to talk about, that he talked about 50% residual as successful. 1988 का डेफिनेशन 2023 में दिखा के लोगों को कंफ्यूज करके विदाउट रेफरेंस बात करके Anil Bhaiya has confused you all to go for bypass right now because you all will develop atherosclerosis in future. You all should go to epic lie down on the CTOT table, sir, नया artery डाल दो. But problem I have is you are putting Lima, you are not putting new LED. Put me a new left anterior descending artery. जिस दिन आप किसी और का डोनर का लेके नया एलईडी डालने आओगे उस दिन आपका probably logic will hold true. You cannot compare Lima with a native LED. You are also putting something into it. So before I jump and go and talk about what this is, every cardiologist will tell you कि क्या बात कर रहे हो सर, इसको bypass में 37-year-old का ऐसा lesion होगा और आप उसको बोलोगे तू bypass करा ले. Focal lesions, that's the problem. Surgeon is waiting to look only at the LED. LED में लीजन निकलना चाहिए, बाकी किसी वेसल में निकले ना निकले, I'll get of CABG. So that's the point that I was trying to raise, that if you have a triple vessel disease which includes a focal lesion in all the vessels, and then why not a PCI, especially if it's a young chap. Now, why I like this patient, you can already see my PTCY inside and he's already undergone a PCI, of course, and I am very confident why I will do it. So what will be medical headline? Dr. Anil Jain created a headline. Will this be a headline if a dog bites me? No, it will not be. This will be if he ends up, this one crazy man goes and bites a dog, that will become the headline. So all the headline that he created was when the dog was bitten by a man. He didn't talk about the normal thing. Let me give you 10 important reasons in next 10 minutes and 5 minutes for the rebuttal. Reason 1 is the guideline. Now he tell me guideline कौन लिखता है, cardiologist लिखता है. No. These guidelines are written by a joint committee which includes cardiothoracic surgeon. And what do they say? Triple vessel disease without diabetes, both are class 1A indication when the syntax score is 0 to 22. Now, when you have a patient who's got triple vessel focal type A lesions, what is his syntax score? This is syntax trial. He already talked about it. Very small trial. And remember, what was syntax? First generation. Paclitaxel, nobody uses now. Even that stent in low syntax score was like MiG-27, Indian Air Force does not use anymore. Even then, हमारे MiG-27 से जाके we bombarded and crashed F-16. So that was the 1 year follow-up. You had composite endpoint. Results were driven more frequent by, even in long term, by frequent PCI for all comers. But what about stroke? He did not talk about it. वो पेशेंट आपका 30 साल जिंदा रहेगा लेकिन पलंग पे लेटा रहेगा, एक हाथ पैरालिसिस, उसकी माँ उसको खिला रही है, बाद में बेटा खिलाएगा, फिर बेटी खिलाएगी, बाद में परपोती खिलाएगी. ऐसा 30 साल जिंदा रह के क्या करना है? Stroke rates, look at that, 4 times higher stroke rate in CABG as compared to PCI. You have a choice. You want to be paralyzed and being fed by your kids, or you are willing to get a second angioplasty done after 5, 10 or 20 years. What about 3 to 5 year data for all comers? 5 years, no difference in death. So ये जो मर जाएगा, तू मर जाएगा, bypass करा ले नहीं तो मर जाएगा, doesn't happen. There is no difference. 10 years again, no difference in mortality. I'm talking about Syntex trial, where we've used first generation drug-eluting. I'm not even talking about fourth generation, polymer-free, abluminal coating, ultra-thin strut, no joints, side branch access. I'm not even talking about that. I'm talking on your front only. Low Syntex score mein kya hai? Syntex score is simple to calculate. Just put the values. Like in this patient, what is this Syntex score? 12. 12 Syntex score. You want to do a CABG? Why? Look at the data with taxes over 60 months. आपने 80 months का दिखाया and you scared us कि मर जाएगा. Look at that. There's no difference. No difference. Even clinical Syntex score, which includes creatinine, LV function, peripheral disease, gender bias, all included, even then Syntex 2 would give you that you need either a CABG or a PCI. So now you talk about best trial. This is one of the trials surgeons never talk about. They don't want to talk about. Why? Because there was no difference in composite of anything with the everolimus eluting stent. This is at the end of nearly 5 years. He's just 35. उसका bypass होने के बाद जब वो बाहर आता है वो 45 का वैसे ही लगता है, ऐसे पकड़ के चलता है, उसकी बीवी हाथ पकड़ के लेके जाती है और दिमाग से 55 का हो जाता है कि मेरी तो bypass हो गई, जिंदगी खत्म हो गई. He will come and ask the surgeon twice, can I ask you something in your chamber personally? अब उसकी बची क्या जिंदगी 35 की उम्र पे? What is left for him? What about new generation drug-eluting stent? We have ultra-thin strut, different platform. How do they fare? This is like 5th generation stealth air fighters. You know, we are not talking about 1st generation MiG fighters. There is no polymer. Taxus had a polymer. Problem with 1st generation was that there was some amount of polymer left behind, so no endothelialization. आप बता रहे थे इतना गंदा, scary, hyper microscopic view of a plaque and trying to scare us. That plaque is lost, completely replaced by healthy endothelium when you put a stent by neointimal endothelialization. आप लोग तो वो कचरा दिखाते हो पर निकालते तो हो ही नहीं, उसके ऊपर से नया डाइवर्जन. भैया यहाँ ट्रैफिक जाम है, तू बाहर हो जा, मैं उधर से लेके जाता हूँ तेरे को. ये रास्ता बंद है, चल उधर से लेके जाता हूँ तेरे को. मैं तो मेन हाईवे खोल रहा हूँ भाई, सफाई कर रहा हूँ और ऊपर से आपको दिखा रहा हूँ बीच का रोड अच्छा है. फिर कहाँ प्रॉब्लम है? लीमा इज बेस्ट. अच्छा, पहले तो आप सर्जन आपस में डिस्कस कर लो कि लीमा करना है कि वेन ग्राफ्ट करना है. Because I know some of the surgeons, they say vein graft is best. Other problem is beating heart is best or on pump is best. अभी वो भी clear नहीं है. Then radial is best or vein graft is, वो भी clear नहीं है. अब I appreciate Dr. Jain. I mean, whatever he puts, yeah, I always tell this. Dr. Anil Jain is a fantastic surgeon. When he operates, if you get his patient with acute MI, उनका ग्राफ चल रहा होता है, दूसरी आर्टरी में ब्लॉक आता है. So he can argue कि दूसरी आर्टरी में क्योंकि मैंने ग्राफ नहीं लगाया था इसलिए बंद होता है. बट अगर आपकी थियोरी है कि एथेरोस्क्लेरोसिस है तो 2 लगाए थे, तीसरे लगा देते. क्यों नहीं लगाते? क्योंकि पता है उसमें वेन ग्राफ बंद हो जाता है, आर्टेरियल ग्राफ बंद हो जाता है, तीसरी आर्टरी बंद हो जाती है. सो दैट लॉजिक डजंट अप्लाई दैट यू आर क्योरिंग एथेरोस्क्लेरोसिस बिकॉज यू आर आल्सो नॉट ग्राफ्टिंग अ लीजन व्हिच इज नॉट ऑप्टिमल. व्हाट अबाउट इंटरनल thoracic artery? Look at this paper. 12 to 18 month angiographic follow-up, failure rate is 8.6% in this study. ये हमारे बेयर मेटल स्टेंट का थ्रोम्बोसिस रेट है. व्हाई? बिकॉज लीमा और बीमा का कोई बीमा नहीं है. बीमा या लीमा इज लाइक डिपेंडिंग ऑन द सर्जन, इट इज मेड इन चाइना. चल जाए तो आसमान तक, नहीं तो शाम तक. सो every lima, does it play for 20 years? No, it depends. Anil bhai is a fantastic surgeon, as I said. His graphs flow fantastically, but then he cannot tell all surgeons ki aap lima hi lagao. I know a lot of surgeons who do vein grafts and they flow very well. First ये decide करो beating करना है कि नहीं. आपने मेरे को बोला हमारा यूरेका मोमेंट आपका अभी तक नहीं आया, हमारा तो 5 बार आ गया, आपका एक बार भी नहीं आया. आप अभी तक कंफ्यूज हो वेन ग्राफ्ट के, आर्टेरियल ग्राफ्ट, बीटिंग हार्ट के, नॉन बीटिंग हार्ट. रिसेंटली देयर इज अ पेपर व्हिच सेज on pump CABG is better than off pump CABG. Now surgeons are saying stroke rate कम होता है when you don't go on pump. I don't want to go on pump because if I not go on pump, we'll do an aortic bypass. Means we'll not touch the aorta, we'll not have any stroke. Still, stroke rates are more than angioplasty. What about AKI? Hazards were slightly more, but हमको डराते कॉन्ट्रास्ट दोगे वो किडनी खराब हो जाएगी. कॉन्ट्रास्ट दोगे किडनी. What is the incidence of AKI in CABG even when lima is grafted? More than 100% rise in mortality if the creatinine goes high, and at 3 months this persists. हमारा AKI in hospital होता है, आपका AKI permanent होता है, because that is not contrast induced, it is atheroembolic infarcts to the kidney. So when you handle the coronaries, you need to handle like a cardiologist, not like a surgeon. आपने दिखाया, मेरा भी वही फेवरेट एक्टर है. आज मेरे पास बंगला है, तो आज आपके पास टेंट है, आईवस है, आपके पास क्या है? तो हमारा पेशेंट एक्चुअली बोलता है मेरे पास माँ कार्ड है, आपके पास. तो आपकी माँ लीमा, आपकी माँ बीमा, बिना बीमा वाली बीमा, जिसका आप बीमा नहीं करते हो, जिसका आप बोलते हो मैं मेडिक्लेम में ऑपरेट नहीं करूंगा, यू हैव टू पे कैश. हम गरीब कार्डियोलॉजिस्ट हम बोलते हैं माँ कौन सी, एक ही माँ, भारत प्रधानमंत्री वाली माँ, फ्री में करेंगे एंजियोप्लास्टी. दैट्स द कॉस्ट ऑफ स्टेंट. एंड लुक एट द गवर्नमेंट्स पर्सपेक्टिव. व्हेन यू डू 3 stents, the Ayushman Yojana packages, the amount that money government has to pay is also lesser than CABG. Surgeons have increased their bypass packages so much. Everybody gets IBP, on pump, off pump. Packages of CABG in Ayushman is now more for CABG than for 3 stent angioplasty. और हम तो stage करते तो हमको पैसा भी नहीं देते government. We do one and then you do second time, no extra charges. What is the important reason is how long will the patient stay? 24 hours, 48 hours. What about CABG? You've done NICAS, whatever. Triple vessel with वैसे भी नहीं होगा. Still 5 days. What about pain, scar, anesthesia? That's important. You tell the patient. That's important. This is how we do. वो tube डालेंगे. And so I have to very scare. When multi-vessel says, I explain it properly to my patients. And then my surgeons came. आपने ऐसे बोला, डरा दिया. मैंने कहा डरा क्या दिया? I tell them. What is bypass surgery? I tell them, आपको बेहोश करेंगे, सीसी सुंगाएंगे, ट्यूब डालेंगे, छाती चीर के, फिर ऑपरेशन करके, टाके लेके, बंद करके, अगले दिन से वेंटिलेटर निकाल के 7 दिन पे छुट्टी देंगे. मैंने गलत क्या बोला इसमें? Is anything wrong in this? And you will take 1 month for that scar to heal. Am I incorrect? Am I incorrect? And I do tell them that maybe you will require a repeat revascularization, which is slightly higher than a bypass. Are you willing to get a second angioplasty done in 6 months, 1 year, 3 years, 5 years? He is 35-year-old. Yes, sir, I'll get a second bypass done. But I don't want that. I'm very happy with the surgeon, but I'm not sure about the anesthetist putting the tube in my mouth. Regroup trial, new DAS, which means better technique. But in CABG, is still the same. 3 years, no difference in the rate of composite outcomes that included mortality, repeat revasc for patients who underwent endoscopic vein graft. आजकल MICAS, robot, minimal invasive, keyhole, no difference. No difference. That's all marketing gimmick, as they say. आपका नया stent, पुराना stent, हम बता देंगे आपको 3rd generation versus 1st generation, what is the difference. But for CABG, there is no difference. You do keyhole, actually it may be worse. But most important, आपके पास माँ है, हमारे पास बाप है. बाप is called imaging. Imaging, हम अंदर से आर्टरी देखते हैं. आपने कब आपने अंदर से आर्टरी देखी? आपने खोला, जहां पे ठीक लगा, एंजियोग्राफी में देखा, ये 2 के बीच में पाल्पेट करो, ऐसे पाल्पेट करो ग्राफ्ट को, लीमा को, एलईडी को. अच्छा, यहाँ पे सॉफ्ट है, खोला, वहां पे लगा दिया. That's how you put. We go inside the coronary, see how it is, where the plaque begins, where the plaque ends, and we stent everything. Dr. Jain, we stent everything from 0 to 0 and take a longer stent, and we don't leave any plaque behind. Because in FAME 3 also it has been shown that the bleeding, arrhythmia, kidney injury, rehospitalization, and I had thought Dr. Jain would talk about FAME 3, all were higher in CABG. I don't want to bleed, I don't want to die of stroke, I don't want to have a residual paralysis. I am okay if I'll get a repeat PCI. The drawbacks of FAME 3, if he would have talked about, he would have said, देखो FAME 3 में भी हम तो superior आए. Who wrote FAME 3? What was the controversy around it? But the drawbacks of FAME 3, in the FAME 3 written by a surgeon, the paper is imaging was used only in 20%. Completeness of revascularization is not analyzed. Women and person of color were not analyzed. What about it's only 1 year data? What happens beyond? You just wait and see. We also can do physiology. We have the most important concern, the social and morbidity concern. Some patients remain fearful for surgery. Just explaining the truth, as I say, most of our patients will say, sir, angioplasty kar do, ठीक हो जाएगा ना. We anesthesia नहीं चाहिए, छाती नहीं चीरना है. And stroke, all said and done, all techniques spoken about remains high as compared to PCI. So this is how we ended up finishing this case fantastically with 3 stents. Patient is, so why you want to hunt the mountain
or a small mole? Why do you have to dig out whole of the chest, dissect his lima, dissect his bima, and then वो बाकी टाइम बोलता रहता है सर मेरे को पेक्टोरल पेन है, आप बोलते नहीं नहीं वो तो लीमा का फ्लो डाइवर्ट अंदर हो गया. वो बोलता है सर पहले एंजाइना नहीं होता, एंजाइना होता था 15 मिनट में ठीक हो जाता था, अब ये 24 घंटा भारी रहता है दोनों चेस्ट. क्यों? क्योंकि आपने पेक्टोरल का फ्लो कोरोनरी को दे दिया जिसके कोलैटरल नहीं है. थैंक यू वेरी मच.
From the surgeon side or the cardiologist or the physician side?
There are two questions, sir. The index case is non-diabetic and multivessel. All trials are mainly because of focused on diabetes first. Second, the stroke rate what you have described, is that described in non-diabetic or diabetic patient? Third, what was the approach? And the stroke was major or minor? And
Good question.
Last, there are meta-analysis also regarding the second and third generation versus CABG. It is published, I think, Lee et al.
Second generation, not the fourth generation.
Third generation going on, but in second generation in 1920 something by Lee et al. Can
So
you do data regarding
CABG,
that also?
if you have diabetes, we always say CABG. There's no doubt about it. That's why this case is non-diabetic. My point of raising this debate was that in a non-diabetic young patient, Anil bhi mujhe always कहते हैं यार तू मेरे को young patient ऐसा दे देता है कैसे debate करूंगा. So but he's right, because if I was to give this patient and change to say 57,
You said strong family history.
Yeah,
so
that's
that
true.
means very
Lipid.
atherosclerotic disease,
Lipid.
and there is a good chance in 157 LDL. So in these patients, progression of plaque proximal is going to happen. Imagine this patient 37 years, and this is now out of the debate, whatever I'm saying. I agree initially maybe we'll do a multivessel plasty. He comes out fine. But we all have to remember that these people are going to progress with their disease. There are going to be more and more plaques developing proximally over time. Like I showed this guy, 41 years I operated, I put 3 grafts. Over time, everything is 67, everything is close proximal. So disease, that is a disease burden. That is the problem. Cardiologists do a wonderful job. I love all of them, honestly. Kamal, they do a wonderful job. Because tomorrow I need to go and operate again, and I can get them backbiting me. So I love them. They're very dear, and most of the cardiologists are very dear friends. I've grown up with all of them. So they do a very good job. Let me tell you, with IBUS, OCT, the new generation stents, everything is good. But the question is, what is the disease? So over time, even if angioplasty is done, I believe these patients should be monitored well, treated well, good dose of statin. In a good way, I'm saying now, as a conclusion to whatever we discussed, that patients 37 years is not just operated for angioplasty alone. Their statins should be proper, control of exercise should be good, lifestyle should be good, everything should happen so that we don't have progression of disease. Invariably, this 37 is going to get more disease in the future. He is going to get it. It's obvious. They're going to be plaque and growth. So as time goes by, our idea is to increase the longevity. Maybe 37 he did a plastic, 47 he do a CAPG, and then maybe he'll be 80, he'll be okay. So
Correct.
in that way, I would say strategy is okay. But for debate's purpose, I did mention what I mentioned. But we must all remember the proximal plaque progression is the nature of the disease. That is why CABG as a co-lateralization operation has advantages in preventing MI and mortality.
MI
At the same
definition,
time, if you
definition is the another thing, that MI was defined in trials for coronary angioplasty as 3 times the rise of troponin baseline. But CABG it was defined as 10 times. I understand आप handle ज़्यादा करते हो. But coming to your point, Karthik, about stroke rate, yes, they were predominantly minor. But what is minor? NIHS score. अब suppose किसी patient को stroke हुआ और सिर्फ एक ये अंगूठा गया, उसको minor बोलेंगे. Is it okay कि right hand का stroke का सिर्फ अंगूठे का signature नहीं कर सकता है? That minor stroke is acceptable? It's not acceptable. Any stroke is not acceptable. Okay, so I agree. Diabetic, I have no doubt about it. Yes, the analysis was 2nd generation. 5th and 3rd generation, we have data that there is superiority. Versus 3rd or 4th generation versus CABG data, you have anecdotal where it is equally efficacious. Long-term data is pending because 3rd, 4th generation को आए, 4th generation को आए इतना 10 साल नहीं हुआ, मैं आपको 10 साल का डेटा कहाँ से लाके दूंगा. But overall stroke rates, yes, were more in diabetics.
CKDs, hypertensives, elderlies, and that's why we all surgeons and cardiologists agree that every patient undergoing CABG must get a carotid evaluation done. And that's what we all do as a protocol. Dr. Hazra wants to say something.
Nowadays, we've started something else. We put all patients preoperatively on, especially the ones that have plaques on 40 or 80 milligram statin, so that we can hope there is a less problem postoperatively. So I think it's not just whether it is angioplasty or surgery. Total treatment of the patient is what is more vital. Like we talk about proper diet, proper lifestyle, proper diet. I think we want our patients to live. That's more important. At 37, again, stroke after CABG at 37 is pretty next to nil in a non-diabetic patient, let me tell you.
Right. I think both the speakers did wonderful job convincing everybody when they started speaking that this is the way to go, this is the way to go. But patient is at the crossroad when they hear both sides of the story. I think shared decision making should be there is third stakeholder. Third stakeholder is the patient, his wife, his children, what kind of job he's doing, whether he can go back to army or as a pilot within 6 months or not. So those kind of things are also important before deciding. So third factor is also very, very important. Now, if you go to a Naya means barber, and if you ask, do I need a haircut? If the Naya is a cardiologist, people will say, no, of course you need that. If he goes to a surgeon, definitely he will say, definitely need a haircut today. So all depends on where the patient is going first. So let him come back, let him have a heart team approach, let the patient take the decision rather than we fighting with each
other. Well said that, but normally this was just a debate for the sake of bringing out the best of both sides with masala. But in reality, we always, all of us, all institutes have a heart team approach where in every decision, I'm sure even Kamal would say that he will be involving the surgeon for all multi-vessel plasty and then taking a decision. Another 1 or 2 points which I thought probably were not mentioned is if you see the data, I don't recollect, it's a long back publication, that 7 to 14, 15% of grafts are put in the wrong vessel. I have seen patients coming with angina, and then when I did an angio again, I found the lima was attached to the diagonal. These cases do happen. We have records. And other thing is cognitive dysfunction. So that is very important. You know, people started making fun of our one past prime minister, and even, you know, there would be slides, please put your mobiles in the MS mode. So that is actually a cognitive dysfunction. And that happens and we don't realize a person's, you know, how his intellectual capabilities also go down. We are only looking at the gross points like a stroke hua ya nahi, sign kar sakta nahi, but those are again points to be seen. And of course, what we are dealing is, of course, there is the next session which is coming is all on statins. I'll be elaborating besides the debate of where we have failed. And 4 decades they have been putting stents, and yet and bypass, and that we'll be discussing this.
I'll not take anybody's side, but being a cardiologist, I have to put my, my hand behind his back. See, when we do an angioplasty of the patient, everything is recorded on the scene with the patient, with the relatives, and they can. We don't know what is happening in the room. Now, my surgeon comes out and says, oh, I could not put the mammary was not good. I could not put a graft to the PDA because it was all impacted. And the physical function was absolutely normal. How did the PDA impact suddenly? I don't have any recording. I don't have any process. So I said, sir, right, what you have done is done. I think you must have done for the best of the patient. So no sides taken. But I think if suppose I am the patient and I would the surgeon, I don't look at the data. Nowadays the patients have started googling and reading the data also. But I suppose I cannot read the data. I don't have any slides. I don't have any studies which I can understand. Ultimately, I have to be not at the mercy, but at the the goodwill of the surgeon and the cardiologist. So I think ultimately whatever the surgeon does a very good job. Whatever the cardiologist try to do a good job. Thankfully with the good stents, our job has become much easier. More so, with the newer antiplated, the job has become even further easier. Because even if we are not able to deploy the stent adequately in some cases because of the difficult vessel curvature or the tortuosity, the antiplatelets take a good care of the heart. So ultimately, it has to be in the goodwill of the patient, whether it's a young patient or an old patient, it's a child, in a very elite job or in a very basic job. Ultimately, it has to be for the goodwill of the
See, every cardiologist who is doing stenting and every surgeon who is doing surgery, we all know which is the correct case for angioplasty, and we all know which is the correct case for bypass. Both of us, we overshoot our guidelines, and we all know that if cardiologist does the stenting in the cases which is they are indicated, I don't think any surgeon. I and Anil Jain, you can ask all the cardiologists, we refer maximum cases. And similarly, all the cardiologists refer maximum cases. So there is absolutely, where is the question of debate? There are clear-cut cases of CME, there are clear-cut cases of angioplasty. And as you said, कि PPE हमने रिकॉर्ड किया, अरे भाई तो ये भी गलत है, रिपोर्ट वेसल में बोला कि एलईडी में शेड डाल देता, बाकी सबको दवाई से चल रही है. अरे भाई किस बात की दवाई? Today intervention, you when is the people vessel things all three complete evacuation is the key. See a patient मना कर रहा है, patient decide करेगा what is the right treatment. Moving my योजना, what are we talking?
But Kamal,
I think
having
the
said
heart
that,
team approach is the thing. I think that's what we do. That was so when we get a triple vessel, we make it mandatory, and that's also in yojanas. Government has it made it mandatory कि surgeon से लिखवा के आओ, bypass नहीं करना है. Then you do a PCI. So I think that's a good approach, and I think that's where it should.
I have a last comment. Surgeon is now an endangered species.
Correct.
Very few cardiac surgeons are coming. We have very few people left. We are less than tigers in the country. So don't worry. You keep plastering. We'll do whatever we get. We are absolutely endangered. No, the number of people joining cardiac surgery is negligible now.
The seats तो अब दोनों की खाली रहती है. वो तो छोड़ दो.
Cardiac surgery की खाली.
The fame. Right. Thank you very much. And this is the question for FAME 3 trial. What was not compared? So all were compared except, and you can go to the app. Next slide. And we'll have lunch. We'll begin our session quickly at on time, 2:30 as the session is scheduled. So a lot of people were already having lunch. We'll be starting sharp at 2:30. 2:30.
Dr. Gajendra Dubey, Mukesh Mala, Dr. Kamlesh Upadhyay sir, moderator Dr. Kamlesh Upadhyay sir, Dr. Vijay Desai sir, Dr. Jigar Gami, Dr. Dhiren Joshi. Yes, sir. We have 37-year-old gentleman, diabetic with family history of coronary artery disease in younger brother, presents with 99% lesion in LAD with non-ST elevation MI with LDL level of 112, HDL is 32, triglyceride 242. He is already on rosuvastatin 20 milligram. His HbA1c is 7.5 milligram percentage. The best strategy post-revascularization to manage his lipids apart from high dose statins and guideline directed medical therapy plus lifestyle modification. So first speaker is Dr. Sarath Chandra. He is the senior cardiologist from Hyderabad. He will speak about bempedoic acid.
Good afternoon, everybody. Thanks to Dr. Sharma for giving me this opportunity. Okay, let me just show you this case history he just mentioned. So this is almost a routine patient whom we see in our clinical practice. Diabetes is so common no matter where you are practicing in India. Patient had a critical lesion and I suppose he underwent angioplasty following this. He has a strong family history because CAD in a younger brother, LDL is 112 and the triglycerides are elevated, but I wouldn't give too much importance to the TG here because he has uncontrolled diabetes and therefore I would say if you control it, the TG would come down. So the emphasis should be on the statin, should be on the LDL because he's already getting 20 milligrams of rosuvastatin, which is a good dose. It is considered as a high dose statin. So what do you think of in this patient? Look at these relatively recent guidelines from ESC-EAS published in 2019. So if you see here, as the risk of the patient rises from less than 1% to more than 10%, the goalpost is absolutely moving farther and farther. While at a low risk, a level of 116 is okay. At very high risk, a level of 55 milligrams has to be maintained as per this guideline. So it is important for a patient like him, who is a high risk patient, that you should really bring down his LDL to 55 while it is right now it is 112. So what drug you will use? So if it is very high, it is 55, and if it is high risk, it is 70. And if all of you remember, the Lipid Association of India has been crying hoarse that it should be 55 or less for quite some time, and ESC and ACC came out with this kind of statement much later. Okay, so you have today extremely good drugs available in our armamentarium. A moderate intensity statin will bring it down by 30%, high intensity statin by 50%. If you combine it with ezetimibe, it comes down by 65%. If you give PCSK9 inhibitor, it will come down by a whopping 75%, and all three it will be 85%. Being a relatively frequent user of PCSK9 inhibitors, I know that it really brings down LDL very, very low, and probably that's what it should be. Just now you have seen a debate where the surgeon versus interventional cardiologist have spoken about what is done at the time of the procedure. But what is equally important in the long run is to bring down the LDL, bring down the A1C, bring down the blood pressure, and that is probably as important or more important than the mechanical part of the treatment. Okay, you have very good data also today. If you bring down the LDL by 1.07 millimoles, which is approximately 44 milligrams, there is a whopping 22% risk reduction over course of time. That has been shown by so many trials, starting from the old trials to the latest trials. So you have drugs, you have evidence. So what is holding us? In real world, this is a relatively recently done trial called the Da Vinci trial, which is done in about 18 countries across Europe, and they showed that LDL level of less than 55 post MI is achieved only in 18% of the population. So that's a very, very small figure. That's a sad figure. Why only 18% when you have the drugs and European population, they hardly pay for their drugs, unlike India. Everybody gets the medications from the governments of their country, and yet the target is achieved in only 18% of the patients. One of the important reasons for not achieving the target is, of course, the ignorance on the part of the patient, certain degree of slowness on the part of the physician. But a very important thing is the statin associated side effects, most importantly muscle symptoms. We all know, those who have been practicing for a while, we know that patients do have considerable muscle symptoms like muscle pain, myositis, and in a rare case going to rhabdomyolysis, and therefore the muscle symptoms do play a certain role in us not achieving what we want to achieve. Now, in this particular data, you can see even among patients post myocardial infarction, 57% are not fully adherent to therapy after 6 months. They initially take the drugs as you advise, but within 6 months, a lot of them either give up for one reason or other. The fully adherent are only 43%. The non-adherents are 26 and partially adherent are 31. And we know that if you bring down the LDL and keep it low, the event rates will come down significantly and remain so. Adherence to therapy can be essential to prevent another event. So which drug would you use here? So you have statin, you have PCSK9 inhibitors of one type or other, ezetimibe, and now the latest entry into India, the bempedoic acid. So what is bempedoic acid? This is a drug which is a drug that acts on the cholesterol biosynthesis, 2 steps proximal to where HMG-CoA reductase inhibitors act, namely the statins. So it is called ATP citrate lyase enzyme inhibitor. It inhibits cholesterol synthesis in the liver. It increases LDL receptors density just like statins. In addition, very importantly, it activates adenosine 5-monophosphate activated protein kinase, which goes on to inhibit gluconeogenesis and suppresses the hepatic production of glucose. Unlike statins, which actually worsen the chances of a person getting diabetes or worsening his diabetes, bempedoic acid actually improves the situation. So this is the mechanism of action of bempedoic acid I already mentioned. ATP citrate lyase is inhibited, and the drug actually is a prodrug, bempedoic acid. It gets converted to active form in the liver. The enzyme which converts it is there only in the liver but not in the muscles, and that is supposed to be the reason why muscle symptoms are not there. The bempedoic acid cannot act in the muscle. And as you see at the bottom, AMPK activation leads to reduced levels of glucose. And if you have a patient who is borderline diabetic, slightly elevated A1C, but it is still a pre-diabetes, and situations like that, bempedoic acid may be a better alternative to statins for reducing the LDL levels. Okay, so here is a comparison of the various drugs today available: statins, bempedoic acid, ezetimibe, PCSK9 inhibitors. Bempedoic acid is ACL inhibitor and thereby cholesterol synthesis in the liver. It is a orally given drug. It is given as 180 milligrams in the night, post dinner, just like statins, and half-life is 15 to 24 hours. If you give only bempedoic acid, it reduces the LDL levels by 17 to 18%, little less powerful than statins. But the moment you combine bempedoic acid with ezetimibe, it comes down by 38%. And the combination has not been shown to increase the side effects of either of the two drugs. The problem with bempedoic acid are two. One is hyperuricemia. It's the glucuronide metabolite of bempedoic acid interferes with the excretion pathway of uric acid, and therefore it raises the uric acid levels in the blood and resultant slight increase in the gout. It also produces a slight increase in the serum creatinine, which is reversible the moment bempedoic acid is stopped, and for some reason it tends to produce slightly higher incidence of tendon ruptures, usually involving the shoulder or biceps or the Achilles tendon. Low incidence but higher than the incidence in the placebo. You can see here hyperuricemia and gout are slightly higher compared to the placebo arm. Another side effect seen with bempedoic acid is mild anemia, the mechanism of which is not very clear. Now, I'll just take you through a couple of important trials. There are 4 big trials done with bempedoic acid for looking at the events as well as to see what is the effect of this drug on LDL. And these are called the clear group of trials: Clear Harmony, Clear Wisdom, Clear Tranquility, Clear Serenity. The right side 2 trials are trials done in patients who are statin intolerant, and therefore the level of reduction of the LDL is far greater. The left side group are the 2 trials in whom statins are already given to the highest dose possible, so the fall is little lesser. Clear Harmony is the trial which is a big trial of 2,300 patients, and it shows that the LDL levels will come down by about 4 weeks and remain so over course of time. It also reduces total cholesterol, non-HDL cholesterol, and ApoB. Triglycerides actually slightly increase. So for a patient like this, there is no special advantage as far triglycerides are concerned, but the triglycerides in this given patient are probably is due to the fact that diabetes is not controlled. Non-fatal myocardial infarction also comes down as you in almost all the meta-analysis combining the patients from different trials. It is clearly shown that non-fatal MI comes down with bempedoic acid. A new onset or worsening diabetes also comes down. You can see here BA, there is another meta-analysis which showed that bempedoic acid is associated with lower risk of CV mortality and diabetes mellitus. Clear Wisdom trial as well as Clear Harmony showed that CRP levels come down. Bringing down CRP, which is otherwise called pleiotropic effect of statins, is actually also shared by bempedoic acid. Significant fall of CRP, hsCRP. But unlike statins, bempedoic acid actually reduces the chances of new onset diabetes or worsening of the current diabetes. I'm almost done. One moment. Okay. So, therapeutic options after maximally tolerated statins, it may be any of these drugs. And where do we bring in bempedoic acid in these patients? So it can come at this level, that patient is just not able to tolerate statin and therefore you quickly go to bempedoic acid. It may be also that you are given the best possible other drugs and still you have not reached the goal, then again you may have to go to the bempedoic acid, or as a combination with ezetimibe following statin failure. So the trial that is awaited, the event-based trial, is called the Clear Outcomes trial, and its patients are going to be on follow-up for nearly 5 years, and the data is expected sometime late in this particular year. All right, thank you very much.
Now I invite Dr. Know the reason.
Should I go fight from that side?
You are on blue. So he will talk about the ezetimibe is much cheaper and effective to improve the patient's dyslipidemia.
Good afternoon, friends. It's a proud privilege to be here in Ahmedabad again. Just had come over 2 months for a similar session, and must really congratulate Dr. Kamal for the Kamal he has done. Even yesterday, the digital, I had sent it to many of my PG students, and they were glued, and I too could attend certain important sessions. And today also, when I saw, there were people waiting outside the hall, which is something a rarity nowadays. So my topic, which I said earlier, is now the case we have seen. A young person has already been alluded by my friend Sharad, who already has NSTEMI family history, because younger brother has got a mixed dyslipidemia. He is diabetic, and we are going to see what best we can do. So here, when we were talking of various colors, so I was so confident, I said, give them all the colors. I will fight them alone. And the one is the blue one given to me. So this is a statin-loaded patient, and then there are others waiting. कि bempedoic acid देना है या ezetimibe देना है, glitazar, PCSK, fibrates. And look, there is a smart lady behind. He says, lifestyle modification, leave him alone. She will come back in the concluding slides. So in such a case, what should be the ideal target for cardiovascular risk reduction? Only LDL, only HDL, which is also low. Triglycerides are also high. As I said, he is a mixed dyslipidemia while on 20 milligrams of rosuvastatin. And what about ApoB and LP little a? So what is new in dyslipidemia has been seen. So statins are, and they have become the hallmark of therapy in all cardiovascular diseases, dyslipidemia, ischemia, ASCVD. But in spite of adequate doses, 40% of the patients still experience cardiovascular disease. And newer therapeutic agents to tackle such residual cholesterol risk is not only to tackle LDL-C, but even TG and triglyceride-rich phospholipids. That is what we are talking of, ApoB, which is an indirect measure of high-dense LDL. LP little a are being introduced, and these are the various drugs. You see, if you see all, this was the latest summary of clinical trials, which has come 2021 in trends in circulation. The important drugs which have made the mark initially were started with high density statins, then comes ezetimibe. I'll not go into the details, and then followed by PCSK, monoclonal antibody, evolocumab, curomab, Ripata, and newer drugs like inclisiran, and even finally bempedoic acid. But look at the sample size. In case of ezetimibe, in improve it in ACS, 18,000, in the ezetimibe, which was the CKD, 9,000, but in clear harmony, only 2,000. So that is important. The duration of the trials in ezetimibe were 6 years, 5 years, whereas in case of bempedoic acid is only 1 year. And the cardiovascular safety outcomes are yet to be proven. So it is not just bringing down the LDL, but is it going to be beneficial? This is a pharmacological style, which I will tell you, it basically reduces the cholesterol absorption. Dose 10 milligram daily without food, very simple, very reasonable and cheap. The mean reduction with monotherapy is 18%, and with incremental doses of statin, it goes up to 25%. And by and large, except for moderately severe hepatic impairment, there is no real contraindication, which is not a problem in Gujarat because alcohol is banned. So it shouldn't be worrying you, I suppose. And cases of myopathy and rhabdomyolysis have been reported, but then these are again very infrequent. Very few drug interactions, which is there with most drugs like cyclosporin. Sometimes you have to be careful with fibrates. So the cardiovascular outcome trials, today any new drug, whether it be SGLT2 receptor blockers, it be ARNI, it may be the statins, you have to show that it benefits and doesn't worsen. So here, there is an incremental lowering of LDL in both the Improve It trial, which was focusing on the ACS patient, and the SHARP trial with ezetimibe in patients who had non-hemorrhagic stroke and even other arterial revascularization. And these are the patients with CKD, and these are all tolerated. So basically, what is your level? When you have seen the patient, usko kis category mein dalna hai? Lowering LDL by 38.7. Now, what is this 38.7? Not a magical figure, it is 1 millimole, which is 38.7 milligram. If you give it for 5 years, it will reduce your chance of heart attack by 22%. If you give it for 12 years, it will reduce your chance of heart attack by 32%. And if you give it for 52 years, it will reduce the chance of heart attack by 53%. So that is what, when the previous speakers were debating whether lima dalna hai ki stent dalna hai, we are only putting the mechanical part and forgetting the most important part. So whenever you are giving a drug, it is equally important how long you have to give, and that is what the cost matters, the compliance matters, and the drop matters. What about triglycerides? All of you, there are many students I see here. For the Indian population, triglyceride less than 100 milligram is preferred, and 150 is the normal, should not be more than 150. And lifestyle interventions are also very effective. Now, this is a very important slide, which should be there with every physician. You can download it on Lipid Association of India. Now, this is very important that today we are talking of the ACC guidelines, the European guidelines, the Canadian guidelines, the British guidelines. In America, they don't talk of the European. Their insurance will only cater to the American guidelines, and so on. In Europe, they will not if you treat as per the American guidelines, they will not insure you. So we have formed our own guidelines, and surprisingly, we have found that there are differences in our culture as compared to the others. So today, our patient fits into the extreme risk category type A. So here, in previous guidelines, they had a low, moderate, high risk, very high risk, but this has been accepted as the extreme risk category, which now even the International Society of Atherosclerosis has accepted. And after 2 weeks, I'll be presenting this thing in New Orleans along with a parallel ACC. So you see, this is what you should be having, all of you, in your mobile, and these are the risk markers. So our patient has got already a ASCVD, he has got a family history, he has got a low HDLC, and if you see all these categories, if you fill them in, he comes into the category of extreme risk category A. The worse than that is category B, where in spite of the best treatment, he keeps on getting recurrent ischemia. So when you see this type of a patient, what are your treatment goals? Your treatment goals in extreme risk, the LDL should be less than 50, and optionally it should be even less than 30. Nothing short of that. Don't be satisfied if your LDL is 60, and that anything beyond, and the non-LDL should be less than 80. This is usually 30 milligrams more than the values in all categories. Now, what about ApoB? ApoB are not a treatment target for the mild to moderate. But if you are a patient with extreme risk group, then even the ApoB has to be treated. And extreme risk group, the ApoB should be less than 50. So this is important. So the goals are there to achieve the LDL, non-HDL. Non-HDL is a co-primary target, and ApoB to be achieved in high, very high and extreme risk, as I mentioned, and then keep HDLC high with dietary modification, even though this is not a target. But 2023 guidelines we might change. So these are the studies of Utopia, where they found that first time when adding simvastatin did make a difference as compared to the control group. There was a reduction in the composite of atherosclerotic cardiovascular events. Most important trial was Prove-It, where 30% of the patients were STEMI less than 10, and these were very high risk patients, where it was added to simvastatin and compared, and there we found that there was a definite 6% relative risk reduction, and the number needed to treat was 56, which was quite appreciable. Now today, when you see a patient with such type of cases, this is a similar slide already shown by Sharad, that you have to always start high intensity statin, atorvastatin, rosuvastatin. It will bring down your LDL by 50%. Add ezetimibe, it will bring down by another 20% per se, and PSK will bring down maximum by 60. But how many of them are going to take it lifetime? And if you add a combination of statin ezetimibe, this 50 plus 20 becomes 65. If you add a statin with PCSK is 75, and add ezetimibe. See, in all this, always a statin, next come ezetimibe, and then third come PCSK. That is important. Even in the European guidelines in the acute phase, they always say start with maximum doses of statin, and then you can add, if the levels are not controlled, add even in the acute phase ezetimibe, PCSK, and at discharge. So ezetimibe is very commonly, it is a very cheap drug, and other drugs which are fenofibrate niacin have not even shown any mortality benefit or cardiovascular safety outcome. The lower is always better, and even 53 is better than 70. And if you see most important trials, Improve-It is as comparable to high density and in with evoculumab and eroculumab. These are the PCSK. So these are the drugs, and it is basically a drug which reduces the absorption, and even it is useful. This slide says in diabetic patients also it is useful, and it is a add. So now what is important is, what is the number 1 year number needed to treat to prevent one event with ezetimibe is 1 in 124, and that with evolocumab Repata it is 104. So there is very little difference, but look at the cost difference. Today even Mr. Gautam asked me, can he shift from Repata to ezetimibe? I'm talking of Adani. I said, I'll tell you after the lecture. So it is not that you have given once. You have to take it lifetime, and look at the cost. So to concluding slides, though it is ASCVD is a very high risk of clinical ASCVD, and then we should add ezetimibe PCSK. Bempedoic acid is still not included. I'm sorry for my friend Sarugletazor, though I'm a proud Indian. There is no mention because we do not have adequate safety data on cardiovascular safety of a higher magnitude. These are the prices which might differ a little here. And so to conclude, it is widely used, it is efficacy at par, and there is no long-term safety concern, dedicated cardiovascular outcome, economical, well-established data in the case we have discussed, and no slide, no talk on lipids should go without lifestyle modification. But the unfortunate part is, this is a fitness gym where everyone is going for treadmill, but they are using the escalator, not the staircase to walk, because there they want to use the treadmill inside. And this is the doctor who had told him to spend 1 hour on the treadmill. That is how he spent. So the lady who you saw, who said lifestyle changes, in reality, this is the queue outside, pills and surgery. Lifestyle changes has got no takers. This is a picture which was clicked by Dr. Sarath when he was coming from Hyderabad airport. A lady he saw and he gave it to me. I said, is this going to be India's future? I said, not if you give bempedoic acid. She will have so much of uric acid and joint displacement, she will not be able to carry all this. So friends, thank you very much for patient hearing. I tried to make it. As was post-lunch, so very difficult. So all statins, do they look safe? They look outwardly on the face of it. But then when you go in for data analysis, the prognosis would change. Thank you very much.
Now I invite Dr. Vivek Arya for the talks on therapeutic research.
Somebody may introduce him. Dhiren bhai, please. Dhiren bhai, introduce Dr. Vivek Arya.
Dr. Vivek Arya is one of the eminent endocrinologists of Ahmedabad. And he's a good academician and good clinician too. And we have heard him in so many diabetology and physicians conferences. And his experience cum his knowledge will definitely throw some light on us. Vivek, please.
Thank you, Kamal, and thank you all the delegates and my co-speaker. As I think Dr. Vijan said, like Sarupitazar still not been mentioned because it's a new drug, so it will not be mentioned. Number two, before I start, let's go and look at the history of the patient because I've missed the target line in this particular discussion. Important thing that patient is a diabetic patient. That is number one. Number two, patient has CAD. Number three, patient has the profile, lipid profile which has been given. So probably the target what we have missed over here is that patient is a young diabetic, has a CAD, family history. Patient has diabetic dyslipidemia, which everybody has missed because which constitute of high triglyceride and low HDL and a small dense LDL. So, and patient is on fairly high dose of statin, and sorry to say that patient has a fairly controlled diabetes. Patient is not a totally uncontrolled kind of diabetes. So my previous two speakers, they have absolutely missed on the target, that they have targeted only and only the numbers. They want to just bring down LDL for some reason, but they have missed that this patient has a diabetic dyslipidemia, which has to be treated with appropriate kind of a drug. And we are lucky to have that kind of a drug which has been available to us. This is a kind of an Asian phenotype. Typically what you find is a thin fat Indian, high visceral fat, higher insulin resistance, high inflammatory marker, high small dense LDL, early beta cell destruction, early onset of diabetes, higher risk of diabetic complication, high risk of CVD. So basically we have to understand that what we are dealing is something like this. And this is what the ICMR in that study has shown, that low LDL, which is pretty common amongst the Indian subset of patients. Almost 72% they have low HDL. Again, if you look at the triglyceride, 30% they have higher triglyceride levels, and the LDL level, which is around in 12%. So what is the kind of a pattern and prevalence of atherosclerotic diabetic dyslipidemia? We have to understand over here that it is high TG, high LDL, and low HDL. And typically, if you look at this patient, has probably each and every part of atherogenic diabetic dyslipidemia. And again, like almost you find 34% of Indians, they have commonly this kind of condition when they have type 2 diabetes. And people who have a higher level of HbA1c, more than 8%, the incidence goes up to 73%. So it is pretty high. And we have been talking about reducing the LDL. Again, if you look at this figure or this study which has published, it has shown that in spite of using the high dose kind of a statin, simvastatin, atorvastatin, there's still a huge amount of residual risk which has been left. So even if you make LDL 0, patient is not going to be benefited by not having cardiac disease in his life. He is going to have cardiac disease because it's a progressive kind of disease, and that will be happening. So now let's understand why it is important, why triglyceride and the CV risk is important, which everybody has missed the point upon that. This is a Bari 2D study which typically has looked at patient with type 2 diabetes and CAD with the baseline TG of 180, and they looked at the composite outcome of CV death and MI stroke and the secondary outcome of CV death. And this is a typically with a higher TG was associated with higher risk of CV risk in diabetic patient. And this is typically you see over here there's increased risk in all the kind of models what they have for the CV risk and for the CV death MI and stroke. Even if you look at the LDL cholesterol in this Predimax study, you find that in no event and the people who had event, the amount of LDL cholesterol is almost same. The p-value is insignificant. But if you look at the triglyceride, the values are very much different in the people where the events were there and no events were there. So it is very important that you should not neglect triglyceride in all such kind of conditions. The second important part what comes is the insulin resistance and diabetic dyslipidemia. Because when you're treating a diabetic patient, all type 2 diabetic patients will have some or more amount of insulin resistance. And why insulin resistance is important? Because insulin resistance will increase your lipolysis, it will increase free fatty acid, and that will be the basically the substrate for all different kind of lipid abnormality what you are getting in the blood, increases inflammation, and all your triglyceride, LDL, VLDL, everything will be get increased because of that. And everybody knows about this YY paradox where Yudkin and Yagnik, they have their Dexadan, and you find that more amount of fat in Indians. So more fat, so more free fatty acids because of insulin resistance. And if you look at the insulin resistance among Indians, you find that it is quite prevalent. Almost 35% at young age will have insulin resistance. Insulin sensitivity is pretty low. So we have to understand the pathophysiology in this kind of a diabetic patient, that why a diabetic patient got CAD first of all, and what should be done for that. So atherogenic diabetic dyslipidemia and the role of saroglitazar, which is the first new clinical entity. If you look at this, you find that you have various kind of a treatment for a diabetes and for dyslipidemia, you have statin and phenofibrate. These are available kind of a treatment. But which of this drug is going to take care of both the things, insulin resistance and the root cause of diabetic dyslipidemia? So PPAR gamma probably had a good role in treating both. And again, like if you look at the newer development where you had a dual blocker. So it was been approved in 2013 by DCGI for treatment of diabetic dyslipidemia. But over a period of time, it has become much more important because it is also useful for type 2 diabetic NAFLD, where you don't have multiple options for treating that kind of a condition. The dual receptor blocker, alpha as well as gamma. And this is how the dual receptor is basically going to act, because it is going to increase the fatty acid uptake increase the fatty acid oxidation. So all those things are going to be beneficial. And ultimately, if you look at the effect of saroglitazar, you'll find that it reduces triglyceride and non-HDL. So, and the PPR gamma will improve the insulin sensitivity, and that again will have a kind of effect, beneficial effect on adipocyte and muscles, and which will take care of your basic disease what patient has, that is diabetes. These are the data about insulin resistance. Probably, again, you have a single center randomized trial for 16 weeks where 30 diabetic insipidus patients with hypertriglyceridemia were included with hyperinsulinemic glycemic plan. And you find that there was at 4 months significant improvement in insulin sensitivity as well as the glucose metabolism improved at 4 months. These are the figure where you can see there's improvement in the blood sugar level, improvement in HbA1c almost about 1.3%. Insulin sensitivity index, which can be measured by HOMA-IR. Again, there's a definite improvement is there. And overall, you can see that not only diabetes, but there was improvement in the triglyceride levels, which was being seen along with that. So, saroglitazar has been studied for multiple factors, and it has been found that it helps in reducing triglyceride almost 45 to 60%, non-HDL 21 to 36%, a small dense LDL by 20%, HbA1c improvement by 0.7 to 1.6%, and liver enzyme improvement by almost 28 to 67%. So in multiple studies, this is the abstract from 18 clinical studies, more than 5,000 patients. It shows that benefit at multiple front, not only one front, multiple front. And this is about the Indian atherogenic dyslipidemic patient, and where 150 patients, and you find that 4 milligram of saroglitazar being used at 12 weeks, and at 52 weeks you can see there's a significant reduction in the TG, almost 60% to 66% kind of a reduction, which has been seen at 52 weeks, which is a great benefit, which probably be missing. Fenofibrate, which has been commonly being used drug, and there has been comparison with that, and here you can see that even with the fenofibrate reduction of around 41%, with saroglitazar almost 55% reduction at 12 weeks, which was been noted. It has been approved by RSSDI 2022 guidelines, where when the triglycerides are high, saroglitazar can be used in people who are at moderate to high risk of CVD. So, just to conclude a few things, it was being thought that diabetes is going to kill by diabetic coma, but diabetes kills patient by dyslipidemia, and which leads to coronary artery disease. So what we need to do is we need to treat the pathophysiology of disease, not the number of your LDL or anything. With this, look back to the patient, and probably if you look back to the patient, you will find that in this particular patient who has typical diabetic dyslipidemia, your treatment of choice should be saroglitazar. So to summarize, in Asian patients, there is an increased risk of insulin resistance as compared to Caucasian, and a target of insulin resistance should also be done in all diabetic dyslipidemic patients, and the elevated triglyceride has a higher prevalence of atherogenic dyslipidemia and NAFLD, and saroglitazar is a molecule which will target both insulin resistance as well as hypertriglyceridemia in such kind of patients. Thank you.
We'll take only 2 questions, please.
You know, there should always be some sort of a rejoinder. First of all, must compliment my other co-speakers for wonderful presentation. Now, what our endocrine friend has mentioned is that we have missed diabetes, we have not missed, we have kept it for him to treat. And of course, it goes with understanding that we were talking about dyslipidemia, and diabetes has to be treated. Now, a very relevant point he has mentioned is like, this is a theoretical drug which has got action on PPAR alpha, PPAR gamma. We all know that on the alpha it will act on the diabetic, and on the gamma it is for metabolic. It will, but in reality this is like saralazine. When the drug came, that this was a renin inhibitor, we thought that is actually an ideal drug which will be above ACE inhibitors and ARBs. Wonderful drug theoretically, but in practice it was a failure. Same way when we came across labetalol, we knew that this was theoretically a alpha blocker and a beta blocker, and only giving beta blocker would increase the alpha action, only giving alpha blocker will increase beta. So this is the ideal drug. But what happened in reality? It never proved. So whenever we are talking about a drug, besides the pharmacological effect, in real life, what are the cardiovascular safety outcomes? And the studies have not been done. And I was quoting not only the international, but more important lipid guidelines, where we have said that now triglycerides, if they are high, you control diabetes and associated features like there is hypothyroidism and others, they will come down. But that is not the primary concern of treatment. Official guidelines mention. The only thing in extreme high risk group, which is again a unique by LAI India, is to control LDLC, to control non-LDLC and ApoB. These are the three, and HDLC and triglycerides come later. So these are the guidelines what we are mentioning. So this is a few points I wanted to make.
Let me also add, you're endocrinologist and naturally you have a better grip of diabetes, I suppose. 7.4 A1C is something which sometimes we accept in a 75-year-old guy. But somebody of this kind of patient, less than 40, for me 7.4 is a strict no-no. We cannot say it just went up in the last few days. He has been having uncontrolled diabetes, that's why his A1C. Let me finish a couple of points then. So I would say that in this particular patient, target is LDL first. The reason, the moment you control diabetes, triglycerides will come down. It's not correct to say that triglycerides are the primary target. No. In any patient who comes to you with elevated triglycerides, without alcoholism, without thyroid disease, most importantly, commonly in our clinical practice, uncontrolled diabetes. Many a time, a diagnosis of diabetes is made in cardiac patients by looking at very high triglycerides. So my first emphasis would be control his diabetes, control his LDL. After that, if the triglycerides are still elevated, go for a drug that will control triglycerides also. And now today we need to tell the patients one number, like blood pressure. There was an emphasis some time back that tell one number, don't tell SBP by PBP. So if you want to educate the society at large about one number in relation to lipids, LDL. Now we all know, no matter what the pathophysiology is, whether he's a smoker, whether he's a diabetic, hypertensive, anything, finally what hits him is the LDL that is accumulated in the blood vessel wall. Therefore, the first emphasis is again on this. And lastly, among my comments, PCSK9 data from the Fourier, if you see, there's a small group of Fourier patients who achieved LDL of something like 15 to 25, and compared to those who achieved 40 to 50 of LDL, compared to this group, they still had further reduction of events. So ultimately, it is LDL, LDL, and LDL. So after achieving target LDL, you want to target triglycerides. After controlling diabetes, ruling out thyroid disease, tell the patient not to take alcohol and pop. So doing all that, triglycerides still elevated, then probably the other drugs will come into picture. Thank you.
Yeah, I'll first of all, like about HbA1c, yes. To go by the ADA guideline, the target would be to keep it less than 7. But 7.4, you would not say that patient is grossly uncontrolled. At 7.4, again, it will be like treatment part would be more strict lifestyle modification and things, rather than you add upon a drug to control the HbA1c from 7.4 to 7. So it's not a bad control. You may not say it is a perfect control. It is not a bad control. If it was more than 8%, yes, we would have thought that is a young patient and sugars are really very bad. So whatever triglyceride this guy has with the 7.4, it is not because of a poor control of diabetes. That is number one. Number two, I'd like to ask you that if your target was to keep, say, LDL, say, less than 50, or your target was to keep your LDL less than 70, were your drug like ezetimibe or bempedoic acid, they were good enough to bring from 112 to 70 or 50, because you wanted a reduction of 40 to 50%, which none of these two drugs probably had that much of capacity. So again, these two drugs were not going to be very effective and not ready to bring down your LDL to that level which you thought according to your guidelines. So, and In a diabetic patient, we are missing out the pathophysiology and we are just targeting the number. That is again, I would like to emphasize. So as a whole patient, we have to look at the patient and look at all the different aspects. Yes, I'll also like to reduce the LDL level by whatever measures to be taken, but I would not ignore triglyceride.
We know that when the triglycerides are more than 200, it is better to estimate a non-HDL than the HDL, with LDL, because at any number of LDL, the small dense atherogenic non-HDL is going to be high. So triglyceride needs to be treated, and in this patient, I think seraglitazole will definitely do a better job. But if the patient, because the patient has gotten history of disease, he requires statin plus either bempedoic acid or ezetimibe. Ezetimibe will be a better choice because improved trial has shown the all benefit apart and in addition that outcome benefit also, and that's why bempedoic acid is yet to show it, and so I think yeah.
We can give both
Dr.
ezetimibe
Gajendra wants to speak some.
Yeah. We can give both ezetimibe and bempedoic acid because ezetimibe having a different mechanism of action.
Yeah.
Bempedoic also shows the LDL reduction, and they require LDL reduction more than 50% in this particular case, and that is partial response to statin. So we can give both bempedoic and ezetimibe, and we will refer for Vivek.
And we also, our clinician, we know that sometimes the bempedoic acid does not reduce LDL to that level. So sometimes we have to combine statin, bempedoic acid and ezetimibe. Then only we go to the target LDL.
This, but I think I agree partially with Dr. Vivek sir, because I think most of the time we are chasing LDL, but in our patients, in our experience, we hardly see any patient.
Yeah.
So I was saying that most of our CAD patients, which we see in daily OPDs or clinics, or those who were present with MIs, most of the time their LDLs are below 130. Some of them are having LDLs below 100 also without therapy. So in them, what is the exact risk factor which is causing these events? I mean, I think that is not very clear. And regarding saroglitazole, I think it needs more evidence in terms of reduction in cardiovascular outcomes before it can be recommended.
I completely endorse, and I think there is also controversy around Fourier data from a recent meta-analysis, which says about fudge data, and then which has been again in the Fourier data for the evolocumab PCSK9. There is a recent controversy, if you would have gone through a meta-analysis, which they said that there is a hidden death which has not been reported in the later part of the follow-up. So that's why I thought this time we would keep on oral therapies.
Let me just say.
Also, icosapent is one drug which should have been added.
Inclisiran is not available.
But no, not inclisiran. Icosapent.
Icosapent, we had that debate last year, so we changed the agenda. I can't copy paste. So last year we had a talk on the data that had come from icosapentanoid.
Yeah, you know, bempedoic acid is a relatively weak drug compared to statin. Even ezetimibe is a relatively weak drug. But the moment it is combined with statin, it becomes very bad. It's just like your sitagliptin. Alone, it is a weak drug. The moment you combine it with metformin or a sulfonylurea, it brings down sugars very bad. So the same thing applies here. Use statin, reduce the LDL. If you fail to reduce it below your target level, then any of these drugs have to be added. Saroglitazole comes in a different package compared to bempedoic acid or ezetimibe. What is lacking? We have been telling the Zydus people that it is high time you have a long-term event-based study, for just like statins, like a 4S trial or something on saroglitazole. I do not know what is the status of a event-based trial over 5-year follow-up or something like that.
Yes, so they have press 6, they have press 7 designed, and I was part of press 1. So that data is to come. If I was to pitch this case with additional one risk factor of fatty liver, then probably this would have weighed very heavily in favor of saroglitazole. They have a very robust data. but I did not include that for the sake of debate. So fatty liver, diabetic dyslipidemia is one case for saroglitazar, but then as the other speaker said, you cannot neglect LDL. Thank you very much. Thank you for wonderful discussion and take home messages.
And
So-
one more thing is, which should be that this has to be taken lifetime. Even if you stop statins, the rebound starts within 48 hours.
Absolutely.
And
This-
it can be worse off in
Absolutely.
ACS.
Just like antihypertensive, they like antidiabetics. Thank you. Thank you, all the chairpersons and speaker. Your mementos, kits, and felicitations are in the kit to save time from the for the academics. We have done the same. We move. So this question was all of are correctly matched lipid lowering trials. Can next slide. So clear. So Orion 9 is not evolocumab. Next slide. It's basically inclisiran. So inclisiran is the Orion trial. Next slide. Next slide. Yeah. So that's Jayesh, next debate. Please invite the chairperson.
So herewith I would like to invite Dr. Anil Kulsrestha, Dr. Mahadev Bhai, Dr. Parag Bhai, and moderator will be Dr. Nitin Parikh, Dr. Pragnesh Vachrajani, Dhiren Bhai Mehta, and Sapan Pandey. Anil Bhai, kindly introduce the speaker.
Good afternoon. We have a case, a 55-year-old, very big blood rate of 90 beats per minute, with grade 1 hypertensive retinopathy, with BPP of 152 by 98 on ABPA, is already on ready 10 milligram, 6.25 milligram of chlorpyrifos, and 5 milligram of endocrine. His creatinine is 1.5 with eGFR of 55. Next, best drug will be. So for that, I will invite Dr. Subhash Chaudhary from Ahmedabad. He is interventional cardiologist at Epic Hospital. Dr. Senior Clinics. Today the case scenario is the 55-year male patient, hypertension with hypertension propionopathy. The blood pressure is 152 by 98 control. On the ranitidine 10 milligram with 5 milligram and chlorpyrifos 6.27.
Per day. The creatinine is 1.6 milligram percentage with eGFR is less than 60, 55 ml per kg per 1.73 meter square. Means this is stage 3A CKD. The patient heart rate is around 90 beats per minute. So basically, the patient is having an uncontrolled hypertension on the first line drugs with the CKD presentation with higher heart rate. So what is the next? Either adding the beta blocker or adding the alpha blocker or newer CCD, AC inhibitor or ARB. In this case, I will prefer the adding the beta blocker. I will say why. In the background of the CKD in the India, the today data, the 1.18 million CKD disease case is reported in the India. Out of that, around the 2 lakh new patient develop the kidney failure each year. Around 1.75 lakh patient receiving the chronic dialysis per year. What is the CKD pathophysiology? Here there is an abnormal sympathetic system in the CKD which lead to the basically increase the sympathetic activity which ultimately lead to the functional and structural alteration in the heart artery and kidney which lead to the fatal and non-fatal CV event. The second mechanism is increase the RAS activity and angiotensin II level which ultimately lead to the increase in norepinephrine release and ultimately lead to the fatal and non-fatal CV event. So basically angiotensin 2 and sympathetic activity become the detrimental for both kidneys. Chronic sympathetic excitation is a major contributor to increase the CV risk and mortality in CKD patients. In the CKD, because of the sympathetic overdrive, the patient having the high blood pressure lead to the consequences, the vascular consequences at the heart level. It lead to the increase the event of heart failure, ischemia, arrhythmia, and increasing the LVH at the arterial level. It increase lead to the vasoconstriction, increase in the case of atherosclerosis, and decrease in the arterial compliance. At the kidney level, it ultimately lead to the sodium retention, hypervolemia, proteinuria, glomerulosclerosis, and increase in the RAS activation. In the CKD, because of the sympathetic activation, the patient having the resistance hypertension, it lead to the, at the heart level, increase the LV remodeling, increasing the risk of heart failure, arterial remodeling, increase the risk of arrhythmia, increase in the heart rate, increase the O2 consumption, and increase the rate of ischemia. At the arterial level, it ultimately lead to the increase the wall thickness, decrease the distal stability. And as we know, in the kidney level, it increase the sodium retention and increase the renal blood flow. So, as in this slide, as we see, that if the CKD stage is increased, there is proportional increase in the risk of atherosclerotic CVD risk and increase in the risk of non-atherosclerotic CVD risk. In atherosclerotic CVD event, it includes the CAD, ischemic stroke, and peripheral artery disease. Whereas in the non-atherosclerotic CVD, it includes the LVH, arrhythmia, sudden cardiac death, arterial calcification, valvular calcification, hemorrhagic strokes, and other complications. So basically, the interrelation between the CVD risk factor and CKD, as we know, the cardiovascular traditional risk factor, some are CKD related risk factor for cardiovascular risk factors like the anemia, metabolic, metabolic disorders, albuminuria, inflammation, hypothyroidism, hyperhomocystinemia, oxidative stress, and malnutrition will ultimately lead to the atherosclerosis, which ultimately lead to the ischemic complication, increase the cardiovascular disease, ultimately to heart failure, increase the left ventricular hypertrophy, lead to the systolic and or diastolic dysfunction, lead to the cardiomyopathy. These three combined complications lead to the increase in the cardiovascular event and increase in the mortality. Here comes the role of beta blocker for coronary heart disease in chronic kidney disease. The scientific evidence supports the sympathetic activity is an important contributor of CHD in patient with CKD. The high prevalence and case fatality rate of CVD in the CKD patient argue for use of cardioprotective medication, especially the beta blocker in this patient. Beta blocker significantly reduce the incidence of cardiovascular endpoint in high-risk patient with CAD irrespective of kidney function. So here the point to remember, the beta blocker reduce the sympathetic overactivity, decrease the rate of mortality, decrease the event hospitalization, decrease the rate of hospitalization. In the choice of beta blocker, there is a classification of the beta blocker according to their beta 1 selectivity with intrinsic symptomatic activity and without intrinsic symptomatic activity. Here, we are commonly used the four beta blocker commonly used are the carvedilol, metoprolol, bisoprolol, and nebivolol. Although nebivolol is often characterized as a B1 selective beta blocker without intrinsic symptomatic activity, the stimulation of cardiac and endothelial B3 receptor by nebivolol, which is ISL, is associated with the nitric oxide release. This agonism at the beta 3 receptor lead to the vasodilation and has a negative inotropic effect in the myocardium. So the commonly and currently used beta blocker, out of 4, the nebivolol has no strong outcome data across the disease in patient on hemodialysis. So the 3 options left like bisoprolol, carvedilol, and metoprolol. The comparison between the carvedilol and metoprolol and mortality in maintenance hemodialysis, the carvedilol show the superiority over the metoprolol in this hemodialysis patient. So In conclusion, relative to metoprolol initiation, carvedilol initiation was associated with higher 1 year all-cause and cardiovascular mortality. One potential mechanism for this finding may be to increase the occurrence of intradialytic hypertension after the carvedilol initiation. So, according to the diacetyl, some beta blocker like atenolol, acebutolol, and metoprolol high dialysis group, while the bisoprolol and proprolol is including the low diacetyl group. While comparing these both group, the low diacetyl beta blocker are associated with higher rate of mortality in patients older than the age of 63 years receiving the long-term hemodialysis. So bisoprolol has a better outcome as compared to the metoprolol. In summary, the interconnection exists between the CVD and CKD. The sympathetic overactivity is a part of both CVD and CKD. Beta blocker should be utilized in patients with a CVD and CKD. Beta blocker therapy has been documented to be effective even with moderately or moderately severe renal dysfunction in patients on hemodialysis. Carvedilol may cause intradialytic hypertension and increase the rate of mortality. So in patients receiving the long-term dialysis, bisoprolol can be preferred due to its better beta selectivity and better outcome compared to the other beta blocker. So my choice would be a beta blocker, and it is a bisoprolol in this case. Thank you.
I'd like to invite Dr. Vishal Sharma, and we'll be talking on in this patient adding alpha blocker. He's a cardiologist, and he'll be talking regarding adding alpha blockers would be the preferred choice in this patient. He's a cardiologist in UN Mehta Hospital.
Hello. So very good afternoon to all the colleagues, seniors and juniors. My topic and my message for today afternoon is loud and very clear. That is, alpha blockers are the antihypertensive drugs of choice beyond the first line agents. So I have been given just 10 minutes, but I think I'll complete before that. I need just 6 points to say my point that alpha blockers are indeed the drugs of choice beyond the first lines in hypertensive patients. Let us start with the recommendations. Most of the international societies like the ESC, ACC, ISH, they recommend that you grade the hypertension of the patient according to their systolic and diastolic blood pressure readings. And if you have uncontrolled hypertension in the form of resistant hypertension or resistance to treat hypertension by a physician, we need to do a ABPM to classify in which category the patient belongs. Also, we now understand that it is not only the grading of the hypertension, you have to classify the patients into low risk, moderate risk, high risk, or very high risk, depending upon the other CV diseases the patient has, or the risk factors the patient has, or hypertension-related organ damage the patient has. Also, we understand that hypertension, the treatment of hypertension has been streamlined depending upon various subgroups of patient, and more or less it is similar. We start with a combination therapy, which can be a ACE-ARB with the CCB, or it can be a ACE-ARB with the diuretic. If the blood pressure is not controlled, we combine these three classes, and if still the blood pressure is not controlled with what we call a resistant or uncontrolled hypertension, we add on either alpha blocker, a beta blocker, or a spironolactone. Beta blockers have very few selected indications, which we'll be discussing in the near slides. So what is our patient? Our patient is a 55-year-old male. He's having grade 3 of CKD. His ambulatory blood pressure was done because he was uncontrolled, and it found that the mean pressure was in fact more than 150/90. He was already on the 3 first-line drugs, and I believe that they were given in their maximum tolerated dose because that was what was mentioned. So he was on ACE inhibitor, he was on CCB, he was on diuretic. His heart rate was around 90. The electrolytes, we don't know. So just to summarize, my patient was stage 2 hypertensive patient with hypertension-related organ damage in the form of CKD with a moderate CV risk. This was what our patient is. And he doesn't have any heart failure, he does not have any angina, he's not a post-MI patient, he's not having any tachyarrhythmias. So what does our patient needs? I think the answer is clear. Now patient needs alpha blocker. Why? Now, the newer alpha blockers, they have these are long-acting preparations, the GIST preparations. They are very long-acting. They have a uniform action, better pharmacokinetic and pharmacodynamic profile. The postal hypertension incidence has decreased. The blood pressure is uniformly lowered throughout the 24-hour period. The nocturnal dip is in fact preserved with alpha blockers. There is reduction in the heart rate as well. And there have been no increased incidence of heart failure apart from the ALHAT trial, which we'll also discuss in this few slides. Also, there are very potent beneficial pleiotropic effects of alpha blockers, which are not seen with other second-line and third-line antihypertensive agents. And this includes a favorable metabolic and dyslipidemic profile. It decreases the total and LDL cholesterol and increases HDL. Also, there is improved insulin sensitivity, there is improved endothelial function, and there is recovery of spontaneous reflex sensitivity. So, how do I say this? There are a lot of data to support this. We have the Associate trial, the SCOT, the BPLA, and the Tormentus trial, by which I presented this data. Now, why not a newer CCP or a newer ARB or new ACE inhibitor? Our patient can just switch over to the next CCP or add on a newer ARB, change the previous ARB. Well, when you see the hypertension guidelines and the various trials, as a stipulation, you should be able to read between the lines. In any uncontrolled hypertension without CV risk factors, if your patient is low to moderate risk, none of the trials of hypertension have shown morbidity or mortality reduction with ACE inhibitors or ARB. We have the HOPE, the CAMLET, the ALHAT. They clearly say that if your patient is on ARB, just changing the class of ARB in uncontrolled hypertension doesn't affect the morbidity and mortality. It might reduce the blood pressure to a more or little extent. And this is, again supported by the CAMLET study, the SCOT BPLA, and the ALHAT trial. CCPs, I would say neither worse nor better. But remember, CCPs as a class, they increase the adrenaline stimulation, and that can theoretically and practically increase the ischemic events. Also, I would like to emphasize in non-diabetic hypertensive CKDs with proteinuria, CCPs, they are worse. They worsen the renal function. So again, the data is supported by the NODEL and the ARS trial. Why not beta blockers? Just add beta blocker in this question. Well, again, if you see in just uncontrolled hypertension without any CV disease like MI, heart failure, beta blocker have not shown any decrease or difference in fatal, non-fatal cardiovascular events or stroke or all-cause death. In fact, I would say that there are certain papers, there have been certain studies which have shown increase in mortality and new incident diabetes in patients who have been put on beta blocker as an antihypertensive. Remember, so this is what has to be understood from the various trials that have undergone. Choosing a drug depends upon the patient, a particular patient. So you need to understand whether that patient fits into a particular trial and not take the data from the trial to treat a particular patient. So again, the SCOT BPLA trial and the LIFE trial have shown the same. Also, the guidelines that you see, they clearly say when the blood pressure is not controlled by the first-line drugs, it's either alpha blocker, spironolactone, or beta blocker. I have patient, we don't know the electrolytes. He was a stage 3 CKD. As far as beta blockers are concerned, the indications are very clear. These patients need to have some sort of cardiovascular disease, which might be, say, MI, angina, heart failure, atrial fibrillation, might be a woman or she might be pregnant. Our patient certainly is not pregnant. Now, for Indians, yes, there is no data so as to say which antihypertensive to be chosen after the first 3-line drugs. Well, at this point, I would just emphasize the ALHAT trial. The ALHAT trial was a trial after which alpha blocker almost got delisted. Initially, 20 or 30 years back, alpha blockers were one of the first-line drugs to treat hypertension, but after ALHAT, it was just blacklisted. But need to see what ALHAT actually meant. If you go deeper, ALHAT trial showed that use of alpha blockers was associated with increased incidence of heart failure. I would like to say here that all those patients who were included in the ALHAT trial, the ejection fraction, the BNP were never measured prior to the inclusion. Secondly, the heart failure assessment in the trial was done by a physician by some SHIP criteria, and a cardiologist was never consulted compulsorily, or echo was not done compulsory to say that the patient was having heart failure. Asians, or in fact Southeast Asians, were never included in this trial. At that time, longer acting preparations, the GIST preparations of alpha blockers were not available. Short acting preparations were used, which ultimately had more side effects. Finally, despite the fact that ALHAT showed that there is increased incidence of heart failure, there was never an increase in mortality with prazosin. Despite that fact, prazosin was off list after this trial. Finally, cost. I think we all know prazosin is a DPCO molecule. So the cost of prazosin is quite low. While the newer beta blockers, as we say, bisoprolol is not in DPCO. So are the newer CCBs like senlidipine or zenlidipine, or say newer AC inhibitors or ARBs for that matter as well. Certain they are also not included in DPCO. So their cost is certainly higher. We do understand the average Indian income to be around 10,000, say. For those patients who are treating themselves and their other family members, I still believe we should choose drugs which are in DPCO so that they are available to them. So just to conclude, I would agree that alpha blockers have been superseded by AC inhibitors, ARBs, CCBs, and diuretics as the first choice. Yes, that's correct. First choice is never alpha blocker. But if the first line has been exhausted, which is exhausted in almost 2/3 of the patients, which majority of the registries have shown, we need to add some. And add-on therapy, as I said, is usually indicated in most of the patients in their natural history of hypertension. Alpha blockers certainly is a definite choice in this setting. Thank you.
Thank you, Dr. Vishal. We invite our first speaker, Dr. M.K. Shah, who is going to put his case for the changing to newer calcium channel blockers and ACE inhibitors with emerging data, which may be a better option. Dr. M.K. Shah is an interventional cardiologist and he's practicing as cardiologist since 1991. And we are going to listen to him for the third aspect of the managing the hypertension in CKD. Over to you. Thank you.
Good afternoon, friends. Anybody awake here? Good afternoon. So friends, just recapitulate 55-year-old male, heart rate is 90, grade 1 hypertensive retinopathy, blood pressure 152 by 98 by ABPM, very well managed by whoever was managing, and he was on ramipril 10, chlorothalonil 6.25 and amlodipine 5. Creat is 1.6, eGFR is 55. What is the next best strategy? Well, friends, let me tell you, there is no single best strategy. None of my friends who have presented their data is wrong, but I would present what I feel is good. So, according to me, changing to a newer calcium channel blocker and ARB, optimizing the dose of diuretic would be a better strategy. Let's just understand what's there on our plate. He has an uncontrolled hypertension. It's not resistant hypertension. It's only when resistant hypertension is there, you need to look for the fourth drug. We have not used all the armamentarium we had. All right, nuclear need not be brought out. We have enough of tanks and other things if we are going to Ukraine. So I think we have enough there. Resistant hypertension is you use 3 drugs, renally adjusted, optimal dose of all antihypertensive agent, including an optimal diuretic, then you have a resistant hypertension. He has a higher sympathetic tone, but is beta blocker the best choice? Probably no. I think Dr. Chaudhary has already been effectively countered by the second speaker. So I don't need to say much against the beta blocker, but he does have a sympathetic higher tone, and I do agree it needs to be addressed too. And he does not have heart failure, angina, myocardial infarction also has been emphasized. He is just 55. He is relatively young. He has a long stint to go. Even a shade of difference we make in his cardiovascular surrogate endpoints also, it's likely to lead to much better cardiovascular outcome in a long term. The worrisome factors here are CKD stage 3A and retinopathy. We don't have much data about potassium, uric acid, albumin, creatinine ratio, echo, ECG, diabetes, etc. We presume they are within range. And he is on 3 drugs, which is on suboptimal dose. What do the guidelines say? It is very clear in guideline over here that beta blocker, when it is to be used, my colleague Dr. Vishal has already mentioned about these things, that he does not have any of those indications for beta blocker, and he is not on the optimal dose of diuretic calcium channel blocker. So to me, we are somewhere in this stage 1 and stage this first step and second step. We have not even reached the third step. So we need not take out more number of things. This is the uncontrolled hypertension we have. Uncontrolled hypertension is one of the biggest risk factor, I would say. If 75% of the people are not being optimally treated, majority of benefits which we have in the trials in terms of CV endpoint reduction are not going to be there at all. We don't need to look for other things. control the blood pressure optimally, and we'll have a lot of benefits. What are the reasons why they are not controlled? There are fourfold reasons. It could be patient related, physician related, the therapy related, or disease related. Patient related factors, we need to find out whether his lifestyle is optimal or not, and whether he is adherent to or not. And if he is not adherent, which most probably he is not, what are the reasons and how we can improve adherence? Improving adherence will give you the maximum incremental gain in terms of CV endpoint reduction. Therapeutic inertia by the physician is obviously apparent over here, and the strategies, they leave a lot to be desired, and that's why the topic of debate today. And of course, patient has an advanced vascular disease. What does retinopathy say? Retinopathy clearly tells us that even among CKD patients, it tells us that patient has an incremental risk. He has an incremental risk for cardiovascular endpoints. So we need to be far more aggressive in these patients. My proposal in this is to step up the calcium channel blocker dose as well as variety from amlodipine 5 to equivalent of 10 milligram amlodipine, that is cilnidipine 20 milligram, change from ramipril to telmisartan 80 milligram, and chlorothiazide dose to be increased to 12.5. I'm going to justify each stage. Why cilnidipine? Cilnidipine is L plus N channel blocker. What does N channel do? N channel increases the norepinephrine release from the presynaptic terminals. So it increases the local sympathetic activity into the tissue, as well as there is a spillover into the system. Norepinephrine levels are going up. Cilnidipine is going to block this release, so it will reduce the heart rate, because if the heart sympathetic activity goes down, that is where it matters. It reduces in the kidney. In the kidney, what happens? Afferent and efferent arterioles both are going to dilate. Intraglomerular pressure will come down. Glomerulosclerosis will come down. eGFR is going to increase. Protein excretion, albumin excretion, which is supposed to be an important surrogate marker both for kidney as well as for heart, it is going to come down. And other markers of renal parameters here, urine, OHDG and LFABP also is going to come down. All these things will culminate into restoration of podocin and nephrosin, and it will protect the podocyte. Now we say that it's all theory. What evidence do we have? In beta blockers, no significant evidence was shown. For alpha blocker also, there is no direct evidence. Here we have at least some evidence. When you count on an average, there is a significant reduction in heart rate. Believe me, the first generation calcium channel blockers, nifedipine, etc., we are all aware about. Patient used to come with palpitation, tachycardia, pedal edema, etc. Here there is a first time we have an evidence that there is a significant reduction 24-hour, daytime, nighttime, both. And if you take high rate morning hypertension patients who have a high morning systolic blood pressure rise, high morning pulse rate rise, and we know the chronobiology of hypertension. Early morning risers have, despite all other parameters being equal, office blood pressure controlled and equal, despite that they have a higher incidence of cardiovascular endpoints. So chronobiology is important. In this morning riser group of patients where the resting heart rate was somewhere around 85, there was 9.7 beats per minute reduction in this trial, a very significant reduction. Pedal edema is another relatively minor side effect, relatively innocuous side effect, but it leads to drug discontinuation, and we all know drug discontinuation is not good for this group of patients. And we have enough number of small trial data which shows that pedal edema definitely comes down in cilnidipine. So what is there in theory, it's there in practice. Around 10-15% incidence with amlodipine drops down to around 2%. This is some data from Andhra. Again, it showed the same thing, that tachycardia comes down, increased heart rate comes down, everything comes down. Now, what about the proteinuria? Here you can see that for the equipotent dose of cilnidipine versus amlodipine, on the left side you can see the systolic diastolic blood pressure reduction was equivalent with both. Despite that, with amlodipine there was around 15% increase in urine albumin ACR ratio versus cilnidipine where there was a 15% reduction. So that is one evidence. We might think that do we have strong evidence? This is the meta-analysis published in 2022. Almost 11 trials, more than 500 patients. Creatinine did not change between the two, but urine protein creatinine ratio definitely dropped significantly. eGFR rose significantly in favor of cilnidipine versus amlodipine. And urine protein, we know, is a very, very important surrogate marker for cardiovascular endpoint as well as renal endpoint. So on top of equivalent blood pressure reduction, if we have some incremental benefit, it's definitely desirable. When patient is on Ramipril versus telmisartan equivalence we have already been shown in many trials, but last 4 hours, again going back to the chronobiology, in last 4 to 6 hours, what happens to the blood pressure when patient is on Ramipril versus cilnidipine? And here you can see that both systolic as well as diastolic blood pressure in last 6 hours, the reduction at the end of 14 weeks with telmisartan was 14 versus Ramipril only 9. So we can have on an average 5 to 6 millimeter mercury difference. When it comes to chlorthalidone, even in patients with CKD, there is a significant reduction in blood pressure when you use optimal dose. So in CKD, we say that loop diuretics are required, but even up to stage 4 CKD, the thiazide diuretics, they keep working, and urine protein creatinine ratio definitely comes down. So overall, considering overall evidence, they can definitely be used with preserved good efficacy in patients with CKD. So this was my contention. Amlodipine changed to cilnidipine 20 milligram. That will ensure optimal renoprotection, surrogate markers, reduction in reflex tachycardia, reduction in heart rate, reduction in sympathetic activity. Ramipril to telmisartan will improve the blood pressure control as well as chronobiology last 6 hours. Chlorthalidone definitely needs to go up to 12.5. Of course, it's a CKD patient is going to require monitoring. After these are exhausted, still there is no role for beta blocker or alpha blocker. The fourth drug, as per the stepwise ESC, AHA, Indian guidelines, wherever you see, it is the spironolactone, because 25% of the resistant hypertension would come down under control with spironolactone. So friends, with that, I rest my case. Thank you very much.
Thank you, Dr. M.K. Shah. Now, first, before we go into the floor, we'll ask the first two speakers whether they have to say anything, because as per Dr. M.K. Shah, there is no role of beta blockers or alpha blocker as per the step of therapies. So what have you to say?
Dr. M.K. Shah, sir, and respected seniors. I am totally agree with both of my parallel speakers, but this patient has uncontrolled hypertension and stage this patient having the chronic kidney disease. The chronic kidney disease is a different entity where there is a sympathetic stimulation, and because of the sympathetic stimulation and correlation, the patient having a future chances of atherosclerotic and non-atherosclerotic complication of related to heart. Whether we should wait for it to happen, or whether we should wait for beta blocker like bisoprolol to go under DPCO for price control, or we should consider our patient safety first. So I think this patient is in the gray zone, but because of the sympathetic core stimulation and because of the end organ damage in case of like retinopathy, and especially due to the chronic kidney disease stage 3, I would prefer the beta blocker in this case.
All very nice presentation, sir, and also Subhash, sir. But I think 2 points coming in my mind. This scenario, the patient was on 3 first-line drugs. Never mentioned was that the best tolerable dose. So probably that might be the best tolerable dose for that patient. So just increasing the dose without understanding whether he would tolerate that would be a slight concern. Secondly, increasing telmisartan, I wanted to ask sir, with PMG and along with that spironolactone, how safe would he feel unless and until the patient is getting monitored very regularly. So these are 2 concerns, because it is never mentioned that the patient was tolerating or not tolerating why the dose of those 3 drugs were kept suboptimal. Probably that might be the best tolerated dose for that. As far as beta blockers are concerned, I think I believe in this case at least there is to go by the guidelines, go by the major trials, probably lesser role. But yes, the CCBs always can be added in this patient change. Thank you.
Any questions, comments from?
Higher the creatinine level, higher will be the dose of diuretics required, stronger will be the diuretics required. Once your EGFR drops to below 30, probably you might need to go to metolazone or even good diuretics. I think there will be enough number of nephrologists around over here. So higher dose of diuretic is not a big concern unless the guy goes into hypovolemic state. We always say that whenever there is a RAS blockade, diuretics, SGLT2 inhibitors, metformin, because the four drugs need to be stopped in case of sick days. Somebody who has a diarrhea, vomiting, migraine fever, planned surgery, angioplasty, hold it for 3-4 days and again. Post the phase, is a stage 3 second EGFR or requires creatinine 1.6. I don't think there is a great concern. And at 1.6 creatinine, anyway he is going to need anyway he is going to need monitoring. Without monitoring, some kind of food, that interaction, sometimes the Ayurvedic drugs, etc. Baba Ramdev might also come into the picture at this stage. So he would definitely need monitoring. Yeah, I would put that as a fourth choice, but Finron and spironolactone cost difference is huge. It's like David and Goliath. So I think we have to be very careful about it. And if you see Finron trials, the incremental benefit is really, really small. Not really convinced about it. I have not started.
Sir, what about the non-dihydrophilic beta blockers, calcium channel blockers like Indias and Verapam? Will take care of the heart rate also, as well as probably will have a better antiproteinuritic effect.
Yes, they will take care of the heart rate by the direct effect on the sinus. No, they are not going to take care of the increased sympathetic activity. See, we are taking care of only the last ladder of the sequence of effect which causes heart rate is just a surrogate marker. It's not the cause. So that's why I would not really consider that. And diltiazem, verapamil, already we know that in patients with heart failure, they are going to worsen heart failure. They are not a great choice so far as antihypertensive is concerned. Like Senedipine is going to take care of beta blocker, your sympathetic overdrive, as well as one more additional point here is we are still using only 3 molecules which can be combined together into one pill. And if you have one pill, your compliance level is going to jump like
that will not take care of the circadian rise in the blood pressure in the evening. So even 3 drugs, I would always give 1 drug at least in the evening time.
Right. So still there will be 2 pills. But if we add any of alpha blocker or beta blocker, we will end up with 3 or 4 pills.
Yes.
A very good discussion on this. Another drug which is very good in presence of reduced renal function, sanity, which is not very popular among us doctors. It's somewhat, its action is like that of artemisinin. Once a day it is given, rarely twice, and centrally acting, very different side effects. And renal insufficiency patient like this, 50, 55, 45 EGFR, it's very safe. Terminal renal failure, of course, it's a different matter. One can also consider it in case of resistant hypertension.
Yeah, I do agree. I'm a very strong fan of using moxonidine. Issues are coming with a lot of drowsiness and postural hypertension. But this central alpha agonist reduces the sympathetic drive by centrally reducing the sympathetic drive.
Sir, hydralazine you don't prefer?
Hydralazine again a direct vasodilator and
increases the EGFR and increases the renal circulation.
Stimulation is going to go up. Hydralazine would be one of my last choice in terms of hypertension. There are some hypertensives who need 4, 5, 6, 7, 8 molecules. That is where I use hydralazine as the last resort. Or if the patient has heart failure, then IST and hydralazine, the combination is going to work. Provided after 4 foundational drugs, pressures are still on outside, above 110.
One more point I would like to add that normally we think of proteinuria only when the patient has diabetes. when the patient has hypertension, I think we need to go for the albumin expression rate also, because that makes the difference in the outcome as well as the choice of drug. So maybe that is the take-home point, that we must start looking for proteinuria even in patients with hypertension and severe. With this, I think we conclude, and thank you all the speakers. Thank you.
Thank you so much, sir. Madhevbhai, special thanks to you. Now we'll go to another bout. I would like to invite Dr. Navneet Shah, sir. Dr. Ashok Khatri, Dr. Rajesh. Rajesh is there? I think he's there. Dr. Chintan Sagar, Dr. Anant Yadav, Dr. Ashwin Gadvi, and Dr. Rajendra Gurnani. They are going to be the co-chair. I would like to request Dr. Navneet Shah to kindly introduce our speaker, Dr. Praveen Bhai. Dr. Praveen Bhai. Sir.
Good afternoon, friend. This is bout 19, and regarding the oral anti-diabetic drugs, and probably some part of it, Dr. Praveen is going to speak about the GLP-1 receptor agonist. So, Dr. Praveen Saleh is an MD medicine and DM, and he's a consultant cardiologist and heart failure cardiologist at Dhirubhai Ambani Hospital. He is PM cardiologist from PM Medical College, and he has an extensive work experience. He is a renowned interventional cardiologist with more than 20 years of experience, and he runs heart failure clinic and practices as transplant cardiologist, and was a part of 18 heart transplant experiments. So he has number of publications, and let us hear him for the first bout, which is a GLP-1 agonist as the most proven therapy in such a high risk patient he is going to mention about in this scenario. So over to you, Dr. Praveen.
Thank you, sir. So GLP-1 agonist, that is what is the topic for me, for this lady who is 90 kilogram and already on SGLT2, metformin, acarbose and insulin. She's a post-CABG. Her weight is 90 kg, so, and she has EGFR, moderate CKD, and she is dyspneic with a diastolic dysfunction. So GLP-1 analog is very poorly understood, especially as a cardiologist, we do not understand it. It's difficult to understand because the name is GLP-1 agonist, it is like a glucagon-like peptide, so I thought it works like glucagon. But when I read it is a glucagon insulin secretor, but it is glucanostatic, so it inhibits actually glucagon. The name comes because it comes from the same gene by pre-processing where the glucagon molecule comes. So first, the name itself is a twister. Second, this is an anti-diabetic which all guidelines says it's a first-line anti-diabetic drug. The biggest concern was it was injectable. Now, some specific attribute of these drugs are, is the only anti-diabetic which secretes the insulin, but it is glucose-dependent manner. You know, like gliptins, which is another, because they are same group, incretin-like molecules. Second is the only anti-diabetic which works on cerebral nervous system, because it's going to cross blood-brain barrier, reduce appetite. Only anti-diabetic which works as GI, because it is reduce the stomach motility. It's an only anti-diabetic which strongly inhibits glucagon, as I was telling, and it only anti-diabetic which has a specific interference with leptin resistance and has a specific role in adiposity and weight, where our concern in these patients are. Now, why we do not understand? So, the anti-diabetic, both we can say liraglutide and semaglutide, they first in lower doses they are anti-diabetic, but when you go on higher doses, they become weight reducing drugs, and when they are weight reducing drug, they reduce weight even in a non-diabetic. They, like SGLT2 inhibitor now are in non-diabetic, GLP-1 analog also can be used, as a weight reducing drug. But the confusion comes because the drug doesn't, that and weight reducing dose are not available in India, and company keeps different name. For example, liraglutide we all know is a Victoza, but the higher dose, which is weight reducing dose, is sold as Saxenda in USA. So it's the same liraglutide, but it becomes confusing because it has two names. Same happens with semaglutide. Now semaglutide is a more potent GLP-1 analog, which is an injectable. Now we have oral formulation available. Now in a lower or anti-diabetic dose, they call it Ozempic, but when they write the anti-obesity drug at the 3 milligram doses, the name is as a Wegovy. So recently, the Elon Musk tweeted, "I lost 12 kg by using Wegovy." So it is same semaglutide, but now it is available also in, and unfortunately, the higher doses are not available. We do not know the story of injectable semaglutide because it's never launched in India. But if you do not understand injectable semaglutide, it is difficult to understand oral semaglutide. So injectable semaglutide has been approved first as an anti-diabetic, then it has a CVOT, which shows that it is reducing MACE events, and then 2021, it is a specific anti-obesity drug. As compared to liraglutide, semaglutide is more potent. There is a more weight reduction, more HbA1c reduction. So liraglutide reduces weight by 6 to 8%. Semaglutide will go 10 to 15%. And luckily, what we have is a oral semaglutide, which is most potent GLP-1 analog. So I think with this background, what is patient priority here? Here we want to achieve glycemic target HbA1c 8.2. We want to do better. We want weight management. Here the height is not there, but 90 kg lady, even if it is 5'6", 5'5", I believe the BMI would be more than 30. Now progression of CKD, definitely she has a CKD. We want to restore. There is a SGLT2 inhibitor is already there, which will prevent progression. But on top of SGLT2 inhibitor, GLP-1 analog also can give her an additional nephroprotection. And we definitely want to prevent an advanced cardiac event. Though she is a post-bypass, atherosclerosis is probably taken care of, but these drugs would produce the stroke. ASCVD are prone to stroke also, nephroprotection. And most important, as a heart failure or cardiologist, we are expecting this might be a high risk for atrial fibrillation and HFpEF. And these are the management issues which we believe that these all four priority can be taken by GLP-1 analog. And this is a slide where you have seen all Gliptin lectures. You listen that the incretin effect, when we eat sugar and we inject sugar, the insulin rise from oral route is more, because oral will stimulate the L cells to give GLP-1 increase, and that is called as an incretin effect. And as you go on high level of GLP-1 analog, as you can see the progressive GLP-1 activity, you have more and more side effects. In physiological doses, when you get by DPP-4 inhibitor, you have increase in insulin secretion, reducing glucagon. But as why I was explaining is higher doses, they have appetite, food, caloric intake, weight loss, gastric emptying, and even a cardiovascular efficiency. So GLP-1 analog has demonstrated a good efficiency. So average, if you speak glycemic efficiency, these are n number, all different, what you say, these GLP-1 analog, which is liraglutide, semaglutide, dulaglutide, and all of them you can see has a very significant reduction in the HbA1c, and most potent, the blue bar, is the semaglutide. Then apart from that, as I was started my presentation, these are weight loss medicines. So when last year in June in USA, injectable semaglutide in the higher doses by name of Wegovy 3 milligram was approved, and the indication was anybody with BMI more than 27 with 1 CV risk factor is a candidate, and anybody who is more than 30 BMI, irrespective, even if these are candidates. So can you guess what the population comes under the indication of the drug? US population. Any guess? 30%, 50%, 70%? 70% of population come under the indication of BMI more than 27 plus 1 CV risk factor, and not the company marketed, nobody marketed, but the drug which was produced for 6 months, 8 months was over in 2 months, and there is lack of stocks of injectable semaglutide in USA. And the YouTuber and all, they patient to patient publicity was so fast that the company didn't have the drug. So strong weight reduction. But yes, what available with us in India is liraglutide, which is in the anti-diabetic dose. It's not a weight loss dose is available, the Victoza. And what we have oral semaglutide, which is 3, 7 and 14 milligram. It is again the Ozempic dose. The pharmacology, it is not that, the weight reducing. So currently it's only an anti-diabetic drug. But even in what anti-diabetic doses, we do see a very good reduction in weight. So oral semaglutide reduces, so apart from injectable, now these are the various trials of oral semaglutide. So when you give oral semaglutide, the drug level is similar to injectable in the what we will say Ozempic dose or the anti-diabetic dose. And these anti-diabetic dose, these are various studies. And as compared to all other drugs, you can see Pioneer 2 with AMPA, Pioneer 3 with CETA, Lira, even when you compare to the liraglutide, which is a strongest, the one of the good GLP-1 analog, oral semaglutide also stands, and this is similar to what injectable does. So upper one is what we say is HbA1c or glycemic efficiency, and lower one is a weight reduction. So what we can say, like an injectable brother, the oral drug also reduces HbA1c by 1.5% and weight by approximate 5 kg. Definitely it is much more stronger to semaglutide both in HbA1c reduction as well as weight loss. And a recent US FDA labeled was that Ribelsus or GLP-1 is now the first drug in adjunct to exercise and glycemic. So till now, actually for me, when leader trial came, we started using liraglutide to reduce cardiovascular events, and it was a very good experience. So what I say that semaglutide, even in guidelines, injectable semaglutide, if you see science, injectable GLP-1 analog are first line drug, but because they are injectable, they were not that projected. But you can see now the moment oral drug is come, it has been now an adjuvant to diet, and this is a result because it's so. If you see science, it was always, I'll say, first line drug, and people say that oral semaglutide is new. I'll say it's not new drug. It is a old wine in a new bottle, because injectable semaglutide already has been seen. We have seen all the story from a weight loss drug to CVOT efficiency till anti-obesity drug. So US FDA has now given it as an initial therapy. Now our patient who is a CKD patient, we all know majority of anti-diabetics uses is a problem. Even SGLT2, which are nephroprotective, cut off GFR by in the kidney guidelines is 30, but now after we have seen the emperor reduce till even GFR of 20 we have used. Here GLP-1 analog can be used till lower GFR. The 15 GFR I think is a liraglutide cutoff. An Indian label of oral Ribelsus or oral semaglutide doesn't have any dose adjustment for even till the end stage renal disease. Now even if it's a diabetic patient has CKD, you do get the similar glycemic efficiency and weight loss, which I think not surprised that is you have a similar efficiency of the drug. But what we see, if you go with semaglutide pooled analysis in diabetic patients with CKD, what is pooled analysis? It's a combined analysis of injectable sema as well as oral sema, and what you see as there is a significant reduction in falling GFR. So what you can see on the lower is the falling GFR. This blue one with semaglutide, this is less falling GFR as compared to the routine anti-diabetic. So semaglutide versus placebo, when semaglutide is used as a top, as an injectable oral pool analysis in all form of renal failure, mild or moderate CKD, you do find a better or reduction in decline in kidney function, and definitely this mechanism is additive and different from SGLT2 inhibitor. Now GLP-1 analog has definitely reduced the MACE event. You have liraglutide, dulaglutide, as well as sustain 6, which is injectable semaglutide, and you see a reduction in MACE event 26%. And you all have heard if it's a predominant ASCVD use GLP-1 analog, predominant heart failure and CKD use SGLT2 inhibitor, but our majority of patients have everything, all problems will come in a given patient, and majority of patients are probably candidate of both of them. And this is very interesting observation with GLP-1 analog and meta-analysis from leader 6 of Lira, sustain 6 of injectable sema and oral sema pioneer 6, a 32% reduction in the stroke events. Again, MACE events, we know that GLP-1 analog has a significant reduction in MACE event. A small MACE event is reduction, SGLT2 inhibitor also, but gliptins are neutral. There is no MACE reduction, and this is what is reflected in all guidelines, which obviously all of you know. Whenever there is a prior ASCVD, GLP-1 analog is the drug of choice. But what more beyond that in cardiology, when you have an obesity, this is a more interesting CBD. This has an connection, and 80% of our patients who are HFpEF, they are basically obese. So HFpEF, most important thing is overweight, and even obesity leads to arrhythmia, atrial fibrillation, as well as ventricular tachycardia, because obesity related inflammation, epicardial fat in obese people leads to myocardial as well as atrial fibrosis. And HFpEF is one of the very common finding in type 2 diabetic. And as your BMI increases, there is beyond 25. If you see on the right side, HFpEF, the incidence goes will correlate very linearly with the body mass index, is contrast to HFrEF. And we are going to get specific trials of obesity related HFpEF and use of GLP-1 analog. So obesity definitely epicardial fat, and our patient is 66-year-old, is definitely has a high risk for development of atrial fibrillation because of her high BMI and diabetic. Weight loss and cardiac rehab, these are the two most proven therapy cardiac which improves the prognosis of HFpEF. So obesity definitely matters in cardiology because it is modifiable. So the effect of semaglutide on CV risk factor, it includes glucose metabolism, reduces body weight, reduces MACE, inflammation, lipid profile and blood pressure, and anti-atherosclerotic agent. So with this patient, I'll give proposal of GLP-1 analog, whether they want injectable, oral. It's up to the after the discussion with this patient. Now last, before I close my point, is one of the biggest benefit which I have seen in my patient, because now this patient actually is taking insulin. So these are a good patients, those who are taking multiple doses of insulin. They accept injectable therapy, and when we started using liraglutide, we have seen 50, 70 and even 100 unit reduction in insulin, and that is not too long, in a period of 3 to 6 months. And then when I went to, so it's a very large insulin sparing drug, and patients who were on say 20 basal, 14 of prandial insulin are on 15 to 16 unit insulin. So one of my maximum reduction in 4 months, I have seen patient of 180 units of insulin per day with 0.6. So I increased to lira to 1.2, but came back to 1.6, and now he is on only 22 to 24 of basal insulin. So this, what I have seen, is a very large reduction. Literature says an average 50 unit insulin sparing. So moment the insulin requirement goes down, we will not see this weight 5 kg, we will see 10 kg, 20 kg, because insulin itself will contributes a lot to the weight of these patients. And I think with that, I complete my presentation. Thank you.
Thank you, Dr. Praveen, for your excellent presentation regarding GLP-1 patient. Now, I would invite Dr. Bansi Sabu for his view on DPP-4 inhibitor, and this patient,
The same patient.
and let us hear to him.
We are not
Now,
changing the patient.
difficult to introduce Bansi, so I will not try to introduce Bansi. It is like introducing Modi Sahib in the politics, or Bachchan Sahib in the Bollywood. So Bansi is such a personality, and so he doesn't need any introduction. Over to you.
Thank you, sir. Thank you for kind words. Thank you, Kamal, once again for. But I believe it's not debate, because I'm not debating against Parveen that GLP-1 versus DPP-4, because I agree all the point that GLP-1 is the molecule which we should give to the patient with established cardiovascular disease. It is the molecule for weight reduction, so it's not direct debate, but just trying that those patients who are already on SGLT2 inhibitor, an elderly patient, maybe a more safe molecule which we can use. And we all know the benefits of the GLP-1, but how many of us are really using in our clinical practice and can use it because of the cost, because of injectable, and many more effect or side effects of the molecule too. The management on top of SGLT2 inhibitor, should I tell it favors DPP-4? Yes. Now today, if I say that it's had become almost like first choice of up to the metformin. Either you put the patient on metformin and DPP-4, or you put the patient on who is already on metformin and SGLT2. I think second choice will be definitely DPP-4, just to make that patient is using a very safe molecule. And if you are putting the patients on DPP-4, you need not to worry that patient is going to call you for any side effect. This patient is definitely overweight, obese, which I fully agree with that. EGFR is 45.7. And here, one very important point is she is above the age of 65. That's an important point. And HbA1c of 8.2 with a fasting of 208 and 282. So first, as a diabetologist, I am not comfortable with the patient who is already on a glargine, SGLT2 and alpha glucosidase inhibitor. I could not understand why diabetologist is doing. He is not up titrating the dose of insulin itself. If you have already started the patient on a glargine, let us try to target fasting sugar around 100 and 110. And why not to increase the dose of alpha glucosidase inhibitor also to achieve a post meal glucose also less than 180, and probably this patient will achieve a target control even by just putting the metformin, alpha glucosidase inhibitor, SGLT2, which is pre-oral antidiabetic. Metformin definitely in reduced dose because the patient is CKD, and if I am putting the patient on glargine, I will achieve the HbA1c of this patient less than 7 or around 7 without getting hypoglycemia with EGFR. So that's first thing which I will say, and with this case, I will first go with that. Whether I should add DPP-4 or not, that's the second part of it. We all know that use of glucose-lowering medication in the management of type 2 diabetes. I agree again with the Parveen that patient with established cardiovascular disease or with CKD, the choice will be always with SGLT2, with the GLP-1. But those who are not tolerating GLP-1 or to whom we are not writing or we are not in position to write them, then probably DPP-4 is a choice, but definitely those DPP-4 which have a established cardiovascular safety data. So like a linagliptin or a sitagliptin may be a choice of drug for those patients to whom we are not writing the GLP-1. Considering the medical history, yes, after the GLP-1, the choice will be again with the DPP-4 in addition to SGLT2 and metformin and alpha glucosidase inhibitor, which is written here, particularly for controlling the post-meal glucose level to get control. Even ADA is not talking about the alpha glucosidase inhibitor, but we Indians use it very high because of our large amount of carbs in our diet, and that's the reason for them to have a post-meal glucose level which is very, very uncontrolled for that. So treatment is definitely to keep the patient asymptomatic. Now a patient with a EGFR of 45 or less than 46 or around that, our idea to keep this patient is a keeping asymptomatic, free of acute metabolic complication to prevent development and progression of further diabetes complication, to preserve the cognitive function and physical activity, and to ensure an adequate quality of life and to avoid the drug reaction too. So factors which I have to consider. Now, if you see the RSSDA guideline, we normally consider there are 7-8 factors which starts with A. A is the age of the patient. B is the BMI. That's higher the BMI, definitely you would like to use the molecule which will reduce the weight more. C is the CKD status. D is the duration of diabetes. E is the established cardiovascular disease. F is the financing position. That's very, very important, as Parveen is coming from Mumbai and must be seeing a lot of patients who are very rich and they can afford not only the semaglutide oral, but he can ask them to get the semaglutide injectable also. That's possible, but it may not be possible for each and every Indian patient. So that's what the F. The G is the glucose control, and whatever the molecule which you are using, first you try to up titrate the dose of those molecules also to achieve a good control, and then H is the hypoglycemia risk. So risk of hypoglycemia is also very important. A elderly male, a 66-year-old female having a EGFR which is less, probably if I will put here on any other molecule which may lead to hypoglycemia, I am a bit worried for that. And for that reason, I may be adding the DPP-4. Against, I am not going against the GLP-1. Still, I will put, as far as scientific evidence is concerned, I will also go with the GLP-1, but if patient is not affording, DPP-4 could be a choice of therapy. Elderly, I will not call at the age of 66. If I will say that 66 is the elderly, some of them will kill me. So I'm not going to tell that 66 is a elderly. But type 2 diabetes, managing type 2 diabetes in a elderly population, definitely we have to worry for hypoglycemia, and that should not happen. The glycemic target may not be 7, but 7.5. 6.5 to 7.5, I always tell that it's a good on target control. You may not get less than that, and not by any condition patient should go in hypoglycemia. So in this particular patient, definitely patient is with established cardiovascular disease or a elevated cardiovascular disease. So SGLT2 and GLP-1 will definitely go for that. ADA consensus for DPP-4, it's a better glycemic durability compared to stepwise approach. For elderly and frail patient, what they are saying, DPP-4 is a safe, and easy to use option. And treatment recommendation for patient with higher cardiovascular risk, it is the stable DPP-4, the brain, it acts at the to decrease some weight reduction also, and it helps at all the, if you see the multiple pathophysiological factors which are responsible for type 2 diabetes. If you add DPP-4, SGLT2 and metformin, probably you are taking care of almost all the pathophysiological factors which are responsible for type 2 diabetes to have a hyperglycemia. So I may use DPP-4 in this patient for a safety point of view, but definitely before that, as I told you, I will increase the dose of glargine, I will increase the dose of full dose of AGI, and I will definitely see that patient's dietary control is there and patient achieve a good glycemic control with that also. The cardiovascular outcome trial with DPP-4 inhibitor, we know that with sexagliptin and with alogliptin, there was a signal of increase in hospitalization for heart failure. But that was not there with sitagliptin, which is now available in our country at a price which is 10 rupees. I mean, it's so cheap that anyone can afford to use it, and now we are using it also for large number of patients. And with the side effect profile of gliptin, if you see, it's very, very less. Hardly 3 to 4% of your patients will come and will have some complaint related to the drug interaction or drug side effects, while 97% of the patients to whom we are giving them a gliptin, patient will not come back or will not call, at least for the side effect point of view. So that's the safety profile of this, but definitely we may not go with the Sexa or alogliptin, even they are also available, but at present I will be more happy to use the Sita and linagliptin, and Sita particularly because the cost of sitagliptin in our country is very, very less, and that we can afford for each and every patient. This is the average A1C. Now, if I again compare with GLP-1 versus this sitagliptin, the average A1C is definitely less, but as I told you, the patient was not optimized the therapy by putting a 208 fasting blood sugar, giving them GLP-1. Will you able to decrease the 208 to 100? No, you have to increase the dose of glargine. So my point is, first I will definitely uptitrate the dose of existing therapy, and still if it not be controlled, my choice may be gliptin because it also decrease A1C roughly between 0.5 to 8. And these are the one of the paper which has been published from India also in a combination of using SGLT2 and DPP-4. Now, why I will use DPP-4? This could be the second reason, because we have now fixed dose combination available with SGLT2 and metformin. And if I want, even a low dose of metformin can be also added in the same group. So that is one of the advantage. A 66-year-old female, if you give her all multiple different type of medication, like using a oral semaglutide and asking her to get up early in the morning at 6 o'clock with 120 ml to drink, to take that medication, and then to remain for 1 hour, not to take anything. And if she is a patient of a thyroid, probably she has to, after getting up, first she has to take the Rybelsus, then again after 1 hour, she has to take the thyroid medication, and then again she has to wait for another 1 hour to have a cup of tea. So that could be again cumbersome for a 66-year-old female. So now with the combination therapy, particularly when this particular type of patients, I may use Sita, metformin and SGLT2 in a one tablet, and maybe acarbose which she is taking, maybe from 25 I will make 50 milligram 3 times daily, and still I can achieve a tight glycemic control. And this is the paper where we had used that SGLT2 and DPP-4 in a Indian patients in a fixed dose combination, how effective it is. And based on CV risk and including heart failure, definitely with a patient with a very heart failure, still we know that there is a black box warning for DPP-4 inhibitor, but they say that the molecules which can be used more of a cardiac safe, like particularly linagliptin and sitagliptin, can be used, but not with established cardiovascular. I mean, with the heart failure, I may be a bit worried again, even with the sitagliptin also. But for CKD, definitely. For CKD, sitagliptin can be reduced at a reduced dose, and the linagliptin can be given even without any dose modification. Also, these are the also molecules DPP-4, SGLT2, along with metformin. There is a significant weight loss, and now with alpha glucosidase inhibitor also had shown there is a weight reduction. So yes, weight is a concern for this patient. I may not go with the semaglutide, which may reduce the weight of my patient by 15 kg, but even 5% weight reduction will also improve a lot of metabolic profile for this particular patient, and that is enough for her to have a lot of benefit of weight reduction too. The strategy for these patients to start with metformin, DPP-4 and SGLT2 and AGI whenever we want to use. So age is a very important. I would like to use one of the most safe drug with fixed dose combination. Comorbid condition, as I understand, CVD, heart failure, CKD, no harm because I am going to use a molecule which is safe for heart. Benefit risk ratio, definitely it is positive because of the cost effectiveness also, and it has got a sound clinical experience. All of us have used gliptin in last 15 years and we all are happy to use it. No risk of increasing hypoglycemia. And one very important point again which I am putting here, that the cost, which is very, very important for Indian patient, and many of our patients, they are ideal candidate to start with them on a semaglutide or on liraglutide, but because of the cost, we just can't use for these patients. So my take home message is individualized treatment strategy and targets for a elderly people with diabetes are now recommended by international guideline in order to achieve optimum risk to benefit ratio. Hypoglycemia, which is the most common and serious side effect in these patients, is of particular concern because it often occurs unexpectedly. The risk to benefit ratio of DPP-4 inhibitors may provide a valid treatment alternative in older patients with type 2 diabetes. DPP-4 inhibitors ensure high rate of adequate glycemic control, are associated with low risk of hypoglycemia, appear to have a neutral effect on body weight, and can potentially improve the quality of life. If necessary, a dose adjustment, which is required when the EGFR is decreasing, can ensure safe use even in the presence of advanced kidney failure. So this will be the only molecule probably which I may give the patient, and then I can tell that even your EGFR goes from 45 to 30 and 20 or even 10, you can still continue to use the linagliptin without any dose modification. With this, I once again thank you, Dr. Kamal and Cardiocon Organizing Committee for giving me an opportunity. Thank you, sir.
Thank you, Dr. Bansi. Now I would introduce you his friend Dr. Sheshadri from Chennai. He is the Krishna of diabetes in India, and he's a very thorough academician and done a lot of work in the field of diabetes. He is a US trained endocrinologist, and not only that, he is profoundly knowledgeable in diabetes, but his knowledge in Sanskrit and the Vedas are also very great. So I'm really impressed with him. And he is going to speak about the new molecule which has just entered into our Indian market, which is siligliptin, and he will enlighten us regarding this new molecule. So what do you think?
Thank you, Navneet. It's always a pleasure to be around you. Banshi, colleagues, Dr. Kamal Sharma. I'm sort of disadvantaged because I've been pitted against two molecules that are established and importantly have a lot of clinical data. But if you're a person who invests in stocks, you invest in potential and not in just performance. I know that Banshi bought Titan about 20 years ago, and that's why, he's carefree today. So I think what we need to do is to talk about the potential of how we go into the next generation of therapies for diabetes and heart failure and heart disease, right? So since this is a cardiology meeting, I thought I would talk about the heart and how diabetes works. So the mitochondria this is the bioenergetics of the heart. In health, I don't know how many of you remember your Guyton days. Life is ATP to ADP and back. That's it. That's all life does. What we do is we produce about 65 kilograms of ATP per day and we consume it. Now, 8% of the ATP, and remember that the heart is only 1 to 2% of the body weight. 8% of the ATP is consumed by the heart. It has the highest mitochondrial content of any tissue, right? So there's an energy demand to the heart, and this is contributed by synthesis, transport, phosphorylation. Heart rate consumes energy, right? Relaxation and contraction consumes energy. This is supplied by two. One is glycolysis and something called oxphos. What is interesting to remember is while glucose is one of the most preferred fuels for the brain, the heart gets all its fuel by lipid oxidation. And I'll talk to you about it because that's where the problem also lies. Right? So if you look at the heart muscle, a majority of the muscle has mitochondria in it. And one of the important parts is something that we learned in medical school, and most of us slept through it, is the respiratory chain. I'll talk about it again later. But what happens is there are two sets of fuels that come into the respiratory chain. One is from the tricyclic carboxylic acid cycle, which is, and this is glucose, and from acetoacetate, which is the fatty acids. In the respiratory cycle, hydrogen ion is exported into the inner membrane, and at some point of time it creates a gradient, and some of the hydrogen ion leaks back. This is called the uncoupled protein response, and this converts ATP to ADP. And this production of ATP is responsible in the pancreas for production of insulin, and in the heart for calcium cycling. In fact, one of the most important parts of what happens in the heart is calcium cycling. So the mitochondria deals with calcium cycling, and it's this calcium that comes into the cytosol that drives contractility, right? The third part is the production of some amount of superoxide dismutase and free radicals, which are all right normally, but if they accumulate, they create problems. I won't deal with this in detail, but just remember this is what is happening in the mitochondria. The mitochondria are so important that they have their own cycle. And what happens is they are able to recycle. Some of them, they fuse, they undergo fission. But what happens is the bad mitochondria are quickly destroyed and new good mitochondria are created. This is what is happening in the heart. And that is why your heart does not have to stop. That is why it keeps pumping. And that is why it's doing what it does. Right? But what happens in diabetes? What happens in heart failure is there is profound mitochondrial dysfunction, and that is what is causing your heart failure. What you're seeing as a sympathetic nervous system overactivity, what you're seeing as other things are the consequence of heart failure and the body's response to heart failure. But what is at the root of cardiomyopathy, cardiovascular dysfunction, perfusion re-injury? All of these are mitochondrial dysfunction. So here is the mitochondria, here is the myofiber, and can you see what happens? That during it normally ATP is present, the contraction and relaxation are very good. When ATP production comes down or ATP production is inefficient, both of these are not doing well, you get heart failure. So far, we've heard from everyone today about the response of the body to this problem. But the idea is in future, we will start addressing what is the actual problem, which is the mitochondrial bioenergetics. So for example, normally what happens is, I talked about the respiratory chain, the hydrogen ion is pumped into the inner membrane, and then some of it leaks back. But what happens when fuels accumulate, when we eat too much, when there is failure, the ions come back in a much greater amount. Scavenger molecules are present. Superoxide dismutase doesn't work. Free radicals take place. The mitochondria dysfunctions, and therefore contractility comes down. This is what is happening there. So what is happening here? Let us go back to this picture. In heart failure, normally in mitochondrial dysfunction occurs, increased ROS, decreased electron chain transport, decreased calcium input. There is redox buffering. What does this lead to? HFpEF and HFrEF, right? So we think about HFpEF and HFrEF as a cause, but it's actually a consequence. So diabetes does even more. In diabetes, there's a mixture of fuels. Normally in the day, glucose is the fuel. In the night, fatty acids are the fuel. But in diabetes, we are eating too much. Both fuels are available. And what happens in the heart is, Normally, the heart just takes fatty acids to a large extent. But when there is heart failure, when there is an ischemic event, the heart actually starting to use glucose. It starts using glycolytic pathways. And that actually is more efficient. But what really happens is the fat intake into the heart does not come down. The heart continues to take the fat in, and these accumulate in the mitochondria, and the mitochondria undergoes dysfunction. I'm simplifying a lot of things here, but please understand what is happening here. So in cardiac disease, there are different things that can happen in the heart and the mitochondria. So one of this is that the fusion and fission that I talked about could be wrong. Mitophagy can go wrong. Calcium transport can go wrong. But at the base of all of this, the electron transport chain is the problem. This leads to cardiomyopathies, myocardial ischemia, and reperfusion. Until this time, we never knew how to address this. Our current paradigms are, you try to decrease the energy demand on the heart. Every kind of treatment that we're using, beta blockers, ACE, ARB, hydralazine, nitrates, I heard a lot of stuff. I'm not a cardiologist, but what it does is, it reduces the energy demand on the heart. It does not address the supply issue. It does not address the mitochondrial capacity, the increase in the ROS, or in the ETC. And that's why we have drugs now, and in the next few years, drugs that will come in that actually address the mitochondria. So I spent so much time trying to introduce this new molecule that actually works at the level of the electron transport chain. Remember that the electron transport chain has about 5 complexes. To the complex 1 and 2, fuel is supplied. This pushes hydrogen ion into the membrane, and there are some rate limiting steps. It's coenzyme Q, the cytochrome C. At the end of it, one hydrogen ion comes back and ATP gets converted to ATP. This is the basis of the electron transport chain. Imiglamin is a first-in-class molecule. It has not been there before, and it doesn't have Western powers and Western marketing technology to push it. But it's approved in Japan, which is tougher than the US FDA. It's available in Korea, and now for the last 3 months, it's available in India. What does it do? Because it works on the mitochondria, it improves both insulin production as well as insulin sensitivity. It also reduces hepatic gluconeogenesis, and because it works on mitophagy and autophagy, reduces beta cell apoptosis. Now, how do you look at imiglamin? Can you see this is metformin? If metformin gets a cap on it, it becomes imiglamin. You put a cap on metformin, you get imiglamin, right? But it's even more than that. It actually goes beyond metformin, and there are some multiple differences. How does imiglamin work? I said the respiratory chain is important. 1 second. It works at the respiratory chain. It reduces ROS influx, and it allows fatty acids to be completed. I'll spend 2 minutes on this. Just before we go on, the therapeutic dose is about 1000 milligrams twice daily, a half-life of 13 hours. In renal impairment, it can be used. Reduce the dose to 500 milligrams BID. Not contraindicated in heart failure, not contraindicated in renal failure, not contraindicated in hepatic failure, and I'll actually show you some animal data that shows that it may be beneficial. How does imiglamin work? What it does is, it improves the uptake of the electron chain in this third part. So it sort of bypasses 1 and 2 and takes the hydrogen ion chain directly and improves the third part is where the synthesis of the hydrogen ion chain occurs. All the substrates are coming, hydrogen ion is present, and it's pushed up, right? The second thing it does is, it increases the substrate for NAD to NADH. This important protein is NAPTMP, and it's an enzyme that increases the production of NAD to NADH. That's where imiglamin works. The third thing is, like metformin, but metformin does it irreversibly. It inhibits the action in 1, which is where the fatty acid goes. So it sort of reduces the amount of fatty acid dependence into the this thing, and it prevents accumulation of fatty acids. Lastly, and very importantly, what happens in diabetes, what happens in heart failure, what happens in mitochondrial dysfunction is this pore called the PTP. It's a permeability pore gets opened in the mitochondria. When that happens, toxins get released into the system, mitochondria get destroyed, the cells get destroyed. What imigliment does is it prevents the PTP pores from being opened. Therefore, it preserves mitochondrial longevity. Right? So this is what it does. Let me summarize it. Increases C3 activity, increases the amount of NAD, increases potassium and ATP closure, indirectly works on calcium flux, which is very, very important for the heart, increases insulin in the beta cell, and increases calcium and contractility in the heart. It also works in the other spaces, increases insulin sensitivity, increases downstream signaling. What it really does is, it's one of the first in class drugs that works in the bioenergetics of the cell. Metformin is an old agent, it does work on the mitochondria, but here is a 10-time improvement on what metformin does. Right? So I'm just going to show some animal models because we really don't have human studies on many of this. Some of these are ongoing. This is looking at urine models where left ventricular end diastolic diameter and left ventricular shortening with hemoglobin, right? This is showing in an HFpEF model of mice what happens. There's prevention of progression of HFpEF and actually improvement in contractility. This is its action on acetylcholine-induced septal relaxation, showing that there is clearly improvement in LV contraction and LV coronary relaxation. This is looking at renal function. This is a murine model, but look at what is happening. There's a reduction in the glomerular injury, reduction in interstitial fibrosis, and if you notice, there's an improvement in albuminuria. We are looking at human studies that are coming, but these look very distant. So to sort of summarize, and remember I showed you what is the basis, what is happening, what is the current therapy. So what will be the next generation therapies? That includes hemoglobin. There's an increase in biogenesis, restoration of mitochondrial function, increase in electron change transport. Future drugs will increase cardiolipin and redox buffering capacity. So I think it's time to start thinking about the next generation therapies today, because yesterday is history, tomorrow is a mystery, but today is a gift. That's why it's called the present. The present, we have a molecule that has potential, that has promise, and it doesn't have the Western backing of big pharma, but I think a lot of Indian companies have taken it up. It's very safe. It is not contraindicated in cardiac failure, not contraindicated in renal failure, and it's time we give it a try. Thank you so much.
Thank you, Krishna Seshwardari. And now it's the time for question answers. I would invite all the three speakers on the dais and Praveen, Bansi, and Vince. Yeah. So before we start, I think that it would have been better if the duration of diabetes could have mentioned in the case and BMI would have been mentioned in the case. So these two things are very important when we are talking about the determination of the drug therapy. So any questions from the audience?
Sir, in addition to what he says, that actually it reduces the insulin resistance also, sir. So that is an added advantage. It acts both centrally and peripherally.
Immediately.
Immediately. It's known to reduce the insulin resistance. Yep. Sadly, sir, since you have mentioned it as a mitochondrial modulator, I think it's a drug of it can work on each and every organ, each and every system, and it should be a game changer. I think it should be a next year. It will say that before hemogenesis or hepatic cell also, it will predates thus before inflammation, peripheral muscle, all the tissue have been addressed.
Only thing I can make the matter is if you say the
So I think, except the injectables and maybe, a higher dose of sulfonylurea, any drug that we have used, 0.5 to 0.8, depending on what we have. Yeah, only if your basal A1C is 12, you will find anything more than 1. So most of our drugs are modest A1C reducers that include the DPP4, that include metformin, that includes the same. I think what imeclamin does is, one, it gives, for example, the reason I made this very cardiac is because it's a cardiology conference. But what is interesting to understand is that today the recommendation for stage B heart failure is to stop DPP4, stop thiazolidinediones, stop sulfonylureas. This is the latest ADA-ACC consensus statement. So clearly, what are we left with? An SGLT2 inhibitor, an imeclamin, and GLP-1RA. That's it. Once you hit stage B, some of your traditional drugs are already gone. So that is one of the reasons I think, having a new molecule that works makes a lot of sense to it. And the reason I spent all this time on the heart and not anything else is because, understanding bioenergetics of the heart is looking at future therapies, right? For example, what does SGLT2 inhibitor does? The heart preferentially takes fatty acids as opposed to the brain. But when you have heart failure, there's a lot of glycolytic pathway that goes into it. And any amount of ketones add to it because ketones are slightly more energy efficient than. But the amount of ketones that are made are not sufficient to meet the demands of the heart. That's why it helps, it improves the efficiency. But if you use a mitochondrial modulator, I'm not saying imeclamin is already doing this very well. We need data to support it. But I think when you have mitochondrial modulators, you're addressing the supply side. And I think that's where the game changer is. There may be more powerful modulators that are coming in. There are several on trials already. But I think what we have is the first drug of the future.
Multiple companies are there. And I think
Trimec is the name. Trimec. Trimec is the
Imeclamin is from
proprietary
Torrent Farm.
Trimec is the proprietary name.
Other companies
And
have also
1000 milligram is the
so. We are not here for discussing the cost of therapy. But I
this is a
personally
part
feel
of
there are
system.
two challenges with this new molecule. One, any molecule which is having is only one part is better compared to when multiple parts. I'm talking from the industry point of view. The reason I'm telling you, the original scientific evidence and the clinical trials and data are not published. Most of the Japanese companies, they come out with the molecule. They don't come out with a lot of evidence, scientific effort. Only few studies are there, and then it is left out to the world, and few of the Indian companies, they just pick up that molecule and not doing any further study, and they just try to sell it as whatever the data which is published in the Japan. It is not like the SGLT2 came in the market. The Remo also was coming from the Japan molecule, and they had not done any study for it. So it is like Kena or DAPA, they have done, and they have gone up to the cardiovascular outcome trial. Even now the US FDA is not giving any mandate that any new anti-diabetic molecule is coming should have a cardiovascular outcome trial. So the purpose of treating diabetes is just not the glucose lowering. It's not just simple glucose lowering is required. Yes, imeclamin is much more than that because it is a mitochondrial modulator which is going to, I think, for prevention of diabetes, and maybe it may be used for a molecule for prevention of diabetes complication too. But primarily we are treating diabetes not for just glucose control. We are treating diabetes for preventing the complication. And unless a molecule comes which also gives the evidence that it is going to prevent the complication. Now the story of saroglitazar, it's a fantastic drug.
If you had used it saroglitazar with a 400 plus triglyceride, you will find in next 3 months your triglyceride had come down to 120 and you are absolutely fine. So as far as number is concerned, your next report will be absolutely fine. But does the triglyceride reduction reduce the cardiovascular mortality? We don't have the answer. And that's the reason we are not using it also for each and every patient of hypertension. You may have an indirect evidence with echo trial that those patients whose triglyceride was more than 200 and 180, they found to have more cardiovascular mortality. These are all indirect evidence. You may have the evidence for low vitamin D with high metabolic syndrome and higher cardiovascular mortality, but by giving vitamin D, does it reduce the cardiovascular mortality? That is more important. So unless those type of study will come, the physicians community, the scientist community would not like to write each and every patient who is coming to their clinic a newer molecule. They will be, they will feel that yes, one more medicine we can write. The similar type of medicines from Ayurveda also, they say that this can, complications can be prevented, this can reduce your weight, this will improve this will do that. But unless we have evidence, we don't use all those molecules.
The mechanism of action is very important. Mechanism of action is on mitochondria. Till now, we don't have any model. Right? And it has been introduced only in June 2021. So you have to keep time.
I think what we should do is take the balance view. One is I think the industry in India should start putting in data. I think and publishing data because that's important. All of us are interested in it, but I think they need to continue and publish data. I think that's very important. Saroglitazar got lucky because it found a new father in NAFL, and big father because it got an orphan drug status for primary biliary cirrhosis, and I think they have data going. I think imiglamin has a lot of promise, but more importantly, I think the way I look at it is today we were able to talk about mitochondria and the heart, and that was the fun part of it for me. Right. I think it'll have use across the spectrum. Initially, you're going to find people using it. For example, let me sort of if somebody has right now, I'll tell you what will happen. Somebody is not tolerating metformin, you'll find a lot of people switching to imiglamin. It's a simple way to do things, right? Second, you will find it as an add-on to one or two drugs, especially in the metformin intolerant people. Third, and I'm maybe I don't know about this pre-diabetes business, but it's interesting, but we need trials. Correct. Third, I think the most important in a cardiology audience.
Diabetic no study either.
In a cardiology audience, let me tell you, the very important place for this is in somebody with HFpEF or a stage B, where you can't use the other. Right, but it doesn't cost. Absolutely. So at this point of time, this is what you should. Yes. Absolutely. So I'm certain, now that it's 3 months in the molecule, we are going to have a lot of real world evidence that is already coming. You're right.
Yes. First of all, good evening to all chairpersons. As you said, just focusing on this case right now, the next line of anti-diabetic medication, apart from diet and above medications, would be
GLP-1 in this particular patient.
But then, should we stop metformin and then start imiglamin 1000 BD?
So anyway, what is going to happen is that this person has
just a cap of metformin.
You can add it to metformin. You can add it to metformin. One. Remember that if the EGFR is less than 45, metformin dose needs to come down. Imiglamin dose also needs to come down. At an EGFR of 30, metformin goes away, imiglamin stays.
So out of the two, according to you, the current scenario, the years, the GLP-1, especially when it is coming in the oral form, so there is a hidden competition between these two molecules. And all of you agree that it is a better molecule to start. Considering that, I don't think it may be in the current competition, as you say. But how much time it takes for us? Same question was arised. How much time as a Indian doctor we need? Maybe more 5 years of experience. What's coming on?
Can I tell you something? I don't think you're going to get a CV outcome trial on this. One, it's not required, but it won't
How
come.
will we decide that which one is a better molecule? Especially if we don't have a study from Japan or US.
Okay, let me put it this way. A lot of times you don't need to find out which is a better molecule. You need to find out which is a molecule for your patient. Right? In this patient who has established
cardiac already, post
Right.
CVT patient.
if this patient requires a GLP-1 RA, right? But imiclemin can be an add-on, right? Imiclemin can be an add-on, but this patient needs a GLP-1 RA.
That is established. That is what I'm saying. That how many years as a Indian doctors a molecule which really doesn't have a data.
So let's look at the history of SGLT2 inhibitors. When SGLT2 inhibitors came, people were using it as a third line. Today, most cardiologists and even us use it as, I'll be very honest, I use it even before metformin. Right? Right? So see how it is experience that drives that upward mobility of any molecule. As we use it, irrespective of what, see, evidence lasts for 2 years. We look at evidence for what we need for 2 years. After that, what we do, our own personal choices. Most of our practices, absolutely, absolutely, we should have evidence. So I know how much industry is here. Absolutely, that's exact. I mean, in fact, I've been talking to all of these guys. Let's get some RWE here.
So I think we should end.
Thank you.
हाँ चा पीता पीता बात करो साहब and she will guide you how to proceed. Commercial કેવી રીતે બનાવવી So it is such a wonderful discussion. Now we'll go to the another bout. I would like to. Now we will start with, I would like to request Dr. Tarun Madan, Dr. Satish Bhatta, Bhatia, I'm sorry, Surendra Kumar, Prakash Vazirani, Bhagirat, please, Bhagirat bhai. Shabim, Dr. Shashi Mundra and Dr. Sachin Patel. They will be the co-chair. Sir, તમે Prakash Vazirani, Dr. Solanki, Dr. Shashi Mundra, and Dr. Sachin Patel. Other two people have not. Sir, kindly introduce the subject and.
So we are moving to the bout 20, sorry, the high risk CAD and long-term antithrombotic strategy beyond a year. And for that, we have two sides. The red corner will be represented by Dr. Jay Shah, and the blue corner will be represented by Tarun Dave sir. The pretext is that there is a 70-year-old male diabetic hypertensive with dyslipidemia. This is usual patients which we see, and he has a past history of CV stroke 6 years before, and with a near complete recovery and past PTCA status with 3 stents 1 year back for an inferior MI. He has a strong positive family history, and he comes for a follow-up. And apart from his medical optimization and lifestyle modification, the best strategy of risk reduction should be whether rivaroxaban in a very small dose, BID 2.5, with antiplatelet aspirin, and that will be represented by Dr. Jay Shah. And the second blue corner will be represented in the form of ticagrelor 60 BD with antiplatelet aspirin, will be represented by Dr. Tarun Dave. I will request to introduce Dr. Jay Shah.
Dr. Jay is a senior interventional cardiologist. He's a close friend. We started together. He's practicing as a consultant at HCG Group of Hospitals. He's a founder member and vice president of Chris Short Foundation. And he is a teacher for DNB cardiology students at HCG Hospital. He's also attached with Star Hospital, Bapunagar and Life Care Institute of Medical Sciences. He holds a DNB cardiology from prestigious UN Mehta Institute. And without wasting the time, I request him to start the talk. Thank you.
Thank you. Thank you so much, Tarun. Respected Vazirani sir, Bhagirath sir, and all the distinguished faculties here. Special thanks to Kamal bhai and the whole team of Cardicon for inviting us and keeping this a very interesting debate or case-based debate for this particular August audience. So the case which has been given to me is 70-year-old male, diabetic, hypertensive, dyslipidemia. Each word is very important. Strong family history with past history of severe stroke 6 years back with a near complete recovery, post PTCA with multiple stents and having a history of inferior MI 1 year back, comes for the follow-up. Apart from medical optimization and lifestyle modification, therapeutic lifestyle modification, best strategies for risk reduction. So here the word is risk reduction, where this particular subset of patient can be put, and for that the role of rivaroxaban and aspirin is being given to me. Why is it so? Because this particular patient is falling into the category of chronic coronary syndrome. We all know about ACS, which is STEMI, non-STEMI or unstable angina. But chronic coronary syndrome is a conglomeration of multiple disease or a group of disease, which is starting from stable angina to new onset heart failure with stable CAD, stabilized symptoms in less than 1 year of post-ACS event. Here in our class or in our case, it is patient with more than 1 year after initial diagnosis or revascularization, vasospastic angina and asymptomatic CAD. All these 6 classes are considered as a chronic coronary syndrome patient on the basis of 2019 ESC guideline. Now the information which I want, apart from the information which has been provided to me, is what is the LV function on an echocardiography, what is the Doppler study, whether the multiple stents are there in the multiple vessels or multi-stents in a single vessel. What is the renal function? I need to be very careful when I'm choosing any strategy regarding the eGFR, history of smoking or tobacco in any form, and is there any presence of peripheral arterial disease, because patient is already having a CAD and cerebrovascular disease. So we need to find out whether the patient is having coexisting PAD or not. These are the information which are required, because my approach or anybody's approach should be more comprehensive and it should be patient centric. So when we are talking about this particular case, atherothrombosis. Now this is the word. It is not atherosclerosis. It is atherothrombosis, which is unpredictable and life-threatening consequences of chronic and progressive atherosclerosis. And here you can see that whenever the patient is having severe death, MI or stroke, altogether the incidences are increasing. It is crossing more than 8% a year. Now look at our patient. Our patient is 70-year-old male, atherosclerotic. Look at the history of cardiovascular disease. Yes, number 1. Number 2, history of MI. Yes. History of severe stroke. That is also there. And history of multiple stents. Now, just by this history, you can make one thing very sure, that whenever there is a presence of history of stroke or MI, the number of years or the longevity or the lifespan is getting reduced. You can see that it is 12 years lesser in a patient who is already having stroke. So we need to be very careful in choosing the molecule, which has got a mortality benefit, which has got a survival benefit. And that is the reason whenever we are choosing any molecule, we always look for the 3 TMAs. That is CV death, MI, and stroke. Here is the registry, which is a REACH registry, involving almost 65,000 patients, more than 45 years of age, and with a prior ischemic history of more than 1 year, almost 20% of the patient, they are having an increased risk of CV death, MI, and stroke at the end of 4 years. So is my patient falling into the category of COMPASS? Yes. COMPASS eligibility criteria requires the presence of prior MI, multiple vessel disease, multiple stents, age of the patient more than 65, additional risk factor like diabetes. We do not know whether the patient is having any history of current smoking or not, but if it is there, then yes, it is one of the major risk. If there is any presence of peripheral artery disease, that also requires to be added, and there is an already an established history of CV stroke which was happened before 6 years. So where does our patient stand? If I look at the guidelines, then 2019 European guideline or Canadian guideline and 2020 ACS guideline on non-ST elevation MI, both are saying that those patients who are having diffuse multivessel CAD, at least one of the following criteria, which includes diabetes, CV stroke, prior MI, technical aspects, multiple stents or multiple lesions, or if there is a presence of any stent failure in the previous history, that needs to be taken as a high ischemic risk category. Now here in our patients, we all know that this patient is at very high risk as far as the thrombotic risk is concerned or atherothrombosis is concerned. And because of that, we are always looking at the enrichment criteria. Now, which are these criteria? These are the criteria which are making the patient for making them eligible for the COMPASS category. Why is it important? Because whenever you have multiple risks or age more than 65, which is there in our case, number 1, diabetes, that is number 2, history of ischemic stroke, that is number 3. Say for example, if the patient is having LV dysfunction, then there is heart failure. So as you go on increasing the number of risk factor, the net clinical benefit is also going to get increased with the help of dual pathway inhibition. And that is what enrichment criteria means. And that is the reason this patient is definitely going to get benefited highly by giving dual pathway inhibition therapy. So DPI is a proven effective option as far as the European guideline concerned in a high ischemic risk chronic coronary syndrome patient. And here the recommendation is being given to aspirin along with the rivaroxaban in a vascular dose, that is 2.5 mg twice daily after 12 months of DAPT in a patient who has received ACS PCI or in this case infeasible MI having stent placement. After 12 months, you can always subject this patient to receive rivaroxaban 2.5 mg along with aspirin. And why is it so? Because in a chronic phase, you are not much dealing with the platelet activation, but you are more dealing with the prolonged thrombin generation. And that is the reason in a chronic phase, you require a drug which has got a dual pathway inhibition, which will help in significantly reducing severe death, stroke, and MI. And here you can see that in COMPASS, there is a 24% relative risk reduction by giving rivaroxaban plus aspirin vis-a-vis rivaroxaban alone in a higher dose of 5 mg or aspirin. Extremely important point is in this slide. Why we are choosing rivaroxaban? Because it is the only drug which is not only having a reduction in the MACE, but it is having reduction in the all-cause mortality. Now let me know a number of drugs which are having all-cause mortality benefit. In cardiology, you have ARNI, you have SGLT2 inhibitor, you have beta blocker, and statin. Apart from that, if you have any other molecule apart from this standard molecule is rivaroxaban, which has got a all-cause mortality benefit. On top of that, there is a reduction of the stroke. That is 42% reduction of the stroke, which has already been studied with an acceptable bleeding profile with DPI regimen. There is no evidence of fatal or intracranial bleeding, which was low or similar in both the groups. So irrespective of the history of MI, whether it is less than 1 year or 10 years, irrespective of the history of PCI, whether it has been done or not, rivaroxaban aspirin combination is going to favor as compared to the placebo. Because stroke reduction, which is very important, it is the only molecule which has got a stroke reduction, which is even better than any other dual antiplatelet or other P2 alpha receptor inhibitor like clopidogrel, prasugrel, or ticagrelor, which was being studied in Karishma trial, DAPT trial, or Pegasus TB54, where none of the molecule has shown any significant reduction in the stroke, which is being there with DPI or a rivaroxaban. So net clinical benefit is being established with a reduction in the CV outcome or a CV events, which is significant. As the months passes, the benefit is getting increased with a very, very acceptable bleeding profile. Previous PCI or no PCI, whether the patient is having any history of MI or not, or prior MI which is more than 1 year, all these factors are getting a consistent reduction in the benefit, consistent reduction in the benefits of MACE events, which is not there with the thymic PCI. 2 minutes. So Pegasus, which was being compared against Compass, Pegasus is the trial of ticagrelor, where MACE reduction, modified major bleeding, which is not the case with rivaroxaban, and all-cause mortality. This is the differentiating point, which is 23% relative risk reduction, which is there in more than 24,000 patients in Compass arm as compared to Pegasus. If I'm looking at Compass PCI and Themis PCI trial, here also in Compass PCI, all-cause mortality and CV mortality are getting reduced with rivaroxaban as compared to ticagrelor. And that is the reason I think in my case, I would always choose rivaroxaban aspirin combination as compared to any of the other antiplatelet therapy, because of the fact that the patient is very high risk, patient is atherothrombotic with an acceptable bleeding margin. I would always keep my patient on a drug which has already been proven, which has already been established in the guideline, and it is the only molecule which has got a significant reduction in the all-cause mortality with a modest reduction in the MI, stroke, CV death, and MACE with an acceptable bleeding profile. I would always choose DPI in this particular case. So just nutshell, CC at high or a moderate ischemic risk and a low bleeding risk case, whether my patient is having previous MI, yes. If the year are less than 1 to 3 year, yes. Either rivaroxaban or ticagrelor, but if there is a previous history of stroke, then I would always choose DPI. In my case, I would always choose rivaroxaban. And in a multivessel disease or a multiple stent, then also I am going to use rivaroxaban. Thank you.
Calling next week.
I think that was an excellent talk, Dr. Che. You have put your points very well. And to call the next speaker who would be speaking as in the blue corner, would invite Dr. Tarun Dave to speak on his talk in the same patient background with a different molecule. And then maybe we can have question and answers later on. Would request Dr. Prakash sir to introduce our speaker. Please play the slide, Dr. Tarun Dave's slide. Input us.
Dr. Vajirani Sahib and other friends. At the outset, I will like to thank Dr. Kamal and his organizing team for giving me this opportunity. And since we are facing this problem of the computer assisted devices making a projection successful, since my days of early days, I am not a very computer knowledgeable person, but as a child, I have learned in the epic of Mahabharata, the curse the Karna had, that at the right time it will not work. So I remember that the computer science is like that. At the right time, it can create some problem for us. So till he settles,
While things are, yeah, meanwhile things are settled.
By the time you can, sir, start
Ah.
speaking on ticagrelor.
No, just 1 minute. We'll have Dr. Jai Shah.
Yeah.
Jai, you proposed that 100 milligram of aspirin and with rivaroxaban 2.5 mg. So in Indian market, I think it is available at the 150 and 75. So either of the dose will be having the similar impact according to you?
I was waiting for this question actually. And I knew that it is 100 milligram. And one thing is that, okay.
so here I am supposed to deal with is the ticagrelor 60 milligram is preferred antiplatelet for the long-term use in this patient. You see, we have a patient profile. He is a 70-year-old man, diabetic, hypertensive, dyslipidemic, history of severe stroke 6 years back, and before 1 year, he had underwent PCI with 3 stents. I assume that it must be a drug-eluting stents. And now, what is the role of secondary prevention for these patients? We need to have, as Dr. Jai has also highlighted, some inputs from the history, whether it's what is the CKD status or EGFR, ongoing medication post PTCA, does he have a PAD, the type of the stroke and the ejection fraction. But pertinent to that, is there any need for a long-term ischemic protection in this patient? That is a first question need to be asked, and what is an evidence or what the literature says about this? You see, there are a lot of data. One of the slides which I have selected from the REACH registry, it says that the patients with a history of ischemic event are twice the risk of MACE for up to 48 months. That nearly 4-year data. That if from a normal population, which will have with these background of multiple risk factors, at the end of 48 months or 4 years, the cumulative incidence of the MACE will be about, say, 9%. But our patients is likely to have an incidence of about 18.3%. So nearly twice. So there is a definite need that the ischemic events are likely to happen, and we need to reduce it. Similarly, in Apollo 1 registry, 1 in 5 patients who were event-free for the first year following an MI develop a subsequent MI, stroke or death within next 3 years. So whether it is a population sample was taken from different country, it doesn't matter. In all these populations, of course, Indian populations was not covered in this data, but they all showed definitely increased MACE rate following first ischemic event in form of an acute coronary syndrome. And in one of the trial, the MACE was 15% at the end of 6 years after the MI. So consistently it shows that after a first acute coronary event, for a couple of years, there is a likelihood of an increased ischemic event in these kind of patients. Now, if the patients have got diabetes or a multivessel disease, they are still at a sustained or a higher risk in the subsequent years. Like say, if you have a non-diabetic patient and no multivessel disease, here that data is missing, whether the stents, all 3 stents were put in one vessel or whether it is a multivessel disease. But he is diabetic. So diabetics have much higher risk if you take particularly this example. Now, complex PCI, if you have performed, obviously these 3 stents, matlab, it's a complex PCI. The secondary events for next 30 months are also definitely high. They are also posing a higher risk of stent thrombosis. So we need to have an agent which is likely to reduce the incidence of the stent thrombosis in subsequent years. So what is an evidence for long-term use of DAPT after this patient? That is nearly 1 year back he had an MI. You see, DAPT study to reduce the long-term risk of ischemic event was continued beyond 12 months. 12 months, there is an agreement, and all the guidelines say that following a PCI, we should give dual antiplatelet agents for 12 months, but this study was extended for another 18 months. And what was revealed was that if you continue this dual antiplatelet therapy, then you will have a further reduction in the composite of the death, MI, or stroke at the end of the 30 minutes. So there are a lot of evidences. The Pegasus TIMI-54 study, which was comparing the ticagrelor 90 milligram twice a day with aspirin, which is a usual dose, ticagrelor 60 milligram BID with aspirin, against only the aspirin after 1 year completion post intervention. And again, the primary endpoint was composite of cardiovascular death, MI, or stroke, and the safety endpoint was TIMI-defined major bleeding. And what did it show? That it shows a 16% relative risk reduction compared to aspirin alone if you are giving ticagrelor 60 BD with aspirin. But it is not, so whether it was a primary endpoint or whether there was a secondary endpoint, you found that the ticagrelor was definitely better than aspirin alone if you continued beyond the 12 months duration of DAPT. You see, this was achieved not at any major bleeding. Definitely the bleeding was higher when you continued dual antiplatelet agents, but the fatal bleeding or intracranial hemorrhage was no more in the ticagrelor arm compared to the placebo. So you are not going to increase the risk of bleeding complications in terms of mortality by continuing the dual antiplatelet agents beyond 1 year. And the benefit of the ischemic risk reduction clearly outweighs the risk of major bleeding when this was continued within 2 years, because in the Pegasus trial, the patients were enrolled even if they have a history of MI within 2 years at the time of inclusion. It also shows the net clinical benefit. If you take the irreversible arm, the cardiovascular death, MI, stroke, intracranial hemorrhage, and fatal bleeding all together, there was a 14% reduction. So put together the ischemic event versus the risk of the major bleeding or the fatal bleeding were reduced by 14% in this trial by continuing the ticagrelor 60 milligram twice a day. And what the recent guideline says about the use of DAPT therapy in patients with ACS who have undergone PCI, because our patient has undergone PCI with 3 stents, and whether it's a drug-eluting stent or whether it's a bare metal stent, and if the patient has no high bleeding risk, I will come later what is being defined as a high bleeding risk. If the patient has undergone the stenting and he is not having a high bleeding risk, they recommend in the green bar that you can continue beyond 12 months. The use of ticagrelor is preferred beyond 12 months for reduction of the MACE. And even the ACC or AHA guideline also says that beyond 12 months, one can continue the dual antiplatelet therapy in this subset. In our case, patient had a history of CVA, so the question of giving a prasugrel doesn't arise. Now, patient selection algorithm in this Pegasus trial from which these recommendations were generated, that patients who have more than 2 risk factors. Now, in our case, obviously there were more risk factors. Patient has hypertension, patient has diabetes, patient has dyslipidemia, strong family history, and these are the list of the multiple risk factors. If the patient has got a multiple risk factors, then the benefits is going to be more even in this subgroup of patients. So putting them together is going to get you the larger benefit. And this was not at the high bleeding complications or a fatal bleeding. Now, how will you define if the patient has a prior history of bleeding anywhere, or the patient has low hemoglobin, you may exclude after 1 year. And if patient has got a multiple risk, in absence of a high bleeding risk category, then you may consider these patients for continuation of the DAPT beyond 1 year. And then you are likely to achieve further benefits in these kind of patients. And cardiovascular deaths and all-cause death in low bleeding risk patients come as per the number of the ischemic risk factor. If you have more ischemic risk factor, more than 2, in our case it was more than 2, then you are likely to have both nearly 34% relative risk reduction in cardiovascular death and 24% relative risk reduction in all-cause death if you have more than risk factor. Our patients have more than 3 risk factors. So we are likely to have the benefit of giving a ticagrelor twice a day in this particular category of patients, which is again highlighted in this slide. And there was a comparison with which the rivaroxaban has come in the use, but the two subset, I think, inclusion criteria, if you go to the COMPASS, the majority of the patients have MI 7 year or more. Here our patient has the MI just 1 year back, and patient received 3 drug-eluting stents. The status of whether the stenting was done or not is not clear in the COMPASS trial. So extrapolating the results of COMPASS trial for our given patients, I think is not acceptable. And one more point, when you have a patient who have more than 3 stents, you have 3 stents, the chance of stent thrombosis are going to be much more. So I do not have an information, does rivaroxaban use reduces the incidence of the stent thrombosis after 1 year. But we have ample data by continuing the DAPT therapy, the incidence of the stent thrombosis can be definitely reduced. And there was also little concern about the statistical analysis which has been put forward in the COMPASS trial, because the subset which was selected for the COMPASS trial is not identical with the patients which is in question. So the COMPASS trial results cannot be extended word to word for this category of patients who is just had a 3 stent 1 year back and has a multiple risk factor. Thank you for your attention.
Thank you, sir. It was a nice rebuttal for the first talk. And what is your take, Dr. Jay, whether we should be giving ticagrelor or versus DPI using a NOAC with the aspirin?
So I think the point was very well taken by Tarun sir, because we need to identify whether the patient has received a stent in which part of the coronary artery, whether they are distal stent, proximal, whether they are at the left main, or they are having multiple stent in the single vessel. All these things are very important to choose the strategy. So it's always better to conclude one thing, that whether my patient fitting into the study design of that particular trial or not. Then and then you will be able to justify the role of either antithrombotic therapy or antiplatelet therapy. In this case, rather than battling on whether rivaroxaban or ticagrelor, let us have a patient as a whole, comprehensive care management, look at the eGFR, look at the overall ejection fraction, look at the presence of stent and which type of the stents are being used. They are also very important. Nowadays, even sir would agree that there's a trial called Onyx 1, where they've used a stent which is a durable polymer, and after 1 month, they're straight away switch over to a single antiplatelet. So the era has come from prolonged DAPT to short DAPT to single antiplatelet. And that all depends on the underlying patient criteria, patient's lesion, and overall scenario. So as I would completely agree with Tarun sir that you should not take a patient or a criteria as a whole. Always consider the patient whether they are fitting into the study design of that particular trial or not, and then choose your study. The question which was being asked by Bhagirath sir, that 100 milligram was being used. Now there is only one molecule which is available in 100 milligram aspirin, that is, the trade name is Folsprin. It is available in 100 milligram. Otherwise, it's right that 75 milligram or before 4-5 years, Loprin DS was available. It was 162.5 milligram dose. But here, even if you use 75 milligram, the antiplatelet action is going to be same as that of 100.
Yes, sir. The third part of this talk, that if you use prolonged dual antiplatelet, as multiple stent is there, so what is your take for the prolonged dual antiplatelet?
Pegasus has already got the data up to 36 months after first year of index event. That means after for 1 year, you give 90 milligram twice daily of ticagrelor. After that, for 3 years, from first year index event, you give 60 milligram twice daily. Up to 36 months, you can always subject this patient, provided the patient is falling into the category of complex PCI, which includes left main, graft vessel PCI, bifurcation PCI, thrombotic involvement, proximal stents. So multiple stents, which size and which lesion, which is the site of the lesion, that is very important. Because twilight, tycho, twilight complex, these are the trial where even a single antiplatelet, ticagrelor, was being used after 3 months of DAPT with aspirin. So the trial has come that you can switch over from longer DAPT to shorter DAPT to single antiplatelet.
No, I do agree that the type of the stent does matter. Now there is a trend for having a less duration for the dual antiplatelet agents. Having said that, there are also number of data that if you use more metal, and obviously if you have put 3 stents, there is a more metal, there will be going to be a higher chance of stent thrombosis. And we do not have a data, to my knowledge, does any of, not just leave aside the rivaroxaban, but any antithrombin drug does have an effect on prevention of the stent thrombosis. Because even if you have put a bare metal stent and you have discontinued as per the guidelines after 6 months, but the fact is that his heart is and the coronaries are having a quite a significant size of the metal inside the vessel, and that will need some kind of an antiplatelet coverage to prevent the stent thrombosis in this particular case.
Means there is a dual pathway inhibitor and dual antiplatelet. So from the physician's perspective, I think it would be only the position of stent, type of stent, and number of stent that is going to decide. So is there some scoring system kind of which is going to have the ischemic burden, which is going to tell and decide which pathway one has to go, whether dual pathway inhibition or dual antiplatelet?
Enrichment criteria. We have done a project called Lighthouse Project. I think Kamal B was also there in that project. Lighthouse Project was the project of uses of rivaroxaban in a highly thrombotic scenario, along with aspirin, after 1 year of index event for 48 months, that is 4 years. And this particular study has proven, it's going to get published, but it has proven that there is no evidence of stent-related failure. But one thing is very important in this case, that all these patients are also having PAD, peripheral artery disease. So in this case also, I need to find out whether there is a carotid artery stenosis, even if it is asymptomatic, more than 50%, then it is falling into enrichment criteria. Now this enrichment criteria, then the net clinical benefit, as the number of risk factor increases, the benefit is going to be multifold with DPI. So it's always better to see the patient in total, as a complement.
Yeah. So the most often now the evidence is emerging that the bleeding is because of aspirin. And that's what was studied in Twilight study also, that you can stop actually an aspirin and continue either antiplatelet or DPI beyond a year. So aspirin will actually go off. That's how I see it future. You will be either choosing of the two. And yes, if it is, the best way to analyze this is if you had an MI, transmural MI, then there is evidence for ticagrelor. If you don't have transmural MI, then
data is, if you have a polyvasculopath or if you have multiple vessels involved with complex angioplasty, then the data is for rivaroxaban. That's how you should probably take a call. If you don't have a transmural MI, the data is not so strong for ticagrelor because the inclusion criteria was for post-MI in the Pegasus study. The Pegasus trial based on this whole thing was based on transmural MI. But yes, in that also, it benefited as the number of stents and etc. increased, but at the cost of increased bleeding, and that's why the 90 was reduced to 60 because it had to 3 arms. So choose 60, not 90 after a year, and choose Riva 2.5 BD, not the other doses that we use. And the first evidence emerged in atlastomie, where they were studying low dose, high dose. They found out high dose along with dual antiplatelet in atlastomie study led to higher bleeding, and the benefits were nullified. So they choose lower doses and designed the Compass trial. Now we also have data in acute setting in Gemini ACS, where they've also included, which I think you touched upon, both of you. So I think we have reached a stage that probably we'll be discarding aspirin in secondary prevention, especially as early as you can. This is like Twilight, the Twilight on which the question is based on. So which regime is used in high bleeding risk in the Twilight trial? Any other comments, if any other chairpersons?
If I have to just summarize, looking to the literature, because I incidentally having to part in this debate, I just went through the rivaroxaban arm also. You see, the trial is really good and its implications are also really good. But at what point of time you are seeing the patient? Suppose I am seeing a patient who had undergone whether angioplasty or not, say 6 years back. And today I am supposed to analyze him and he has a multiple risk factors. And I have to use something for a secondary prevention. I would probably, and as a peripheral vascular disease, probably I may use not the ticagrelor as the first choice, but the rivaroxaban low dose 2.5 milligram twice a day with a low dose of aspirin. But suppose I have a patient who had come just 6 months, or not 6 months, but say 1 year back, some kind of interventions of acute coronary syndrome. Probably I would prefer more in favor of this. And let his 3 years passed after the index event, without any clinical event, and then we can think of other.
Yeah, this is a very good point, that how long or how old case you can use. Rivaroxaban, you have data in Compass up to 10 years. Yeah. 10 years and 20-year follow-up is ongoing.
Yeah.
Because and ticagrelor, the data is for 3 years. But after 3 years, you cannot use ticagrelor.
Compass mein patya. And
20-year follow-up is designed.
The follow-up is long, but the inclusion have only 5% of the patients who have an acute coronary syndrome in less than 1 year.
Right.
That was the problem.
Thank you all the faculties. Please collect your mementos in your kit. For the sake of science, we are not felicitating each one of you individually. Thank you very much. Thank you. Thank you. Thank you. We move to the next session.
I would like to invite Dr. Vinay Bomia, Dr. Kumud Kumar, Dr. Kamlesh Patania, Dr. Bhavesh Patel, Dr. Shabbir Gadi, Dr. Rajiv, and Dr. Bipin Patel. Dr. Rajiv Sahnani. This is regarding anti-anginal choice. Kamlesh bhai, you are requested to. एक इंट्रोड्यूस करी लो ना स्पीकर ने प्लीज डॉक्टर दीपा कामेटा काइंडली इंट्रोड्यूस
Good evening, everyone. Today's speakers are Dr. Deepak Ameta, Dr. Jayesh Mania, Dr. Vishan Mansuri, and Dr. Jashraj Pawar. Read out the case. So here is a 65-year-old male with a history of old inferior wall MI due to occluded RCA, which undergone CABG 4 years back for his triple vessel disease. Now has occluded SVG to LCS graft, but patent both SVG to RCA as well as Lima to LV. The stress radio nuclear imaging had revealed mild reversible ischemic territory of LCX, and his ejection fraction is 42%, and the patient has class 3 angina along with class 2 dyspnea on. The patient is on GT and 6.4 milligram twice a day, apart from the DAPT and high dose statin. The patient is already on metoprolol 100 milligram per day, ACE inhibitor as well as diabetic. His resting heart rate is 80 beat per minute and BP of 106 by 70 millimeter of mercury. He has occasional VPCs on ECG. So the question is, what is the preferred modality of next line of anti-anginal would be in this patient?
Good evening, everybody. I am Dr. Deepak. I am from Udaipur. I thank Dr. Kamal Sharma and the Cardiocon team for inviting me. So we have learned that this is the scenario in which the patient is post-CABG complex patient, and specifically one graft is blocked, and now the patient is having angina class 3 and dyspnea class 2. So we have multiple options. We will see first line of drugs and then second line of drugs. So specifically we are here to discuss the second line of drugs after beta blockers or calcium channel blockers. So as a cardiologist, we are CAD means we have three clinical scenarios. One is chronic coronary syndromes, in which the ESC 2019 they have specifically mentioned that the bottom slide is green, in which the patient is doing fine with everything, lifestyle modifications, and the red one is the patient has interspersed with 2 of the acute coronary syndrome. Second is when we are dealing with acute coronary syndromes and when we deal with stenting. So whenever there is an acute debris, we put a balloon, we put a stent, then there is a distal embolization of multiple material debris, and then it leads to the microvascular spasm, microvascular occlusions. It also leads to slow flow and no reflows. And third one is the patient's epicardial coronaries are okay, but there is slow flow. So there are three important aspects of coronary artery disease. So we'll see to it. And this coronary slow flow is also very important because 20% often require readmissions. They have complications including arrhythmias and SCDs. So regarding all these complexities in CCS, in ACS, and a slow flow phenomenon, we will discuss the role of nicorandil, that what is its role and how does it help in each of the clinical scenarios. So what we know about nicorandil is that it can be used for treatment in stable angina, in microvascular angina in which epicardial coronary arteries are okay, refractory anginas, and the unique cardioprotective action is also there, which is ischemic preconditioning, and then it also prevents and it also treats no reflow phenomenon. So how does that occur? Let's see. So this is nicorandil, and its mechanism action is dual. So it activates the ATP sensitive potassium channels, which leads to hyperpolarizations, decreased calcium, and then it dilates the peripheral arterioles and dilates the coronary arterioles, smaller arterioles. It has also a nitrate moiety, and it has nitrate effects also, which leads to vasodilatation of larger arteries, epicardial arteries, and venodilatation. So it has effects on epicardial arteries, venodilatations, smaller resistant arterioles also. So it has a balanced vasodilatation. So it dilates arteries also, it dilates veins also, epicardial coronary arteries, and smaller microvascular. So it reduces both preload and afterload. So nicorandil protects the heart from subsequent ischemic attacks also. And so it has only potassium channel activator currently licensed for the treatment of angina because it has a pleiotropic advantage, like it also has some sort of platelet inhibition, vasodilatations, cardioprotection, and reduction in atherogenesis. So this is all about the nicorandil. So what is the data that we have about its usage? So the most important trial was impact of nicorandil in angina, IONA study. So there were 5,000 patients and mean follow-up was 1.6 years. They have given 20 milligram BD, and the primary composite endpoint was a composite of coronary heart death, non-fatal MI, and unplanned hospital admission for cardiac chest pain. So what after that, a median follow-up of 1.6 years, they have seen that the composite of CSD death, non-fatal MI, and hospital admission were decreased. So in the first point, we have seen that the p-value was significant. So it has shown that the composite was significantly better with nicorandil. And specifically, the death was not so much of involved, but the composite was quite reduced. As also CHD death and non-fatal MI, all cardiovascular events were also less. So this INO trial, it was a very important trial. It established the effects of nicorandil in the use of coronary syndromes. And this is also a trial from Japan. 13,000 patients, mean follow-up at 2.7 years, mean dose was 15 mg. And then it has shown that the all-cause mortality was also down, cardiac death was also down, fatal MI was also down, CHF was also down with the nicorandil. So after all these trials, what we have come to that the ESC guidelines, they have mentioned the first line, we all know that beta blockers are first line, CCBs are first line, combination is 2A. And the second line drugs, the first is long-acting nitrates that we have to see. Long-acting nitrate is class 2A. And if the patient is not able to tolerate beta blockers, CCBs, or long-acting nitrates, or if he's symptomatic on all this, so we can use nicorandil, ranolazine, ivabradine, or trimetazine as a class 2A level B. So what favors nicorandil apart from all the drugs? So it is a small, that nicorandil versus nitroglycerin for symptomatic relief of angina in patient with slow coronary flow. So we will now see the slow coronary flow. So this also shows that the patients who were on nicorandil were more in class 1 as compared to nitroglycerin. So it also provides better symptomatic relief of angina than nitroglycerin. And what we were talking about ischemic preconditioning, because it also has effects on smaller arterioles. So it also helps in ischemic preconditioning. So it was a smaller study to study the possibility of pharmacological preconditioning by oral nicorandil to prevent ischemic myocardial injury and 4A type of MI. So 182 patients, and the conclusion was that the nicorandil treatment using before PCI decreases the risk of MI 4A in patient with a stable CAD due to the pharmacological preconditioning. And this was also the other benefits. What we have seen, that there are pleiotropic effects of nicorandil. So it was a study to assess the anti-ischemic and antiarrhythmic effects. So 20 milligram twice daily was used, and then on the left side we see that the number of angina episodes were less, and tachycardia episodes were also less with the help of nicorandil, because it possesses a pharmacological preconditioning. And what every cardiologist uses in his cath lab is whenever there is slow flow or no reflow, then we use IV 2 milligram, and then if needed 2 milligram also, and definitely it always improves the flow of the epicardial vessels. So again, it has shown that the IV nicorandil improves coronary blood flow, cardiac systolic function, and prognosis in STEMI patients. So this is all we have seen about the nicorandil, and now we also see about that what are the drawbacks of other therapies. This nitrates, as we know that nitrates as a marker of multiple comorbidities. If you are using lots of anti-anginal therapies, means the patient vasculopathy is very aggressive. And the patient overall, if the patient is very aggressive in his disease, the patient overall symptomatic status and overall morbidity would be raised. So nitrates are associated with significantly increased post-elective PCI mortality. So I believe that this might be also with all other drugs, because as your number of drugs, anti-anginal drugs are increasing, your number of the patient disease is more aggressive, and you will have to have more of the mortality and morbidity with all these drugs. So this is same again. So, and apart from nitrates, there are some of the effects of unmet needs of beta blockers also, because you cannot use beta blockers in a patient of asthma, COPDs, PVDs, CCBs. They are having the problems of flushing, peripheral edema. Nitrates, the patients have their tolerance. The patient have the headaches with the nitrates, and sometimes they are not tolerating the nitrates. So, and vis-a-vis, this is comparison with ivabradine, ranolazine, and trimetazidine. So first, ivabradine, that we see that ivabradine in all the trials, they have never mentioned that the mortality has improved in ivabradine. Ranolazine, yes, symptomatic benefit was there in the ROLL study, but the mortality was same. It was not neither increased neither improved. And trimetazidine, overall the symptomatic status was improved, but there was no changes in the outcomes. So there was no mortality benefits with either of the drugs. So by looking by all the dual mechanism actions, by its balanced vasodilatations, by its multiple effects, pleiotropic effects, nicorandil for me seems to be an ideal add-on anti-anginal agents, because it is a dual anti-anginals, does not have any adverse hemodynamic effects on heart rate, conduction system, myocardial contractility, and it has a specific activity of ischemic preconditioning, useful in recovery of myocardial stunning, and it is for treatment and prevention of no reflow, and there is no tolerance like nitrates. So for me, the add-on drug is nicorandil. Thank you from my side.
Thank you, Dr. Deepak, for this wonderful presentation. I would like to invite Dr. Yash Mania to continue the talk.
First of all, thank you for inviting me as speaker, Dr. Kamal Sharma sir, for inviting me as a speaker. So we already discussed that other patient is a stable ischemic heart disease. This is a previous history of patient undergone CABG before 4 years and occluded one graft, one venous graft. Apart from stable angina, patient has also NYHA class 2 dyspnea. This is an important history mark. And patient ejection fraction is around 42%. Patient on drug therapy 100 milligram metoprolol with nitrates, and the heart rate is 80 beats per minute with occasional VPC present on ECG also. So for the second line drugs, so all the 4 drugs we can choose as a second line. This is the ESP 2019 guidelines that shows class 2A indication for all these 4 drugs: ivabradine, ranolazine, nicorandil, and trimetazidine. In some selected cases, we can also add as a first line drugs if some contraindication and non-tolerance to first line drugs also. So we can choose any of these 4 drugs. But in this case scenario, why the ivabradine is ahead of other 3 drugs? So there are multiple factors. First of all, we have to discuss that why the second line drugs is important in this case. So why up titration of beta blocker? Because patient on 100 milligram beta blocker. So we can up titrate beta blocker also in this case. Or patient has angina. So angina is really important in this case to relieve. And third part is heart rate. Heart rate reduction is also important. Patient has 80 beats per minute on 100 milligram of metoprolol. So these 3 parts is also important in clinical scenario before adding second line, before choosing the second line. So why the up titration of beta blocker is not conventional in this case? So we have some evidence. One is a control 2 study in 2018, which include more than 1,000 patients with elderly patient around 60 years and patient at NYHA class 2. Most of patient in NYHA class 2 dyspnea, and that shows, and patient has background around 90% patient with background beta blocker with bisoprolol and metoprolol, and that shows both in efficacy and safety wise. Addition of other drugs with beta blocker had more benefits in angina event free, and also for the safety purpose decrease the side effect by adding ivabradine compared to the up titration of beta blocker. More other studies that shows that addition of beta blocker with, or sometimes with beta blocker ivabradine is more benefit compared to the up titration of beta blocker. So more is not always necessary or not better compared to the adding to the therapy. This is other studies, other 2 studies. Addition study in which addition of ivabradine to the ethanol 50 milligram. In associate study also with beta blocker, irrespective of PCI, addition of ivabradine with the beta blocker is more beneficial compared to the up titration of beta blocker. So my second point is that angina is really important to treat because patient is hemodynamically stable. So why the angina is important? In clarified registry, it is more than 32,000 patients in 49 countries, and patient has previous history of coronary events and patient symptomatic. So if patient has patient with previous history of myocardial infarction and patient with symptoms of angina, then patient has more chances of MACE event, coronary events, or hospitalization. So we have to treat this angina as early as possible with adding some amount of other drugs. And my third point is that is heart rate reduction is beneficial? Then beta blocker is also heart rate reduction drugs. So why can't we kind of titrate? So other events apart from lowering the heart rate, is there other benefit of with ivabradine is also present or not? We have to study that. Then yes, ivabradine has other benefit rather than reduction of heart rate is increase coronary flow velocity reserve and coronary flow. So heart rate reduction with ivabradine compared to bisoprolol is more or less same, but the coronary flow velocity is more likely improve with the ivabradine compared to the beta blocker. So why this happen? So as we already know about the mechanism of action of beta blocker prolong the diastole, but it impair intraventricular relaxation time. Compared to that, ivabradine reduce the entry of sodium, that may reduce the cytosolic calcium, and that may increase the reuptake of calcium to sarcoplasmic reticulum. So improve relaxation of ventricle with also decrease the reactive oxygen stress in myocytes. So ivabradine has additional pleiotropic effect rather than heart rate reduction also. So this is the multiple action rather than heart rate reduction, which is there is no negative inotropic effect with the ivabradine. There is also does not unmask the alpha adrenergic vasoconstriction, so reduce the there is less chances of decreased systolic blood pressure, does not improve the contractivity, AV conduction, and also patient has ventricular premature complex in ECG. So it does not alter the QT interval in particular ECG. So decrease the chances of arrhythmia also. So this is a multiple action of ivabradine in different part because of decreased heart rate that may improve the LVEF by decreased demand supply mismatch also. So decrease infarct size, increase coronary flow, we already discussed about that, and decrease the chances of arrhythmia. So now why the ivabradine is chosen over the other three drugs? So our patient has coronary artery disease, NYHA class 2 dyspnea, and LV systolic dysfunction. So we have two studies, landmark study. One is a beautiful study. Of course, the overall data of beautiful study is negative, but in patient of symptomatic, particularly subgroup analysis, with patient has limiting angina, then significantly improvement of primary endpoint with CV mortality and fetal MI in ivabradine group in add-on therapy with ivabradine. So this is the data. This is the data shows that if patient had limiting angina and particularly patient with heart rate is greater than 70 beats per minute, then ivabradine is of course very beneficial in case of LV systolic dysfunction with coronary artery disease. And this one is a very landmark trial. Dr. Deepak also already discussed that Signify trial, but this Signify is about the coronary artery disease, but this is about the LV systolic dysfunction. Patient with class 2, 4 dyspnea, it includes AF is around 35%, heart rate is greater than 70 beats per minute. And when we add this, then of course patient has mortality, decreased hospitalization, decreased heart failure, repeat hospitalization, and also decreased combined hospitalization on death, both in SIP trials, in particular patient of heart failure. So in SIP trial, that shows that ivabradine reduced the total hospitalization, recurrent hospitalization, and increased the frequent admission for the further hospitalization also. And my fifth point is also the ivabradine also reduced the angina frequency in cases of coronary CAD also. So in signified trial that shows that compared to the placebo, ivabradine significantly reduced the angina frequency also, and also improve the quality of life. So ivabradine is a broad spectrum of action. In any case, if patient we can use as a monotherapy compared to the beta blocker in various studies like the initiative study, responsive study, and reduction study. We can use as a monotherapy in particular patient who has contraindication of beta blocker or who is non-tolerant to that therapy. We can use in a specifically elderly population, diabetic population, post-revascularization population,
or we can use as also add-on therapy or up titration with the beta blocker. We already discussed about that in control 2 studies. And this is the landmark trial. In SHIFT trial, we can use in LV systolic dysfunction patient who have NYHA class 2 to 4 dyspnea and patient at class greater than 80 heartbeats on maximum tolerated dose of beta blocker also. So take home message from me is that ivabradine has its own distinguished set of beneficial effect, not just another heart rate reduction drugs. Combination of beta blocker with ivabradine is superior to the beta blocker. Up titration alone, more is not necessarily always better. In a patient with limiting angina on optimal medical therapy, it may second choice drugs, in particular this case scenario. Thank you.
Well described about the role of ivabradine and why it should be chosen over beta blockers. Thank you, Dr. Yasmani, for this wonderful presentation. I would like to invite Dr. Jishan Mansoori to continue the talk.
Good evening, everyone. So my first question as an interventionist is why not to revascularize, right? So we don't have any data on the native vessels, but I think all the cardiologists sitting here would agree that why not to revascularize, why not attempt to revascularize first and remove the cause of angina itself. However, that is not what is at stake here. So I'll continue with ranolazine. What is ranolazine? So it's a piperazine derivative which represents a second anti-anginal drug in the management of chronic stable angina pectoris, approved in 2006-2008, I think more than 1.5 decades back. In the ischemic myocardium, the late inward sodium currents and they increase intracellular sodium, which will increase intracellular calcium. And again, there will be calcium overload in the ischemic cells, which leads to diastolic stiffness because of prevention of diastolic relaxation. Elevated diastolic wall tension will compromise coronary flow itself. And calcium overload will also have adverse effects in myocardial electrical activity, which predisposes to other tachycardias as well as ventricular tachycardia. So ranolazine inhibits the late phase of the inward sodium current during the cardiac repolarization, so decreases the calcium overload, reduces the stiffness and improves the perfusion. So this is the summary. So what happens in the ischemia, there is increase in the late intracellular sodium, increasing the calcium overload, resulting into diastolic stiffness and resulting into increased oxygen demand and decreased supply. Ranolazine affects these late sodium currents and it prevents the diastolic stiffness as well as preserves the myocardial blood flow. So myocardial ischemia is associated with increase in the fatty acid levels with enhanced oxidation of long chain fatty acids, which requires more ATPs as compared to glucose utilization. So there is again increased oxygen demand rather than glucose oxidation. So it may also lead to accumulation of free fatty acids and lactic acid, which will increase the acidosis and affect the heart performance itself. So this is also again prevented by ranolazine as a partial inhibitor of fatty acid oxidation, which shifts the metabolism from long chain fatty acid towards the glucose oxidation. It also inhibits the delayed rectifier potassium currents at the therapeutic levels, which prolongs the ventricular action potential duration or the QT prolongation. So normally it is given by oral route and onset of action is within 2 to 6 hours and steady state within 3 days of twice daily dosing, half-life of around 7 hours, and metabolism is with liver as well as kidney. So tolerance, extended release ranolazine has been found to be well tolerated. However, there are some adverse effects like dizziness, constipation and peripheral edema, and plasma levels may increase by 50 to 60% in patients with renal and hepatic impairment. So caution is to be required, and it is contraindicated in patients with creatinine clearance of less than 30 ml per minute, especially those on dialysis and those with cirrhosis or the end-stage liver disease. It undergoes hepatic metabolism by CYP3A4. So all those patients who are already on medicines which are inhibitors of CYP3A pathway, then ranolazine is contraindicated because its metabolism will be inhibited and the action will be prolonged. Like antifungals, ketoconazoles, macrolides, clarithromycin, protease inhibitors, diltiazem, and grapefruit juice. So although it prolongs a QT interval slightly, it has no pro-arrhythmic effect, and it should be avoided in patients with prior QT prolongation, as well as any other drugs which cause QT prolongation. And an ECG has to be performed after initiation as well, within a week or two. Dose generally 500 to 1000 milligram, 500 milligram twice a day to be initiated, and maximum up to 1000 milligram twice a day. And what does the guideline suggest? As already discussed by Dr. Ameta and Dr. Mania, that it is a class 2A, level of evidence is B, and it is always a second line anti-anginal drug. So what is the clinical data? So there are 3 studies, MARISA, CARISA, and ERICA, which provide the basis for the use of ranolazine as an anti-anginal therapy. So in acute coronary syndrome, there is a Merlin-TIMI 36, which is a randomized trial, and it found that there is no benefit overall in the acute coronary syndrome. Again, trimetazidine and ranolazine, these both drugs stimulate the glucose metabolism apart from the from beta oxidation of fatty acids. And ranolazine has additional benefit by inhibition of the sodium currents, which causes antiarrhythmic effect. So it has a better efficacy. Ivabradine, the comparison of head-to-head ivabradine versus ranolazine was done. The study population is very minimal. However, the result was that both are equally active, but ranolazine has a better safety and tolerability profile than ivabradine. And patients with microvascular coronary dysfunction, a topic which is doing rounds in the international circulation right now, patients without obstructive coronary artery disease with microvascular coronary dysfunction. Ranolazine improves angina in those patients, especially in women with evidence of myocardial ischemia but no obstructive cardiac disease. And the effects of ivabradine versus ranolazine so significantly improves both, but ranolazine has statistically more improvement as compared to ivabradine. Patients with new onset or paroxysmal atrial fibrillation, it has been found that ranolazine enhances the effect of amiodarone for conversion of post-operative or new onset atrial fibrillation. And the conversion rate was significantly higher when ranolazine was given along with amiodarone as compared with amiodarone alone. Post-operative atrial fibrillation after cardiac surgery, a significant reduction on the onset of post-operative atrial fibrillation when ranolazine was added to the standard therapy. The antiarrhythmic effects of amiodarone was enhanced by the ranolazine. Amiodarone plus ranolazine had a significantly shorter time to sinus rhythm conversion as compared to amiodarone alone. Chronic AF, it has not been found to have any significant effect or the AF recurrence. Glycometabolic effect, ranolazine monotherapy, patients with type 2 diabetes mellitus have been found to have some dose dependent reduction in the HbA1c also. And effect of ranolazine monotherapy was studied, and it significantly reduces the HbA1c as it shifts the metabolism from long chain fatty acid to glucose oxidation. But incomplete revascularization after PCI, the study which REVER PCI, the ranolazine in patient with incomplete revascularization after PCI, there is no evidence which supports the use of ranolazine in these patients. So the take-home message is that it does not affect the heart rate and blood pressure. It is a second-line anti-anginal drug. Most important for microvascular coronary dysfunction, post-surgery AF, type 2 diabetes patients, but has limited evidence in acute coronary syndrome, incomplete revascularization after PCI, and chronic AF. Coming to our patient, elderly male, old ACS, triple vessel, post-CABG, now 1 graft is occluded, 2 grafts are patent. So as I said, first option is to revascularize. And mild to moderate LV dysfunction. Now this patient does not have ACS, but angina and dyspnea is clinically significant, NYHA class 2 and 3. So ranolazine is favorable. On GDMT, highest tolerable doses of GTN and beta blockers. Ranolazine also has one effect. It has an interaction with beta blocker. It increases the effect of metoprolol by inhibition of CYP2D6 metabolism. So ranolazine will also potentiate the effect of beta blocker. So that is why it is also important. Hemodynamics, heart rate is, I would not say that this patient is having elevated resting heart rate, or ivabradine might further reduce, or elevation of the beta blocker might also further reduce. Blood pressure is also borderline, so high dosages of nicorandil. As studied in the trial, the nicorandil ideal dosage would be 20 milligram per day. Most of our patients tolerate 5 milligram twice a day, and that too with a lot of headache. So ranolazine is favorable here. And now ECG is suggestive of BPC. So patient is having a pro-arrhythmic substrate. Here I would say that ranolazine is preferable to other anti-anginal drugs. So that's all I have in my argument. Thank you all.
I'd like to invite Dr. Jasraj Pawar for the continuing.
Good evening all, and thanks Dr. Kamal Sharma sir for letting me as a speaker. So we have students here in our topic in science. What is the role and the strategy and the additional benefit of skill remodeling, switching and rediscovery. So we have already discussed the case, it's a on failure, which means that we can analyze CDG for that, now the SCG cases are experience. And the patient is having the angina class 2 angina and our first study of them, this is very mild angina, this is already on Metabolite 100 milligram. This is the optimal dose in vision population. Still is started 80 and that is 76 and actually diseases are local. So what are the points to find out here? Is the still is 45% and what the actual this angina percent treatment for the heart failure. Patient is non-diabetic, diabetic, occasional repeated ECG and patient is already on 2 class of hemodynamic continuing drug and patient is also diabetic. So on diabetes, there is a risk of hyperkalemia and critical illness. So which we also look for and also for. So that we need against with a different mechanism. So what is the conventional approach to the ischemia by using the antigen? So either we should decrease the oxygen demand or we can increase the oxygen supply. So decrease oxygen with beta blocker, which should be a nitrate proton, which can decrease beta blocker can decrease the heart rate and toxicity, and CCD nitrate can vasodilate to decrease the force from free leg. So decrease the oxygen demand. On the same time, we can increase the oxygen supply by the nitrate nicorandil to dilute the coronary arteries and increase the oxygen supply. So beta blockers, as all we know that decrease the heart rate and increase the angina by increase the micro-oxygen consumption. In the same way, vasodilator, they dilate the venous system better and coronary arteries are secondary coronary flow. It results in a decreased venous pressure, thereby reducing the anti-drug stress in mitral oxygen. Nitrate can also increase the coronary flow and exercise. Our tolerability is an important issue with using the nitrate and nicorandil. These drugs classes can be well used in combination for the treatment of coronary. So coming to the our drugs to compare the comparing the three drugs, we are ready. So we have this beautiful trial. The point important in the beautiful trial is that this trial is done for the patients with the predominant heart failure symptom, and ejection fraction was less than 40%. While in our case, we have the ejection more than 40%, that is 42%. So applying this study, we are ready. We cannot use the anti-angina drug, and it is predominantly beneficial for the patient having heart failure. In the same fifth study, which was same design, and again the ejection fraction was 35%. So we have one study, clinical study. Here we are discussing the anti-angina drug, and this study was designed to prove as anti-angina effect and benefits we are having. Here we have the same study population like 55 year last year angina. This fraction was more than 40%, as in our cases and that is more than 70%. But what we see in the clinical study show that the being added to JDMC did not improve the outcome in patients who have failed coronary disease without clinical heart failure symptoms. There is a signal for an increase in the risk of cardiovascular event whenever the patient with the angina preaches class 2 or higher. Even the primary cardiovascular effect of diabetes is to reduce the heart rate. These results suggest that an elevated heart rate is only a marker of risk factor, not a modifiable determinant of outcome, especially in the absence of heart failure symptoms. So, what is why there is a paradox that everybody is useful and heart failure and not successful in angina as shown negative trial by the same signified. In angina, heart rate is used to adapt the energy production to the oxygen delivery. Why in heart failure, the heart is reduced to adapt the what is the ATP available. So in early destruction, due to the theory, early the heart is just a modified risk structure, and it is a prognostic marker. Just treating and targeting heart rate is not beneficial. In stable theory, which preserve your early heart is the myocardial metabolic adaptation in the heart rate is very different to a normal system. So what to understand is that it follows that the clinical data are not so conclusive, and what was wrong was the perception that heart rate reduction is the cardiopulmonary, not only in animal experiment but also in human stable theory, as in the clinical experiment. So coming to the renovation molecule, this is already discussed with the concept that it is a late 47 blocker, and it is also additional fatty acid metabolic modification by the piece of correlation. So in the concept study, what we have the great amount of patients, and the 80% of the patients were already on the baseline treatment of beta blocker PCB, and already the heart rate was an optimal dose. So adding this analogin on the beta blocker, what result shows that exercise duration was not much difference, like 21% and 23%, and adverse event rate was higher, 33% when analogin was added on the beta blocker. Another two studies, as we have discussed, the Marisa and Erica study, all these studies show that the side effect profile with the vanillin is very high. This is 29.9% in the Erica study. Constipation, syncope, asthenia, dizziness. These are the side effects in the 75-year-old male patient. They can be very cumbersome. And again, the last study, the Merlin PA trial, which is studying patient, 20% discontinued treatment because of the adverse event. So the renovation blocks and prolongs the QT in the dose-weighted manner. Because the concentration rate will increase with QT interval, the use of renovation has been taken only for the patients who have not an adequate response to other antigens. Renovation should be avoided in those patients with a clear QT prolongation, and renovation should be used only when there is no adequate response to the other antigens. So there is no need to treat the asymptomatic VPC in this case. If we have already studied the VPC's primitive VPC with the class 1B drugs, Atalol and Medron, they found that there was no morbidity benefit, and use it with caution regularly and especially long treatment. So coming to our molecular trimethoxy, this is the famous picture of the Camilla, who is the research scatter, and he was banned from the last year 2020 Beijing Olympics because he was found in an antibiotic of positive for trimethoxy. So it is already banned since 2014 in the sport purpose. So it is beneficial in heart metabolic modification. So is this situation better than metabolic agents like added to a beta blocker? So coming to the basic energy used by the heart, most of the energy is supplied by the free fatty acid metabolism by the beta oxidation, while glucose metabolism contributes the 30%. So this is the at the rest. What happens in ischemia? This glucose pathway is inhibited and free fatty acid pathways are going on, which we do not require in the ischemia. This results in the inhibition of the pyruvate dehydrogenase, more lactate and cations produced between the cell acidosis and contract dysfunction. So we need another molecule which addresses the energy issue. So we have the primary disease, which inhibits the pre-precursor coenzyme kinase and prevents the beta oxidation, and more the glucose is utilized for the ATP production. We know that the glucose ATP production by the glucose metabolism more efficient pathways, which gives more 33% of more ATP for same amount of the molecule of the O2 provided. So what are the clinical benefits of this molecule, which we have studied in a simple case study, where we found that community treatment in the stable effort angina using pembrolizine and metoprolol, a total 4 to 6 patients with a stable effort induced angina and doesn't chromatic disease. We found that this increases the exercise tolerance and time to 1 mm ST segment depression and time to onset of angina. We have another one study, choice 2 study, which was also multi-center open label study, and elderly patients 19 were included, and we found that the proportion of patients with class 1 angina increased to 6-fold, while that of class 3 angina decreased almost 4-fold. So primarily protects the ischemic myocardium by improving the microenergy utilization during the myocardial ischemia, and it directly inhibits the cell toxicity and increase the ATP, reduce the acidosis, and improve the function. So it directly benefiting survival the cardiac cell. So what are the recommendations in Indian Heart Journal? So when the angina is not controlled by the first line drug, so emerging therapies such as pembrolizine are certainly effective second line agents, and they are not reviewed by the conventional drugs. And Once daily dosing of sustained release formulation reduces the pill burden and improves the compliance. European guidelines also recommended from class 2B to class 2A to use pyrimethamine, and there is an additional benefit of ischemic glomerular restriction. This is also studied in the some trials and commission that there is improvement in LV ejection fraction, there is improvement in systolic volume. There is also clinical decrease in the BNP level, and there is an increase in the TTR ATP ratio. This is the marker of the motility in this indication. So when you add the nitrates or CCB to beta blockers, adding pyrimethamine results the maximum reduction in angina symptoms, 77% reduction. And when there is the optimal use of beta blockers, in the presence of in the full phase of beta blockers, addition of analgesic has no additional benefit. So we need another molecule which utilizes the oxygen, which is oxygen provided to maximally produce the ATP, and we see that pyrimethamine also improve the endothelial dysfunction in the chronic heart failure as an antioxidant effect. So to conclude, pyrimethamine is the preferred next anti-anginal drug for any dysfunction. In patients with PA more than 40%, evaporating indication in this patient is not justified. And in patients with the maximum beta blockage, use of analgesic won't give its desired effect as an anti-anginal drug, and using just to treat the disease is not justified. Analgesic has more side effects, and its discontinuation rates are very high in trials. Adding nicotinamide to NTG 6.4 mg BD as already patient taking may lead more other side effects like hypotension, trigger headache, and drug withdrawal. So in our patient, this is elderly patient, this is very well tolerated molecule, EF 45%, which improves the ejection fraction, and class 2 angina and dyspnea also improved in the trials. It also decreases the nitrate usage, and when provided the blood pressure 106 to 70, 178, pyrimethamine is suitable as it is free of any hemodynamic action, and we can maintain the same blood pressure and the heart rate. Thank you.
Like to ask Dr. Deepak, in this case, as the patient has a class 2 dyspnea and the LVEF is 42%, to this should not we keep ivabradine or nicorandil?
That ivabradine is also a very good choice because heart rate, but since the heart rate is already at 80, so in the guidelines it is written that if it is more than 70, then we can use ivabradine. But if we consider that it has a potent and multiple vasodilatation effects plus venodilatation effects, nicorandil, and it relieves microvascular angina, so it has pleiotropic effects. So I'll consider it to be a slightly better agent as compared to ivabradine.
To treating clinicians, all such patients who have been partly managed by interventional people. All these drugs are basically, when you read into the final details, how much angina is relieved, increasing distance to getting angina. इतने स्टेप ज़्यादा चलता है, 10 स्टेप के बदले में 15 स्टेप. This is almost something like a bridge. That is why I think a lot of money are not coming to hospital and service. Metabolic management was a very sound pharmacological method, but the clinical outcome, ask the clinicians and the patients. That point, that revascularization attempt.
So putting a stent would be better than adding medicine.
Now again, putting a stent in a stable CAD with mild ischemia, will it really be better than stents? Current says no, Orbita says no, so we don't know. That's why the case that was selected, go back.
Whereas a class 3, it would definitely benefit.
Yeah, class 3 and symptom relief. As a cardiologist, we are always feeling go back. We'll be always, yeah. So that's why deliberately we chose EF 42. But class 3 angina, yes, class 2 dyspnea. So you need to do something already on nitrates and already on full dose beta blocker, then and a post CABG. And ischemia in this patient was not much, but BPC was deliberately added to look for QT prolongation. Then ranolazine, though prolongs QT, but can improve the outcome. So yes, I mean, you have to choose drugs based on like combining nitrate with nicorandil may not be more beneficial, except what Dr. Amita showed in some of the studies from Japan. Most of them are from Japan on top of nitrates. Ivabradine, if you had LV dysfunction, this debate is straight away. If EF was 35%, he wins hands down that you get ivabradine. Ranolazine, as Ishan mentioned, you would always choose a metabolic modulator plus a venodilator. So trimetazidine or ranolazine combination is better to choose along with nitrates, or you can use nicorandil and stop nitrates and go high dose nicoram and add a metabolic modulator may help. But the case was mild ischemia, not significant enough. EF is not so low, and patient is getting VPCs, and maybe his QT is slightly borderline. Then we have data from ranolazine that it prevents sudden death. So that's why the case was a balance of everything. But if you have LV dysfunction, ivabradine. If you don't have LV dysfunction, LV is more than 40, 45, heart rate is not very high, you can rule out ivabradine. Bradycardia, rule out ivabradine. Borderline QT, risk of VPC, ranolazine comes in, and otherwise metabolic modulation. Chairpersons, if there are any more comments to add. Yeah, good question. So, yes, next slide. So, I think next slide. So we had a trial called ATPCI, which was recently done in coronary artery disease, post PCI. You cannot equate this to CABG. OD preparation was analyzed to look for event reduction. There was no benefit. So post angioplasty, acute situation. This is acute MI though. It did not. But most of the trials now have emerged for OD preparation compared to PED preparation. And the advantage that they say is the continued metabolic modulation. But again, most of the data is, as was pointed out very effectively, that it was the distance, quality life, time to ST depression. આ બધા સ્ટડીમાં શું જોઈએ છે? TMT કરો, 3 મિનિટમાં ST depression થયું, હવે દવા આપી તો હવે 7 મિનિટમાં ST depression થયું. એન્જાઇના 15 મીટરે 500 મીટરે થતું હતું, હવે 1 કિલોમીટરે થાય છે. Angina પહેલા had to make you stop. Now you can walk through with the angina. So most of the trials are like that, but mortality reduction, ivabradine if you have LV dysfunction. Otherwise, all of them do good for metabolic modulation. So that was the message. All right, thank you very much. And then we move to next session. Thank you all chairpersons. Please do collect your mementos and the kit. Your mementos and the gifts are in your kit. For the sake of time, we are avoiding giving it on stage. Thank you very much. We have our next session. So this slide, ATPCI evaluated which molecule? Next slide. I've already answered it. It's trimetazidine. And this was the trial. Next slide. Yeah, that is the ATPCI published in Lancet recently. Next slide. So we have this case of MRA. This is basically a new therapy, mineralocorticoid receptor antagonist in diabetic kidney disease. Now you if have ASCVD also. So 65-year-old diabetic, history of old anterior wall, post-PTCA, stress nuclear imaging revealed ischemia, SDS4, EF40, dyspnea class 2, on dapagliflozin, telmisartan, apart from GDMT for IHD, UACR of 280, EGFR 48, potassium 4.7, occasional VPC, preferred MRA of choice is the case. May I have these speakers and the chairpersons? Dr. Ronak Shah, Dr. Ankat Humar, Dr. Apura Parekh, Dr. Umesh Godani as chairpersons, Dr. Kashyap Bush, Dr. Ashish Saxena, Dr. Nehal Sadhu, and Dr. Arjun Satpute as moderators for the session. The speakers will be Dr. Sunil Thanvi and Dr. Jignesh Vanani. Next slide. Over to chairpersons to introduce the speakers. Go back. Back. So what we are trying to learn in this case is management of diabetic kidney disease in heart failure with reduced ejection fraction. We'll also try to learn method of starting each therapy, how to follow, and what is the evidence of newer MRA. That's the idea of learnings from this talk. Over to chairpersons. Next one.
May I now invite Dr. Sunil Thanvi sir for this presentation on this phenomenon in this scenario, whether opinion is better or not. As we all know, Sunil is a very good friend of mine and is a very senior cardiologist at the Zydus Hospital. So over to Sunil.
Yeah.
Good evening, and I think it's a very good method of whipping up, discussion and creating interest in therapy, because what is happening is so many things are available now, and we are still at bay to understand what is what and what is correct. So I think Kamal, well done with this format, and I think this is very important for people to understand what is good and what is not. My brief today is to talk about the role of MRAs in diabetic kidney, especially with respect to similar. In fact, I would have liked if Dinesh should have spoken first, because I would be speaking against supplement as such. But nevertheless, I'll start my talk. So this case is basically about a 65-year-old diabetic female patient, old anti-MI, post PCI, 3 years back, first imaging revealed mild severe ischemic of her, EF around 40, classic dyspnea, on data, 75 meeting exam, so obviously well controlled blood pressure, and apart from other deviations for ischemic habits. Her UHCR is 280, which is on the higher side, EGFR is 48, which is low, but not that low to not do anything. Her current serum potassium level is 4.7, again, borderline, still rotating VPCs and ECG. The preferred MRA of choice would be. So, to my mind, I think cenerimod is a drug which would get best in this scenario. As you can see, I've done 4 or 5 boxes. So, you have a diabetic female patient who has already undergone a PCI, ischemic heart disease with some residual ischemia. Ejection fraction 40 so that the mildly severe on DAPA, another PDMC, EGFR borderline, UHCR on the higher side. So the perfect setting, what I believe, is for this particular molecule. Why is this so? Because we know that CKD and diabetes both go hand in hand as far as cardiovascular disease is concerned. Diabetes alone is a major cardiovascular risk factor. CKD alone is a major cardiovascular risk factor. When put together, they are the worst of it. And why is that so? Because we know that there is a shared pathophysiological mechanism that link cardiovascular disease. The associated factors leading to the central nervous system activation, inflammation, endocrine dysfunction. We have the oxidative stress and dysfunction. So on and so forth will lead to various changes in thereby leading to both cardiovascular and kidney dysfunction and effect. So as you can see from this flow diagram, fibrosis is actually the primary driver of pathophysiology in several autoimmune symptoms, whether it is heart failure, liver failure, whatever disease. Actually, fibrosis causes a problem. So focusing on fibrosis as a disease mediator could potentially be modulated with RAS inhibitors, MRAs, or other novel agents in development for prevention and treatment of fibrosis within the cardiovascular then continuum. If we can do that, nothing like that. We also know that albumin level increases. It's associated with higher cardiovascular risk across all EGFR categories. Whatever the EGFR be, whether it's normal, mild to moderate, or whether it is severe reduced, albuminuria itself causes high mortality risk. So albuminuria, CKD, when you have diabetes, these are all 3 major risk factors in this particular case, which sort of tells me that this case is tackled very well. Very fragile patient. Again, increased baseline USR is strongly associated with increased risk of cardiovascular kidney outcomes. We know that when the USCR is within 30, and it is more than 1,000, this is a difference, it is nearly within 1. And similar to case for renal outcomes, when the USR is within 30 and it is more than 1,000, it is nearly, you can say, 50%. So, we need to control all these factors. We need to control the progression of CKD, we need to control the progression of fibrosis, we need to control the overall pathophysiology of this patient. So what are the triggers that lead to the severe progression path of diabetes? There are a mix of hemodynamic, metabolic, and inflammatory fibrosis, which leads to tubular damage, inflammation, glomerular sclerosis, medullary expansion, glomerular hypertrophy, ultimately kidney fibrosis and severe progression. So we need agents which work on all these areas so that the progression can be retarded. And what are they? Currently we have ACE inhibitors, ARB, diuretics, calcium channel blockers, ACE inhibitors which work at hemodynamic level, and they reduce the intravenous pressures, thereby reducing the hemodynamic damage to the kidney. We have ACE inhibitors, lipid analog, metformin, and other agents which also metabolically regulate, improve the glycemic control, and also give better outcomes as far as the kidneys are concerned. We know ACE inhibitors particularly, they are renal friendly and they help in reducing the progression of CKD in diabetic patients. But what about the third part, inflammation fibrosis? We still don't have anything to work on that. We also know that despite RAS blockade, and HSC inhibition, there is a lot of area still to be covered, a lot of resistance. Just as that alone, combination, and otherwise, we can see that there is a definite resistance risk for CKD that keeps on going on despite whatever therapy we give. So there is a scope wherein we can put some molecules, especially which can act on the phagocytes and the other parts. Therein comes in the role of overactivation. So how does this work? It works as various mechanisms. We have increased ligand-dependent MR activation by aldosterone. Why is it important? Because it correlates with CKD and early hypertension study. And we have to alone itself is a marker for future cardiovascular events, arrhythmias, so on and so forth, and also for healthcare, as you can see. Increased ligand-dependent MR activation of cortisol, again, it is quite important because it's very heart failure mortality, and there is dysregulation which leads to further worsening of CKD. There is increased ligand-dependent MR activation through RAC1 and oxidative stress, again, which can lead to worsening of CKD, heart failure, and type 2 diabetes. And of course, there is MR activation which increases in silver media. So we can somehow try and control the MR overactivation. We will be able to control a lot of these various events and thereby reduce the overall progression. How does it cause kidney and cardiovascular damage? Okay, thank you. How does it cause kidney and cardiovascular damage? Again, the MR pathway becomes overactivated with multiple mechanisms. Downstream effects being kidney damage, vascular damage, remodeling, the dysfunction, physical stiffness, mitral hypertrophy, ventricular remodeling, fibrosis, reduced coronary blood flow, system and function of the brain. So, as a cardiologist, for me, this is something very, very important. But I need to understand that MR overactivation is not something that should or can be done, but it should be done. That is what I now feel after having gone through the whole gamut of heart failure and CKD. It is also potential treatment target to address the resistance in CKD and type 2 diabetes. This is where we need to work because everything else is still there, right? So it is fentanyl which targets the MR overactivation, which may contribute to kidney and cardiovascular disease progression, patients CKD and type 2 diabetes, and thereby it blocks the MR overactivation, and therefore it reduces the albuminuria, it reduces the CKD progression. It also helps as far as the blood pressure concerned. It has a more or less neutral effect as compared to spironolactone or It's a more or less neutral effect. So heart failure patients like elderly females who are just about there hemodynamically, it could be a good drug to act. And we have a lot of animal studies which show that fibrosis in heart and kidneys are definitely prevented when the patients are given Pindrinone as compared to Epinone or even spironolactone. What is also important to understand is that it is pretty safe. The ARC study, the ARC study very clearly showed that as compared to spironolactone, as compared to epinone, the hyperkalemia that was seen was far less as compared to the other molecules. And if you look at the NT-proBNP levels with this particular molecule, again, there was a significant reduction in NT-proBNP levels when this particular molecule was given as compared to both epinone as well as spironolactone. So for me, this is a molecule which should work in this particular subgroup because elderly female, post-PCI, EF 40%, a CKD with USCR which is on the higher side, definitely I would not hesitate in adding this particular molecule. Again, you look at the emphasis HF, the result very clearly showed that patients treated with epinone had an increased risk of potassium, but not a potassium more than 6, and of hospitalized hyperkalemia or discontinued studied medication to reduce event. So this is one area which I feel that epinone again works better. Currently, it is indicated in adult patients CKD associated with type 2 diabetes to reduce the risk of sustained eGFR decline and kidney disease, cardiovascular death, non-fatal MI, and hospital heart failure. Also, what is important to understand is that it also reduces the incidence of new onset atrial fibrillation. So it is cardio-safe, renal safe, reduces albuminuria, prevents AF, reduces heart failure hospitalization, especially in patients with HFpEF, bireduced EF, where it has been studied in fidelity, and the Figaro-DKD trial, it has been shown to be beneficial. And therefore, I'll just jump the slide because these are all numbers which I think we will always find everywhere. But the cardiovascular benefit of epinone was not modified by prevalent ASCVD status, like in this particular patient. Known ASCVD, already undergone PCI, this patient would benefit more with epinone as compared to a placebo or another molecule alone. It also reduces the risk of composite kidney outcome as compared to placebo, irrespective of ASCVD history, and therefore I think for me, epinone would definitely be the molecule of choice. So if you look at the guidelines currently,
AHA 2022 recommended ACE 22 clinical trial patterns. I'll just check 2 more slides. Level 1A, ADA KDGO guidelines recommended definitely by KDGO guidelines 2022 level 2A, ADA 2023 guidelines level A recommendation for this molecule. And we talk about the pillars for reduction in diabetes complications. We have glycemic management, blood pressure management, lipid management, and agents of cardiovascular renal benefit, and which are RAS blockade, SGLT2. We know that these two are already there, still there's residual risk, and to control that, now we have Fundinone, which can definitely help, especially this particular group of patients. So 65-year-old diabetic, EF 40, GFR of 48, USR of 280, potassium of 4.7. I would not hesitate in adding Fundinone and giving the best possible benefit. So I think given the wealth of data now that we have with Fundinone, cardio-safe, renal safe, albuminuria reduction, improvement in heart failure, reduction in heart failure hospitalization, I think this is one molecule will definitely add as compared to other molecules. Only 5 key takeaways. 1, initial treatment and serum protection less than 5. Withhold treatment serum protection more than 5.5. Initial treatment EGFR is more than 25. This is something we need to understand. Fundinone reduces the risk of ESC-KD by 1/5 and reduce the risk of hospital heart failure by 1/5. This is a very important slide. Please remember it and take it home. Thank you very much.
Now I will request Dr. Jignesh Vandani to speak on eplerenone can still be a good alternative in view of LVD. Good evening to all. Sir probably may not remember me, but sir has taken my DNB final exam few months back only. And I am very thankful to Dr. Kamal Sharma and Cardiocon team to provide me this opportunity. Sir maybe arbitrarily hide the fact that patient has class 2 dyspnea on exertion, except that patient is 65 female, ischemic heart disease, diabetes, CKD, or we call it diabetic kidney disease, with LVF of 40% and with so effectively patient is of case of the heart failure with reduced ejection fraction according to newer all heart failure guidelines. So our patient managed based on the heart failure with reduced ejection fraction guideline, and there are 4 pillars everyone knows of. So elaborately, MRA is one of the pillars of the heart failure with reduced ejection fraction, and eplerenone is more specific for aldosterone blockade and therefore causes less gynecomastia, causes less vaginal bleeding, and it is already better than the spironolactone. And this is the AHA 2022 guideline heart failure. It is also suggested MRA, spironolactone, and eplerenone is recommended with careful with the EGFR more than 30 and potassium is less than 5. And one value statement, high value statement, MRA therapy provides high economic value. And these are the trials supporting the MRAs long way back, FSS in the acute MI setting and emphasis with the chronic heart failure setting, which shows that it reduces the heart failure hospitalization as well as cardiovascular death. This is the only study or only I can found in the literature. This is versus the Fundinone versus eplerenone, and this is particular study is important. This is the dose finding study for the Fundinone, but it was thus show that the Fundinone is well tolerated. It reduces the anti-proBNP level, and it has the similar to cause the hyperkalemia, not better than. And this is the inclusion criteria for the Figaro DKD and Fidelio DKD, which are 2 largest trial available with the Fundinone. And these are the one exclusion criteria. They have excluded the patients with clinical diagnosis of chronic heart failure with reduced ejection fraction and persistent symptoms with NYHA class 2 to 4. So their patient in the trial, large number of patients are
mainly NYHA1, or we can say that the asymptomatic patients with long-term diabetic and uh, chronic kidney diseases. So they have excluded. So class 1 indications. So we can say that there is no head-to-head comparison with eplerenone versus finerenone. And this is detailed analysis of the, sir has already talked about this fidelity analysis. And this has a similar experience of the hyperkalemia with both the drugs. This is with the eplerenone emphasis trial. There is 1.5 times more the hyperkalemia, and with hyperkalemia with the finerenone from fidelity analysis is almost twice. There may be permanent discontinuation was drugs was also twice than the placebo. So from my point of view, mRNA, eplerenone is still class 1A indication in symptomatic heart failure patient with reduced ejection fraction, and place for finerenone will be decided after fine arts heart failure reduced trial. Till now, we have to wait to include in the heart failure guideline. And hyperkalemia is issue is common with all mRNAs. Caution must be taken with low eGFR, and current post of the finerenone is also issue. So from my side, symptomatic patients with diabetes and diabetic kidney disease, older generation mineralocorticoid receptor antagonist eplerenone is better, and for asymptomatic patient for prevention purpose we may consider finerenone after SGLT2, GLP-1 agonist and AC inhibitor. Thank you.
I'll give a small rebuttal for debate, right? So I have a right to rebut my first speech. So I think what Dinesh said is correct. I mean, the trial did not have a huge heart failure patients, right? It decompensated heart failure. But they did have patients who were diabetes females, not symptomatic. This particular female patient is not symptomatic for heart failure as such. It's class 2. Class 2 is a very thin line. She got class 2 or class 4 very, with this market effect. So to my mind, I don't think it's a contradiction, but we cannot do that is wrong. Second is, yes, there are no large scale studies to talk about heart threat. But when we talk about heart threat and heart malady severe, definitely this is one molecule. Because all these patients, they are either, class A or class B, or type A or type B heart failure, who will be going on to be type C and type B. Right? They all have this factors on hand. They're not symptomatic, they are like type A, type B heart failure patients. But they go on to be type C, type B. Now the data says that if you use finerenone this particular group of patients, they are going to reduce their incidence of heart failure, they will reduce the incidence of progression of CKD. So I think this is one molecule which we also use as compared to other spironolactone or ethanol. Nothing against these two molecules. When it comes to capacity reduction, yes, it's not a good molecule. We cannot make if the patient with hypertensive heart failure, I will not be using it. Maybe I would rather use spironolactone, it's a better molecule. But otherwise, it is safe, it is more efficacious, there's more data coming up. It's very urgent, right? We just have experience of what? 2 trials, 3 trials, we have now. There's just so few trials that actually doing full radiographic look at finerenone. We have about 35 trials which have been done already. There are more in the peripheral towards heart failure, that's also. So I think when we look at the overall results rate across students, probably this could be a good drug that can be given. That's the mission made out, but as an option, scientific platform, others are in favor of finerenone.
The nephrologist, I will still say in this scenario because there is a significant proteinuria and reducing GFR. So apart from all these factors, CKD and particularly advanced CKD, this is already advancing CKD. So advanced CKD is a significant mortality risk factor in coronary artery disease patient. So till now with spironolactone or eplerenone, we didn't have much data like this Fidelity and Figaro trial given with finerenone. So in reduction of UACR as well as reduction in CKD progression. So from a nephro perspective, I will still prefer another thing as compared to eplerenone, the chances of, because in this patient they also send there are few BPCs. So I think hyperkalemia is still more common with eplerenone as compared to finerenone, as compared to is shown in these two trials at least. So still as a nephrologist perspective, you will prefer Fenrinon?
Sir, I am differ with you with this. Hyperkalemia is having similar incidence with all MRI. What is it? Thank you, sir. Thank you.
Thank you, Chairman and Co-Chairman. And now we'll go to the last topic, last discussion, last bout. I would like to invite our host, Dr. Kamal Sharma. We would like to invite Dr. Viraj, Dr. Subir, Dr. Dinkar, Dr. Harshad Patel, Dr. Marmik Brahmbhatt, Dr. Bhavesh Panchal, and Dr. Sunil Mehta. We'll introduce Kamal bhai. राज कपूर को कोई इंट्रोड्यूस कर सकता है? લાવવું પડશે ને સાહેબ તમે જે બી ટીમનું જે બી કહેતા હોય
Over to chairperson.
Hello. So I would like to invite respected Dr. Kamal Sharma for the topic which we have been discussing for Tapamage in the preferred drug for ATR cardio. Yeah.
Thank you very much. So this is the last bout of the day. I thought maybe I'll speak the toughest topic at the end. This has got a story to it. So this was like my nani, my maternal grandmother. She passed away at 78. She was diagnosed that time multiple myeloma, but was a borderline case. So we don't know whether it was multiple myeloma or not. After that came the expert view on ATTCR. And now I retrospectively, when I look, I feel that maybe I was missing out on ATTCR, basically trans thyroid, or maybe AL, but maybe I was missing out on amyloid cardiomyopathy. This was like 10 years back, but that's the perspective, and these are my disclaimers. So what I'm going to talk about is why it's an important. We had an oncologist on the supposed to have on the dais, but unfortunately he's not here. Because this is now cardiologist ની બધાની ટેવ હોય બધી બાજુ ઘૂસી જવાની જેમ ડાયાબિટોલોજી ઘૂસી ગયા હવે થોડું ઓન્કોલોજીમાં બી ઘૂસીએ છીએ અને these people Pfizer people tell me સાહેબ પહેલી વાર કરો છો મેં કીધું હવે છેલ્લી વાર નથી આ ઘણી વાર બીજી વાર કરશો. So this is one therapy that probably again we are entering into now there is oncocardiology now, that's also coming up very strongly, where you have echo assessments, looking at the GLS in cardiac patients getting chemotherapy. There is a separate chapter on cardio-oncology where onco patients should get a thorough cardiac evaluation and also modify their therapy by the echo assessments. And that's why it's so important that before that you should miss out on a therapy like this for a patient who's got a cardiac disorder, which can be treated by a therapy which would give longevity. So I'll be talking about these various aspects, and then probably why shall we focus firstly why every echocardiographer should know about cardiac amyloid. So it's misdiagnosed, as probably, I don't know, 10 years back there was no concept of evaluating this. There were hardly few radionuclear centers, so there is very little knowledge, misconceptions, inefficient sensitivity, perceived rarity, associated tissue biopsy risk were involved. So amyloidosis is an infiltrative restrictive cardiomyopathy, which is basically either you have two types. One is light chain amyloid and other is transthyretin amyloid. The breakthrough that has happened is now the transthyretin amyloid can be treated with therapies like tafamidis and give longevity. If my maternal grandmother had taken this, maybe she would have been here for another 2 years before she died. So what is a transthyretin amyloid? Basically, it's mainly produced in liver and spore subunit, which is dissociate, and it then aggregates and forms what is a amyloid fibrin formation, which deposits in the heart and impairs its functionality. It can be either a wild type, which is means the first way, or it can be a mutant type. So there are two types of it, and to make it simple rather than complex, its prevalence in patients with reduced ejection, preserved ejection fraction heart failure, it accounts to almost 1/7 or 1/5 of the patient. That is 7 to 13% of restrictive cardiomyopathy is this. And the mortality is because of the progressive heart failure, and survival after the diagnosis is 3 to 5 years in West. In our countries, it may be as little as 6 months. Median survival for hereditary is 26 to 62 months, and wild type it is 43 to 67 months from diagnosis. Now, it has a varied presentation. You have preserved ejection fraction patient who's come with either conduction block. So lot of pacemakers that you're putting without, you think, echo ma LVH che and a complete heart block che. And actually what you've missed out, you put a pacemaker and she dies of heart failure. What probably you missed out is a conduction abnormality in a patient of HFpEF because of amyloid. Also aortic stenosis, TAVI kari didu, AVR kar didu, and patient died. Why? Probably the patient had ATR amyloid. So it's the finding the right lead and finding out who should get it. So this is very simple. I'm going to make warning signs very simple. Any heart failure in a patient who's more than 65, or aortic stenosis more than 65, or hypotension or normotensive in a patient who was previously hypertensive suddenly gets hypotension. A lot of times you have patients who have hypertension. Tame antihypertensive leta tha dose and 2 દિવસ પછી સાહેબ ચક્કર બહુ હતા and BP is now low. Or you have, if you do imaging, etc., subendocardial or LGE on cardiac MR, or you have apical sparing with longitudinal strain on echocardiography, or there is decreased QRS to mass ratio, pseudo Q wave, also we call as pseudo infarction pattern, or AV conduction block with LV thickness more than 12, and any one of this is good enough to make a suspicion. So once you have a patient with signs and symptoms of heart failure and echo ma simple કે ECG માં લાગે MI enteroceptal થઈ ગયું છે અને echo જુઓ તો hypertrophied EF 65%. Very simple for an echocardiographer to suspect a cardiac amyloid. Speckled appearance is secondary, but if you see ECG showing MI, echo not showing MI, that's very strong suspicion of a patient of amyloid. So scintigraphy grade you have to look at. If the suspicion persists, you can do cardiac MR. So best way is આપણા ત્યાં શું કરી શકીએ? SPECT scan. Just do a radionuclear scan. Non-invasive, get a SPECT scan. And when you do SPECT scan, if there is scintigrade is more than 3 to 4, that means you are dealing with a cardiac amyloid. Which is if it's more than grade 2 or 3. એમાં simple હોય છે. Heartની density SPECT માં બોનની density કરતા વધારે હોય, that means there is selective uptake. Technetium pyrophosphate scan, which is easily available all across Gujarat, and it can be done in a patient who's suspected for it. And you of course then can do a hematologic test, which can be AL amyloid mate, and then the diagnosis is different. So you have a patient which have multiple healthcare professionals have to play a role. You'll have neurologist who will pick up a patient from neuropathy, orthopedic from the standard protocol for testing biopsy tissues, hematologist, cardiologist, nuclear guy, gastro, genetic, primary care physician, healthcare professional. So basically what this therapy, tafamidis, does, જે tetramer બને છે એને એ unstable કરી દે. So then it is easily circulating naturally through the bloodstream, and this free therapy, the tafamidis free acid, which is bioequivalent of 80 milligram tafamidis, is approved therapy now for ATTR cardiac amyloidosis. So it's the only approved treatment with this targeting TTR destabilization and prevents the progress and preserves the natural function of TTR. So tafamidis is the only therapy which is effectively treating ATTR amyloidosis, cardiac amyloidosis in randomized trial. So this is a trial called ATTR ACT trial, where they gave patients tafamidis 80 or 20 or placebo, and then they followed it up in the long term with the LTE, and they continued this, and they randomized to 2:1 for 80:20, and then they were, of course, once the outcomes were there, protocol amendment was done, and open label free acid 61 milligram QID was continued. What did it show? It showed that the survival was more in patients given tafamidis. 71% survival at 30 months compared to just 57% in those who were not given this therapy. So average, again, hospitalization also is only 0.3 versus 0.46. So what the ATTR CAG showed, that functional quality improves. She is able to walk 76 meters more. The quality life improves by 14 points. And the results also for NT-proBNP, which is a marker for heart failure with preserved ejection fraction, also improves significantly. 80 milligrams by 45% and 20 is 23%. The placebo, when you just give therapy for preserved ejection fraction, like the dapagliflozin or the ARNI, which is the standard care, will be only 12%. So this is a therapy which is very safe. No safety concerns were identified in the study. Adverse events remain similar to the placebo, and this has been a follow-up of like 58 months, which is almost like 5 years. And the post-hoc analysis shows that the all-cause mortality by taking tafamidis versus those initiated on placebo has been now followed up even beyond 72 months. So the post-hoc analysis, 5-year all-cause mortality is reduced by 41%. So this is one therapy which has shown significant improvement in survival at 5 years, with 53% preliminary survival tafamidis versus just 32 on placebo arm. And there is 44% relative risk reduction for all-cause mortality, and all-cause patients with ATCR with baseline functional class 3 at 60 months is reduced by 35%. Also, it's irrespective whether it's a wild type or a the mutant type, both the groups will work. So, or you don't need to be distinctive of બેમાંથી કયું ATTR-CM છે. Irrespective, you just diagnose ATTR-CM and you can do. So basically, transthyretin amyloid cardiomyopathy is misdiagnosed, underdiagnosed. It's an orphan disease. Orphan disease, એનું કોઈ નથી, કોઈ શોધતું નથી, કોઈ treat કરતું નથી, અને elderlyમાં કોઈને પડી નથી. That's the problem. But then when I look at it from a personal story, I think if I had to pay whatever money it took, and if it was going to give 3, 4, 5 years more for my grandmother to live, I should have probably, if this therapy had been available, would have been greater benefit to her. So it's demonstrated overall mortality and hospitalization rate compared to placebo. Patient quality and functional biomarkers improve. Post-hoc analysis has demonstrated 5-year survival to be much better. With patients in continuous tafamidis cohort show greater improvement with baseline class 1 or 2 or compared to 3. And patients with continuous cohort have similar survival rate for both the genotypes, and it's a well-tolerated therapy. The monitoring, as I said, you need to look at the echo and the ECG, and once you have done it, the wall thickness will also improve, systolic function will improve, so would diastolic function, and no onset of aneurysm is what you need to monitor in elderly who are more likely to develop atrial fibrillation and AV block. Thank you very much for patient hearing for the talk on tafamidis. Thank you. So cost of the therapy, I think is 1.5 lakh rupees, 1.2 lakh rupees, and it is to be continued for lifelong. So 5 years, no, per shot for 1 month. So it's costly, but then it's worth it if you live. So that's why I say it's an orphan disease difficult to diagnose, disease difficult to treat, no support socially, emotionally, financially. There is no support system for it, but I think Pfizer is supporting in terms of getting the genetic profile done for free, and they also support for the follow-up assessment and nuclear scans in Gujarat. So if you have suspicion for a patient with amyloid, they get a spec done, and I think they waive off the charges if the patient, they pay the charges of diagnostics if the patient goes through the therapy. That way, I think there is some support structure emerging. It's reimbursable, I think, from Mediclaim point of view. So if you're hospitalizing, if the patient has Mediclaim, it can be covered. But then, દર મહિનાના 1.25 લાખ કેટલા મહિના reimbursement policy કેટલી જોઈએ is be a question, but I'm sure this will come into consideration because this is a problem of oncology. Oncology માં બી આ થઈ રહ્યું છે કે chemotherapies are evolving on outpatient. અને reimbursement issues are coming even in oncology. પેલા કે દાખલ થાઓ તો મેડિક્લેમ મળે. હવે ગોળી ખવડાવો તો મેડિક્લેમ ના મળે અને બધી ગોળીઓ થઈ ગઈ. You have CML, you want to treat, you give dafasitinib or timitinib or whatever, and patient doesn't have to get admitted. So then again there is an issue કે તમે ટેબ્લેટ reimburse તો again first આપણે જે બધા કરીએ જે એકવાર એડમિટ થાય પ્રિસ્ક્રાઇબ કરે 3 મહિના reimbursement થાય ફોલો અપ માટે ડાયગ્નોઝ માટે મેરો માટે દાખલ થાય મેરો વખતે ફરી ઇન્ડોર લખાય ફરી પ્રિસ્ક્રાઇબ થાય so that keeps on happening. So maybe there must be some way of looking into the whole aspect, but I think if there is one patient or zero patient from Gujarat so far. Gujarat. Okay, so there are already 5 patients from Gujarat because when I was getting part of the program for the screening, I screened 5 patients. 5 માં એક AL આવ્યું, ATTR ના આવ્યું. એક માં 90 વર્ષના માજી હતા તો પેલાને સ્કેન જ નતું કરાવવું કે હવે માજીને શું કરવું થઈ ગયું હવે સાહેબ જે હશે તે. એક patient already was on thalidomide and all that, and that she was doing better. Thalidomide is given for amyloid kidney. So she was doing good. So Saga and oncologist said કે કઈ જરૂર નથી હવે સારું તો છે 5 વર્ષ તો થઈ ગયા thalidomide પર ચાલુ રાખો. So that patient was lost. So I have not initiated on any patient honestly speaking, but I have screened 5 patients. 2 were negative for the scan, so did not turn out. But I'm glad to hear that 5 patients are there already on tafamidis in Gujarat, and I think Mumbai has probably the largest number of. Bangalore has highest number. They have a good cardio oncology team which looks into the whole aspect, and that's where the whole therapy is initiated. So thank you very much, and we can have the second aspect of the talk from Dr. Raj.
Kamalbhai, thank you very much for your excellent academic feast of today. Today is Gagar Ma Sagar am kahiye to. Now I invite Dr. Raj Raval for the talk.
Kindly introduce it, Dr. Raj.
Good evening. Yeah, good evening, everyone. It's a wonderful feast of knowledge today. Thanks to Kamal Sharma and whole team. We have 3 cheers for them from all audience. Well, I am a critical care specialist, and I was called because I am dealing more with the hospice therapy routinely. So he told me that just discuss about the hospice therapy. And as a critical care specialist, I am very optimum. But since my job is to counter him, so I try my best to counter him. So basically in ATTR CM, like in cardiomyopathy with amyloidosis, the commonest is diastolic heart failure. And what we discuss is this, the cost effectiveness of tafamidis therapy. So this is the interesting studies. I think this is the biggest study available. So the cost of therapy is $225,000 per month in US, and they did studies that they found that with the quality adjusted life year gained, that is 1.79, and the cost is rising to $880,000 per month. And they found that the ratio with the cost effectiveness is 0% in 10,000 probabilistic simulations. So there has to be a 92.6% reduction is required in cost. There are so many arguments in US with the Medicare, and even with the reduction, they come with a $2,000 per month. That is also quite high. So with that, the quality assured life, the lifespan increases 1.29 or 1.5 times. So that is hardly 13 months. And that is also with this tafamidis is not a magic pill. The patient has so many comorbidities. So all other medicine, all other therapy, all other hospitalization, all other complications is getting added. So we really have to think before prescribing this medicine. So this is from a physician that it is anxiety provoking. If nobody believes that comes to my clinic where I have to sit with patients who are worried how they are going to get it. So you have to sit with and visit, because patient is already sick and you are talking with the financial aspects and about disease. It is really very, very anxiety provoking. And
most of the patients are old age, right? This disease is of a old age. So to spend $250,000 every year on patients who are 80 years of age. So not to be disrespectful to them, but it is not sustainable. See. So this is, I think, the available in Indian market at 1,20,000 rupees. So what I feel is, this is the famous story like Birbal ni khichdi. You feel like that, oh, it is too far. It's too far. So then I believe that we have to focus more on hospice therapy, because that is more rational, more optimum, and we need to focus on that. I think maybe we are missing the current Indian data, but with a good hospice therapy, at least you can sustain for a longer time. So we know that diastolic heart failure is with a normal left ventricular systolic function in absence of cardiac valvular disease. The syndrome of heart failure is DHF. Now these are the most common conditions, three conditions: the presence of signs and symptoms of heart failure with a normal ejection fraction, and presence of increased diastolic pressure or impaired filling caused by delayed isovolumic relaxation or elevated stiffness. The pathophysiology, all we know that there is a ventricle, there's a thick wall with a small cavity. So there is an increased left ventricular mass versus volume ratio. When the left ventricular becomes stiff, it relaxes slowly in early diastole. So eventually, there is a resistance in a filling pressure in the late diastole. So your diastolic pressure got elevated. Now these are the typical diagnostic criteria. I am just focusing on that. The axial dyspnea, orthopnea, gallop sounds, lung crepitations, and pulmoedema with a normal or mildly reduced ventricular systolic function, and evidence of abnormal left ventricular relaxation, filling, diastolic distensibility, and diastolic stiffness. Now there are 4 treatment goals that has been advocated: the reduction of central blood volume by means of diuretics, improvement of LV relaxation by means of calcium channel blocker or AC inhibitors, regression of LV hypertrophy by means of AC inhibitors and ARB that we use commonly since years, maintenance of arterial contraction and control of heart rate by means of beta blocker and antiarrhythmics. So this is a treatment algorithms for confirmed ATTR amyloidosis. Heart failure, we know that we are treating with all this stuff. This is modified agents that already Kamal has discussed. The tafamidis is a approved drug. Another drug for cardiomyopathy and neuropathy, that is inotersen and patisiran. That is even cost is double than tafamidis. It is still coming, so the cost is double than tafamidis. And for arrhythmias, you can give beta blockers, you can give antiarrhythmics, you can give NOACs, you can give warfarin antagonist, all this medical therapy. And for the device with a heart block, you can have a permanent pacemaker, ICD and CRT in some patients. Practical points in ATTR-CM, that the goal-directed medical therapy is very, very poorly tolerated. All these drugs, as Kamal has told, that they can produce hypotension. Beta blocker may worsen heart failure symptoms. The benefit of ICD has not been studied very well in randomized control trial. This is modified therapy, which is already we have discussed and which is under a great discussion, like TTR silencers, TTR stabilizers, and TTR disruptors. As we have discussed, the inotersons and patisirans, they are very, very costly drugs that will not improve the disease. It just slowing the progress. It is just slowing the progress. Now we discuss about the hospice therapy. When we have to consider the hospice therapy, so out of these criteria, 1 and 2 must be present, and 3 maybe in a supportive. So patient is already optimally treated with diuretics and vasodilators, which may include AC inhibitors or combination of hydrolyzin and nitrates. If patient has hypokalemia, so you can try only with the nitrates or hydrolyzin. So that has to be documented on medical records.
patient having angina at rest and that is resistant to standard nitrate therapy, or patient is not a candidate for invasive procedures. Patient has significant symptoms of recurrent congestive heart failure at rest and it is classified by NYHA class 4. So unable to carry any physical activity without symptoms. Symptoms are present even at rest, or if any physical activity is undertaken, symptoms are increased. And third criteria is there is a resistance SPT or VT, history of cardiac arrest, history of unexplained syncope, embolic phenomena, concomitant HIV disease, or ejection fraction is decreasing. Now these are the treatment guidelines, like you have to address the aortic stenosis, thromboembolism we have discussed, conduction disorders, heart failures, atrial fibrillation, and ventricular arrhythmias. And these are the supportive measures. So there is a great modality of treatment is available in a hospice. If we keep tafamidis and the hi-fi drugs aside. And these are the supportive measures that we are commonly using, like sildenafil, neprisilin inhibitors that is available, ivabradine, iron supplements, renalizine, mitochondrial enhancements, statins, serelaxin, that is endothelial redox balance restoration. Paraxylase, that is not available, but these are the supportive measures which are available. So what I mean to say is, whenever you are addressing the disease, you have to address it as a whole, not like a one drug which is a magic bullet and it will give and it works like a patient becomes Superman. So it's not like that. So hospice arise, I think we have to be more rational and more optimum. Thank you very much.
Yeah, so well, very well defended, Dr. Raj. I mean, I must compliment you because he's very smart. He asked me to, sir, put slides to bhejo. I send him the SGLT2 ka data of deliver trial, SGLT2. He talk about the price of this thing. Now the price counterpart is, પહેલી વાત, મને થાય તો શું અને મારે નાનીને થાય તો શું? મને થાય તો મારો તો 10 લાખ ઉપરનો દર મહિનાનો મેડિક્લેમ છે. હું 3 વાર દાખલ થઈ જઈશ અને મને કવર થઈ જશે. મને કોસ્ટ નડતી નથી. મારા નાનીને થાય તો શું? એમનો મેડિક્લેમ નહોતો. તો મને વાંધો નથી. I will spend for her, if she live 3 more years, I will spend 1 lakh rupees per month for my grandmother to live if I can afford it. So which fortunately now I can. Then if the therapy was not available, so there was no question. But what was, again, he himself showed in his slide, okay, if you do this, this happens if you do this. So he is already defended me. SGLT ad આપો તો હાઇપોટેન્શન થાય, આર ની આપો તો હાઇપોટેન્શન થાય, પેલી ટોલરેટ નથી થતી, પેલાથી ડિસ્નિયા વધી જાય છે, પેલાથી હાઇપોટેન્શન. So other hospice is not working. So hospice is like, wait till she dies. So that I'm not ready to do and not ready to accept as a man of a science and as a fighter. I will fight till the last nail for me, for my patients, for my relatives, and for each and every individual, like a cardiologist, who keep on doing massage even if the patient is arrested on table. So I will not I'm not letting a cardiac arrest patient go. This is an oral pill which I would surely prescribe, irrespective of the cost. There are ways to do it of managing the cost, which I already told you: admit, cover in mediclaim, pay from the pocket, get, and there are support measures. So sam dam dand bhed. There are ways. તમે પેશન્ટને કહો કે આ એક દવા છે, તું 3 વર્ષ વધારે જીવીશ, 10 લાખ રૂપિયા વર્ષે ખર્ચે. You have to give that choice. Will you live 3 more years with 10 lakh rupees a month? If the patient can afford, get reimbursed, get covered, I think this therapy has to be considered. See, you are a cardiologist, so your family members, they can afford everything. See, so we wish that our relative will not get such a bad disease. But see, overall economical condition, if you look, this is definitely it's a costly drug. So we have to definitely request to them, rather than we fight. We can request them to reduce the cost. So that can do. See, we can give a Nobel Prize to Dr. Kelly, who has invented this. So that we can do. We can very well appreciate the research efforts by Pfizer
but we can request them to reduce the cost. I think that they can do. So that is the thing. And again, hospice therapy, again, see, it is optimization of medicine. It is optimization of medicine. So the hypertension, then you have to adjust the drug, and so it is a continuous effort, right? So that we can do. So just it's just a debate, but otherwise it's a wonderful drug, and we should appreciate any research, though it has it just increase the outcome by 0.1%. So that's good. Thank you.
Hello. Recently, actually, I did 2 patients in our ICU as we are dealing in ICU type of patients. After having this lecture, I recall that there were 2 patients. One was a lady who was around 65 to 60 years old, and was an uncle who was also around 70 years old. The important point was they were first time diagnosed as having aortic stenosis presented with atrial fibrillation and CCF. Was managed conservatively, but we had no clue that how it occurred. What was the cause of that? They were a well-to-do family, but actually when we had not any further, so we did not advise to go for further scanning and further any diagnosis. And also the same thing, when the age is there, we definitely go for the conservative treatment. But if I would have known that this might be a case of amyloidosis and we can go for further scan, we would have advised him, and definitely they would have go for it. And this is a subjective matter. If my grandmother is there, I am ready to pay for 1 lakh rupees, 2 lakh rupees for 2 years or 3 years, even if there is no guarantee. So there are so many treatments are there which were costly before 2 to 3 years, before 4 years, and after a repeated diagnosis, after awareness, now more and more patients, more and more families are going for the treatment, like pacemaker and all these things. So I think this needs awareness in routine doctors who are working in ICU, who are working as in a OPD, except cardiologists. So this needs an awareness that which type of disease, this type of complication are there, which needs diagnosis, and then we should let the decision on to the families, so if they want to go for that or not. So that was a very informative lecture for us. Thank you very much.
Got one question, that if a patient who's having congestive heart failure, we are initiating the screening for. In the screening, she hasn't developed yet. So how frequent that screening has to be done?
Yeah, it's a good question. So a lot of times, if you have a patient who's having a dilated cardiomyopathy picture, it may be end result of an infiltrative amyloid as a burnout presenting with DCM. And this is also the subgroup where you will benefit if you just had cardiomyopathy without any peripheral involvement like neuropathy, etc. Other thing is that earlier you start, better it is. So that's why the question becomes important, that the more benefit is derived in class 1, 2 compared to 3, though both of them are statistically significant, but 1, 2 will have more survival, bigger win ratio compared to class 3 and 4. So early diagnosis is very important. So how often to do? I think the guidelines are very clear. In asymptomatic restrictive cardiomyopathy, confirmed pakka case, you will have to do serially. Asymptomatic, no cardiomyopathy, you will have to probably screen more than once. Beyond a year or so, if unless they get symptoms, or you have some other suspicion, like somebody has developed now neuropathy, or somebody has now started getting a aortic stenosis murmur, or somebody who's got ECG now, QRS complexes have started becoming smaller. So, and you think the patient is asymptomatic and patient has NT-proBNP rising and troponins normal. So that's when you would suspect and do an echo. So serial echo may not have much value, but yes, your suspicion, the whole idea of this debate was, they were like, sir, tame amaru eklu ek lecture leso, me kedu nahi lo. we'll have to keep it in debate format so that we can justify why the cost is not only a consideration, but we also want to enlighten about awareness about occurrence of this disease, which is not diagnosed. As I said, I was not aware 10 years back. I don't know whether my grandmother had, my nanny had amyloid, or was she suffering from something else, but she had hypertrophy. She had poor RQRS complexes. She had diastolic dysfunction. She was incidentally diagnosed as multiple myeloma. She was treated for multiple myeloma. She started improving. Suddenly she had renal deterioration. Then she had neuropathy. Maybe she was dealing with an amyloid. But this was 10 years back. This molecule was not there. We were not aware to evaluate. We would only think of amyloid as a one thing, pseudo infarction pattern, that's all. So that way, yes.
And I think Dr. Bhagyesh has rightly said that the awareness is very important. See, after that study, what I have shown, in the US, there is the increased screening, and they found that there is 13% increase in a patient in a diagnosis. So that means so many people are just left undiagnosed. So I think that awareness is very, very important. There's a practical point that at least we have to be aware about this, and we have to identify and screen that patient properly. Thank you very much. Thank you.
Thank you, all chairpersons and moderators. For the session, the question was that ATTR-CM, which type of amyloid? ATTR wild and the variant types were used in the tafamidis. Next. So thank you very much. That brings us to the end. Next to the scientific session, but now we have the entertainment section. So over to Jayesh Bhai, and we'll also have gala dinner happening. Jayesh Bhai. Acha, come. Huge crowd. Can we stop the transmission now?
Today, actually, what
The
has
transmission
happened,
needs
all-
to stop online. Online transmission has to
So
stop.
many cardiologists have participated today in today's singing. I think we can start. कश्यप तार्किक शुरू करिए.
જયેશભાઈના માનમાં મારે ભુજ પહોંચવાનું છે એટલે હાલરડા સંબંધ જે ઘણા બધા સંગીતકારો છે અને ગાયક કલાકારો છે તો લેટ અસ સ્ટાર્ટ વિથ વન વેરી સ્મોલ હાલરડા ઓફ મુકેશ